Good afternoon, all our esteemed faculty members for this session on the second day of the fourth annual conference of the Indian Myeloma Congress 2021. And all the participants also a very warm welcome to this session. So we will have the scientific session followed by oral presentations of the best papers. And then we don't have an inaugural ceremony because of the COVID pandemic. And then we'll have the corporate symposium. And then from 8 o'clock at night, we'll have the plenary sessions. So in this first scientific session, which is management of multiple myeloma in low middle income countries, we have Dr. Tufan Kanti Dulai from Kolkata as one of the chairpersons. He is professor and head Department of Hematology at the NRS Medical College and Hospital, very active in conducting hematology CMEs and symposias. We all know him very well. And our second chairperson is Dr. Bahusahib Bagal from Mumbai. He's a professor and consultant in medical oncology and bone marrow transplantation at the Tata Memorial Center, Mumbai. So over to both the chairpersons for this session on management of multiple myeloma in low middle income countries. Dr. Tufan and Dr. Bagal.
Yes, ma'am. So, thank you, Sonia ma'am, for kind introduction, and thank you, the organizing committee, for giving us the opportunity. So, the first session, the today's session is the management of the multiple myeloma in the low middle income countries. So, in this session, the first topic will be on the multiple myeloma improving outcome in the resource limited setting. So, this is a very interesting topic in the Indian perspective. And the today's speaker is none other than the Professor Pankaj Malhotra. He is the Professor of Clinical Hematology, in charge Internal Medicine, Department of Internal Medicine, Postgraduate Institute of Education and Research. So over to Dr. Pankaj, please.
Thank you, Dr. Dolai and Dr. Bhausab. So the first talk is multiple myeloma, improving outcomes in resource limited settings or low and middle income countries. I hope my slides are visible and I'm audible.
Yes, sir.
Yes, sir.
Okay, thank you. So first of all, the first slide I would show about the distribution of multiple myeloma in India, and this is an epidemiological study which is done on the population-based cancer registry. So all multiple myeloma cases which was diagnosed during 2012 to 14 and 27 population-based cancer registries. So this was done by Dr. Kaustubh Bora of ICMR Assam division. So what this study found was that the overall crude ratio of multiple myeloma in India was 1.27 per 100,000 in men and 0.95 in women. The other important thing it found was that the most cases belong to 60 to 69 years age bracket. So now this is, opposite to what we believe that the younger, that we see a lot of young patients with multiple myeloma in 40 years and 45 years. And we generally we have an impression that it is the, in India, probably the young patients are young myeloma patients we see more commonly, and it probably it is common in young patient, but from the population based cancer registries this is not so. So maybe this elderly population does not come to the clinic. The other interesting thing in this paper was that the incidence of myeloma was highest in southern and northern zones and least in northeast. So Dr. Kaustubh Bora recently did analyze on these population-based cancer registries further. And what he has found is that two states, Punjab and Kerala, actually have the highest incidence of multiple myeloma. And in Delhi, in Delhi, the highest incidence was in women. So although he could not participate in this conference because his marriage is fixed for next week, but these were the findings he shared, and he's writing the manuscript on that and is likely to submit. So so this was little bit about the myeloma epidemiology in India. Now, when we consider the management in resource limited settings, the first thing is we need to know the challenges. Once we know the challenges, then we can find out the solutions. So these challenges in treatment of multiple myeloma can be patient related or physician related, disease per se related, and some miscellaneous challenges. If we talk of patient related challenges, I think the most important thing which we see in the OPD is the financial. The first thing actually, whenever myeloma, we are suspecting myeloma or we are diagnosing myeloma, I think the first thing we ask is आपका reimbursement है, reimbursement नहीं है, आपके finances कहाँ से आएंगे? And based on that, actually we do perform many tests like MRI, PET, CT scan or other thing. This paper is looking at the clinical profile of multiple myeloma in South India, and this is from Kidwai. Not Kidwai, this is from the MES Medical College, Kerala. So this also mentioned about the same thing, that the use of bortezomib is limited in our center because of the financial burden and cost factor. And we are unable to do the serum free light chain assay because of the finances. So this paper, I'm just showing that this is a kind of experience of all of us that the first thing we face is the financial problem of the patients, and that's why many times we are not able to adhere to the uniform response criteria or management guidelines which are given by IMWG group. This paper is from our center looking at the cost of treatment of multiple myeloma in public sector tertiary care hospital. And for transplant, it was approximately 4 lakhs. And for conventional chemotherapy, it was something like 62,000 or so. Although in the private sector, this would be obviously a little bit high. Whereas if you look at the cost of transplant in a corporate hospital, this is from BL Kapoor. The cost of auto transplant was something like 12,500 US dollar, which is double than what you see in a government sector. So the cost is a major factor when you are considering the challenges of patient-related challenges. The other is, we know that literacy, if the patient is educated, then it is easy for us to explain to him all the things. The third thing is the delayed presentation of patients. We know all our patients, in spite of symptoms, they go to either it is not diagnosed or they go to various other specialities before coming to ours. Then it is the non-compliance. Even if you tell the patient that this treatment is to be continued for this much period of time, many times once the patients feel better, they leave the treatment, or sometimes they abandon the treatment because of many reasons. And many times the patients do not have a family support. So if there is nobody to bring the patient to the hospital, even then that may be cause of a poor outcome in these patients. Then many patients have comorbid conditions. There is a high prevalence of malnutrition. Then we also have tropical infections like tuberculosis, many viral infections which are seen in our setup. Then we come to the disease related challenges. As I already mentioned, the advanced stage at presentation, young age, at least in the clinic, we see that the biological behavior of the disease may be also a little different in our setup. This paper is again from our center looking at adolescent and young adolescent myeloma over a period of 5 years. So it was something like 10% in our cohort of 415 patients over a period of, I think this was 5 years. And the majority had the high risk disease, and 20% patients were transplanted. So young patient, the transplant rate should be something like more than 70 or 80%, but only 20% could be transplanted. And majority of the patient had high risk disease. So these were the conclusion of our research on adolescent and young myeloma patients. Then this paper again from our center looking at plasma cell leukemia in northern India. And the contrasting feature was that the flow cytometric immunophenotyping of our cohort revealed altered expression of CD138, CD56, and CD20. So this is different than in the West. So we need to understand the differences of our myeloma patients as compared to the West. We really do not know what is the reason for that, but what we have to understand is that there are some differences. Then this is from Kidwai, myeloma experience of an institute in limited resource setting. And they saw that, in all the ISS staging system, the median survival was almost half of what you see in the West. So even though in the clinic, we give the Western data, Western figures on ISS stage 1, 2, and 3, but practically the rates are almost 50% of what you see in the West. Then the other difference is maybe the prevalence of peripheral neuropathy in our population at the time of initial diagnosis. This is another study from our center. So something like 62% of patients had evidence of peripheral neuropathy, and these are treatment naive patient. So so again, that may be little different what you see in the West. And almost 50% of patients had creatinine more than 2 milligram in our population. So again, as opposed to the West, where only 25 to 30% patients have renal insufficiency at the time of presentation. Then another paper from our center looking at the impact of relative melphalan pharmacokinetics and pharmacogenetics on outcome of post-auto transplant for myeloma. And what you see is that at the standard dose of 200 milligram per meter square, the incidence of diarrhea, cumulative GI toxicity, and infections were quite high in frail patients, if you take the definition of IMWG. So based on that, we actually propose that if a patient is frail, then you can reduce the dose to 140 milligram per meter square of melphalan. This is another paper from our center looking at the myelomatous pleural effusion. So we actually gave a algorithm that if any myeloma patient present with pleural effusion, so it may not be only related to myeloma. We do have many infections. So all infusions are not myeloma related, and you have to rule out tuberculosis and many other infections in our setup. Then the third challenge is physician related. We know that many times the diagnosis is delayed. Many times we see patients are following up in orthopedics OPD or in the nephrology OPD, and only after few months the diagnosis of myeloma is made. Many times the physician who is looking after myeloma patient, the workup is incomplete, and so is the risk stratification. Sometimes there is a poor adherence to protocol and suboptimal supportive care, and this is because there is people with expertise are less in number. Then obviously many times we feel problem in availability of drug. Then the protocol actually varies from different centers. Patient physician ratio is also a problem. Patient nurses ratio is also a problem. And then many times, our intelligent and expert people actually leave the country and go to the Western countries. So for example, this patient had a morphology which was looking like a lymphocyte like, but it was a plasma cell myeloma. So unless you have an expertise, you cannot diagnose the same. So clinical profile of myeloma in southern India, again, the limitations of the physician. If the patient is not able to afford, so you are unable to do the free light chain assay. Then miscellaneous challenges are country-specific healthcare expenditure, healthcare priorities, infrastructure, drug availability, and treatment availability in tier 2 and tier 2 cities. Then environment related, we know we have a dusty environment, and many times patients develop infections not only because of the dusty environment, but also the drinking water and food. Then obviously economic growth, industrialization, and increase in the burden of cancer overall, it is happening. This paper is from CMC Vellore looking at access to hematopoietic cell transplantation, and this was basically on thalassemia, but basically this was trying to say that the kind of even though we have 100 centers now, but even then these centers are too lower in number to take care of all patients of myeloma. But if the patients undergo transplant, the TRM in the West is less than 2%, but here in our setup, it varies from 2% to 7% at different centers, though the overall survival is good if this patient undergo transplant. Then little bit about the performance of India's national publicly funded health insurance scheme, PMJ. So even though, it is providing care to the patient, but it has not been able to improve the access or financial protection. This study was done in the state of Chhattisgarh. The other thing is looking at the availability of essential medicine. This study was done on ALL patients in New Delhi. And what they found was that according to WHO, the availability target is 80%, but even in the capital city of India, the availability was 70%. So what to talk about the tier 2 and tier 3 cities?
Dr. Pankaj, you have 2 minutes left.
Okay, so these are the challenges, and all these challenges are related with each other. Now, coming to the solutions. So when NASA began to launch the astronauts into space, they found that the pens would not work at zero gravity, and they spent almost $12 million. And what did the Russian do? They used a pencil. So we need to find a simple solution to that. So first is the chemotherapy in developing country is less better. Maybe yes, because these patients come at an advanced stage, so we cannot follow all those. We need to have a twinning program with centers of excellence and enrollment in trials. The cost of medication, we are fortunate that we have a lot of generics which are available and follow most of the standard protocols. We have many center schemes also. So both generic as well as innovator molecules are the same. So this last was about the melphalan, and this paper is about the pomalidomide. And then we have guidelines from the Indian Myeloma Academic Group to be followed. So few of the possible solutions are creation of manpower, training of general physician and radiotherapist, and trying to follow the uniform recommendations. Few management tips which we can follow even resource constraints is that the triple therapy is better than 2 drugs therapy, continuous therapy than fixed duration therapy. Try to use the novel agents, weekly bortezomib rather than twice weekly. Use of bortezomib if you find the cytogenetics as 414, and for renal failure patients. And if it is 17p, you can use pomalidomide upfront. Age and performance status are important prognostic factor, and use zoledronic acid monthly, and continuous refining, updating knowledge, and thus therapy. So this is a vicious cycle, in our patients, from poverty, delayed diagnosis, advanced disease, increased use of healthcare resources, increased mortality, and less spending on healthcare structure. So finally, coming to conclusion, the management of myeloma poses unique challenges in resource-constrained setting. The challenges are mostly related to finances, delayed presentation and diagnosis, and availability of treatment. However, we are fortunate that most novel anti-myeloma drugs are available in generic form and easily available. And the challenges should be perceived as opportunities for research, as the large population of world is still in low and middle income countries. And collective and focus effort like this conference and image would probably help improve the management of myeloma patients in India. With that, I thank you very much for your kind attention. I would be happy to take the questions.
Thank you, Dr. Pankaj for the excellent deliberation. So now we go to the couple of questions. Any question is there, Dr. Bhavsar?
I don't see any question in the chat box. I would like to ask one question to Pankaj, sir. Sir, you said our patient tend to present in advanced stage, and you also said that many patients have higher number of patients have renal dysfunction, etc. So, and you alluded to the difference in your preference for triplet versus doublet. So,
Yeah.
what once patient comes to us, that is the point where we can help him and we can treat him better. So, what are your recommendations? How our management should be differing from Western countries?
So obviously as I said before, the first thing we always ask is about the finances of the patients. So when we are discussing about the management of a patient, what we have to discuss is that it is a continuous management of myeloma. So it is not that we say ki, if the patient says that he can afford, let's say, 10,000 rupees for the next 1 year, then we should not start with bortezomib based therapy. Even let's say the patient has renal failure. What we can do is, we know from the available information that triplet is better than 2 drugs. So we can use a regimen, for example, CTD regimen, cyclophosphamide, thalidomide, and dexamethasone. So even though, if the patient is well affordable, you may not use this regimen, but CTD regimen is not bad. So what we have to see is that if the patient can continue the regimen, he should not abandon the treatment. If he takes treatment for 2 months, 3 months, and then abandon the treatment, then that is not a good thing. So I would actually give, maybe cyclophosphamide, thalidomide, dexamethasone based regimen, which is, kind of a good regimen, then using bortezomib just for 2 months or so. So that kind of a thing, we have to see when we are seeing these patients when they come to us. So a comprehensive management for till the time, for at least year and a half, we feel that these patients should be on treatment, and we should not stop this treatment at 4 months or 6 months or 8 months of therapy. I hope that answers your question.
Yes, yes.
Thank you.
Dr. Pankaj, I have another question to you. In terms of the diagnosis, in the resource poor setting, what is the minimum diagnostic investigation you should send? Because the PET CT and the MRI, these are pretty costly.
Yes. So I think this is again a very important question. So I feel that a bone marrow is generally available at almost all centers. If the bone marrow is not available, then probably that center should send the patient somewhere else. Then serum protein electrophoresis is another one. And skeletal survey by X-rays. So even though people would say that these days we should not do the skeletal survey, I still feel that in a resource constrained setting, even a simple skeletal survey with simple radiology, X-rays is more than sufficient. So what we have to do is we have to see the organ dysfunction which is going on. So if our therapy is not going to change, even if we have serum free light chain or a PET CT scan, then we should not go for those tests, especially if the patient is not able to afford. Thank you.
There is one question is there in the chat box. Dr. Uttiya Dev is asking, is it time for the quadruplet instead of the triple regimen in India?
So for newly diagnosed, I think this question is directed towards that a newly diagnosed patient and patient probably who can afford everything and there are no financial constraints. And the quadruple basically means that whether we add DARA to the existing regimen or not. So we are going to have a panel discussion at, I think at 6:30, where we are discussing the management of newly diagnosed patient, and exactly the same question I'm going to ask to my panelists. Here I can just mention that if the patient is able to afford, then DARA with RVD is the standard of therapy, especially patients who are at high risk myeloma. Thank you.
I think, thank you, Dr. Pankaj, for the wonderful lecture and the question answer. Next, move to the next lecture. I hand over to Dr. Bhausar, please.
Thank you, Pankaj sir, for an excellent lecture. We now move on to the next challenging part, and it is managing high risk and defining and managing high risk multiple myeloma, and that too in the Indian perspective. And so as to do justice to this difficult topic, we have Dr. Manju Sengar. She is the Professor Adult Hematology Disease Management Group at Tata Memorial Center in Mumbai. Over to you, ma'am.
Thank you, Bhausar. Thank you, chairpersons and the organizers for making me part of this particular, very interesting session where we have to put the data where we don't have much data existing. So again, making us think again that we need to generate data before we start talking in the next meeting. So with that, I'll start with my presentation. You may see some clouds here because for some reason I saved these slides on an iCloud and what I could see was only blank slides. So I have managed to put some slides in last half an hour as I joined the session. So the topic allotted to me is defining and managing high-risk multiple myeloma and Indian perspective. What I'm going to do, since there is not much data available from the country on this aspect, what I'm going to do is to put forward the evidence which is available from the literature and see how we can implement this in our setting, give some important differences before we take that trial data and put back into our patients. So to put things in perspective, what is very, very important is that we need to differentiate what is a real world data versus a trial data. And this is not from us, this is the data from the Connect Multiple Myeloma real world data. And if you look at the patients which are enrolled in clinical trial versus what is seen in real world are completely different. You exclude poor performance status patients, you exclude patients with renal failure. Many times those who have extensive bone disease are also excluded because they have poor performance status at the time of presentation. So that is something which we need to keep in mind. The second important thing is that when we interpret a trial data and bring it back to our own countries, we need to look at geographical variation. Not just in terms of there could be, pharmacogenomic differences between two, ethnic population, but important thing is that what is the patient profile in our own country with respect to what is there in the clinical trial data. A very important was highlighted by Dr. Pankaj is availability and access to the drugs. So we do have novel drugs available, but not everyone can access them. And this is especially true if we talk about daratumumab. So that is something which we need to keep in mind. The PMJ, which Dr. Pankaj mentioned, has made it, the HBP2 has made it, now VRD can be used for most of our patients who are eligible for Ayushman Bharat scheme. So that may improve the access, but DARA is in no sight for universal access for quite some time. So that's something which I want to highlight before we move on to actual data. What factors define high-risk myeloma? We all know that there are patient-related factors in terms of age, frailty, renal failure. Then there are factors regarding disease at diagnosis, as well as disease, while we are giving treatment. So these are different factors which indicate whether myeloma is high risk or not. Let's look at what is happening to our own patients. So we know that earlier there was an evidence that 60 or more than 65 years, if you have a multiple myeloma, that's not going to do well. So that's again a high risk factor. But over a period of time, it's the frailty assessment which has taken over. So age itself does not have so much of meaning, but the frailty has meaning. So if somebody who's frail is going to be high risk because the tolerance to treatment and the intensity of treatment which you can deliver is going to be compromised. We always say that, India, we have 1 decade, or at least sometimes we say 2 decades younger as far as our median age for myeloma onset is concerned. So we always say that we have younger patients and, we don't have to worry about this particular frailty. This is a very interesting study which was Lancet Public Health 2019. And what I just want to highlight of this particular study is that if you look at, a 75-year-old chronological age Swiss, his or her physiological age is going to be global 65. 65-year-old is going to be 75 years. So if you look at Indian population, if chronological age there is 65 years, which is this dotted line, the physiological age of that person is, the matching age there would be 58. So 58 is the physiological age and chronological age is 65. So even though we may have younger multiple myelomas in terms of median age, but the physiological age is almost a decade older. And that's what we need to keep in mind when we are interpreting data for our patients. Another important factor which was mentioned is the presence of renal failure. Those who have renal failure do poorly. And if you look at the data, and this is the data from Dr. Lalit's paper, almost this is the data for patients who underwent transplant. And even in that subset, less than 40 creatinine clearance was seen in 25% of them. So these are patients who have undergone transplant. So if you look at all comers, there are going to be many more who present with renal failure as opposed to those which are reported in clinical trials. Definitely a higher risk population. This is something which is standard. So anybody who falls in the ISS3 along with high cytogenetics or high LDH becomes a high risk myeloma. Can we use it in our setting? Most of the large centers now have FISH available to them. LDH is easily available, beta-2 microglobulin and albumin. So yes, this can be implemented in the large centers who treat multiple myeloma. Whether we are different in terms of frequency of these cytogenetic abnormalities. So this is, the data which we have looked at from our own center, Dr. Amre published in 2016. There was not much seen in our, roughly 300 and odd patients which were analyzed. So we are pretty much similar in terms of frequency of, high-risk cytogenetic abnormality, but it's the other factors which make it, little difficult to deliver the treatment in these patients, which I said, including performance status, age, and the presence of renal dysfunction. Another important factor, we all know that plasma cell leukemia is associated with poor outcome, even circulating plasma cells, and most centers have availability of flow. So even, we can look at the circulating plasma cells at diagnosis, because even that makes it, poor outcome in terms of both progression-free and overall survival. So these are the factors which are at diagnosis. But as you treat the disease, you get to see response. We know very clearly that people who fail to respond to first-line therapy or relapse within 6 months of completing treatment, they don't do well. Their median survival is less than 2 years. Is there any way to identify those who have complete response and still have higher risk? And measurable residual disease in myeloma is something which can identify those individuals who are going to do poorly. This is prognostic. It can identify individuals with high risk group. If they become MRD negative, they're going to do as well as a standard risk MRD negative multiple myeloma. So this is prognostic. Can we do it in our centers? Answer is yes. A lot of centers now have facility for next generation flow, large centers where myeloma is treated. they can definitely look at MRD. But does it have therapeutic value? Answer is no. As of now, it has only prognostication. We need to wait for trials where MRD-based interventions are going to have differences in outcomes. But yes, you can, if you have a high-risk myeloma who achieves MRD negativity, you can rest assured that he or she is going to do as well as a standard risk myeloma in absence of, measurable residual disease. So what treatment options are available to these patients? VRD is KRD, DARA-VTD, and DARA-VRD. These are the 4 different regimens which have been explored in these transplant-eligible high-risk multiple myeloma. Just to tell you that none of these trials exclusively enroll high-risk myeloma. High-risk myeloma constitutes a proportion of these patients, and in most trials, this proportion is less than 20%. At best, it's somewhere around 14 to 16%. So small number of patients, and from where we have to extrapolate the data for the larger subgroup of patients who are going to walk into your clinic tomorrow. So this is the data for VRD GEM trial. And if you can see that VRD can induce VGPR or better in roughly around 70% of patients. If you look at the MRD data, because that's something which we are looking at, because that is linked with progression-free survival and to overall survival in a significant number of patients, this particular regimen at the end of transplant, that was not in high-risk category, across all age, all cytogenetic groups, induced MRD negativity post-transplant in roughly around 45% of individuals. So we keep that in mind. Another option, if you look at majority of the guidelines, they talk about carfilzomib, len, and dexa in these patients. So what is data for carfilzomib, len, and dexa in the high-risk patients? So if you look at the extreme right, you can see that almost 86% of these patients who receive KRD just before starting maintenance are in VGPR or better. What about the minimal residual disease? It's roughly around 49%. In those who have undergone transplant, it's roughly around 51%. This is in the high-risk group. And if you remember, we discussed that around 45% of all comers in the VRD study could achieve MRD negativity after that. So that's something where we are in terms of KRD. There is no head-to-head comparison in high-risk patient for VRD versus KRD. And we very well know that KRD did not show better outcomes in standard risk myeloma as compared to VRD. So before we do these cross-trial comparisons and make recommendations, we need to keep these facts in mind. Another regimen, which is combination of daratumumab with bortezomib, thal, and dexa. And as you can see here, the VGPR or better is roughly around 78% of these. And if you look at the progression-free survival for this particular regimen as compared to VTD, there was a difference in terms of PFS and high risk, but it wasn't as good as what is seen in standard risk myeloma. Another regimen which is studied in a phase 2 form was combination of DARA with VRD. And if you look at this trial again, here again the VRD, if you look at DARA VRD, the responses which are complete responses or better were around 79.8, and as opposed to 60% or so in the VRD arm. If you look at the MRD negativity in these patients, if you look at the intent to treat, it's roughly around 47%, but VRD arm has only 18.4. I don't understand the reason why this is lower than what was reported in the VRD GEM trial, but this is what is, is the evidence. So DARA VRD seems to be better than VRD as per this data. We have to await the longer, progression-free survival. So this is a summary of all these trials, what I just spoke about. And if you look at the high-risk population, this is, this particular table shows for entire intent to treat as well as for high risk. For some of the studies which have reported, the post-consolidation CR rates are not very different if you look at VRD or if you look at the DARA VTD, or for that matter, if you look at the KRD, which is slightly on the higher side as compared to what is reported with the VRD regimen. The MRD negativity rates in high-risk population has not been reported uniformly, but there seems to be a sense that the results seem to be better with the KRD as compared to VRD. However, if you look at the DARA VRD arm, it's very similar to what we see with the VRD. So this is again all cross-trial comparison. We don't have head-to-head comparison saying that this whether the patient population in this particular study and the Griffin trial were very similar, and we need to see the phase 3 data to and a longer mature data to make sense out of it. What about the transplant ineligible patient? We know that with SWOG trial, VRD became standard of care. It was better as compared to the RD. But what about the high-risk population in this subgroup? The VRD fared better than Lendexa, but it wasn't something which was greatly impressive. So it was 8 months progression-free survival for those who were high risk by FISH. Whether DARA in this particular transplant non-eligible population shows a difference. So this is the DARA VMP, the Alcyone trial, and this is again a progression-free survival in this particular group. And as you can see that it is crossing unity. So the difference here, what DARA makes in high-risk group seems not so well as it is being seen in the standard risk group. This is for the Maya trial, where it was combined with Lendexa in transplant ineligible population, and you can see that the DARA RD arm showed 24% MRD negative rates, and if you look at the VGPR rates, it's around 79.3%. So again, cross trial difference, but it doesn't seem to be remarkably different than what we have seen with the earlier studies. Again, this is the MRD data and CR for the non-transplant eligible patients. And as you can see that the progression-free survival wherever has been reported, it seems pretty, early. Some of these trials have not reported the progression-free survival, but there is an improvement in Alcyone trial, both in terms of PFS and OS overall, but not in the high-risk population. So there was so much confusion. Meta-analysis was conducted for all these trials where daratumumab was combined with a doublet or a triplet, and the pooled result do show benefit in high-risk population, but this is not an individual patient data meta-analysis, but this is what is the conclusion, and probably that forms the basis for majority recommending wherever it's feasible, in high-risk patients to consider DARA in combination with a triplet. What about transplant in high-risk myeloma? We know that transplant benefits these patients. The benefit not as good as what we see in the standard risk. This was the CIBMTR analysis, criticized because there was not good induction regimen used in these patients. However, if you look at the VRD data, where this is the IFM trial, and you can clearly see that transplant makes a difference and it has benefit both in standard risk and high risk, although the benefit is lesser in high risk as opposed to the standard risk. What about tandem transplant? There is data, from this European Myeloma Network trial that as compared to VMP consolidation and single transplant, double transplant works better, especially for patients who have 17p disease. It did not benefit that much for the 414. Same way here for the Stamina trial, the early results did not favor the tandem transplant high-risk group, but this is a post-hoc analysis which came as an abstract form, and at 6 years, the progression-free survival was much better with the tandem transplant as compared to single stem cell transplant. So which subset one can think of? Probably 17p. If you haven't got a complete response at the end of induction, at the end of first transplant, that's somewhere one can think of doing tandem stem cell transplant. What about allogenic stem cell transplant? Quite compelling in terms of what a physician would think that it will help high-risk individual. However, the data till date has not shown any benefit of doing allogenic transplant as a consolidation or after an autologous transplant as a tandem allogenic transplant. So we don't have much data for that. What about the maintenance therapy in these high-risk myeloma patients? So if you talk about transplant eligible, post-transplant maintenance, we have data for lenalidomide. The benefit of lenalidomide has been shown in the meta-analysis for all the subsets, including high risk, but as in other scenarios, similar, seen with len maintenance, that the benefit is not as large as what you see in a standard risk. And this is not just one study, the Myeloma 11 study. There are several studies which have shown a PFS benefit, and some of them have shown an OS benefit in this subgroup. But the benefit is not what you would want or what you see in standard risk. So whether we can use bortezomib maintenance here. So there are two trials. One of them addressed, bortezomib maintenance.
Dr. Manju, you have 2 minutes left.
Yes, I will be finishing in 2 minutes. So bortezomib, with induction and then followed by bortezomib maintenance. Another one was bortezomib thal maintenance, and both showed benefit. In 17p, it did result in benefit, but 414 was something which did not make a difference. And therefore, there is a suggestion that probably 414 would require an additional drug and something like an RVD, which, this is the study where the consolidation and maintenance RVD was used and we're in the high-risk group itself, and it was showing an improvement in PFS as well as OS. So RVD can be considered in this subgroup. So what about the implementation of all this data in our setting? So if you have transplant eligible patient, VRD as induction is what we would feel is better. DARA is an option for a limited subset, but we are not sure how many of them can continue that maintenance for, till progression. ASCT as single, because doing tandem transplant is something which has not been very practical with us. And these patients can be continued on VR as maintenance. For those who are non-transplant eligible, but they are fit, VRD as either continuous therapy or, after 1 year, VR maintenance can be added. Again, a small subset can, benefit with DARA if they have feasibility. However, we need to see whether this treatment can be continued for long. So that was my last slide. Thank you so much with that.
Thank you, ma'am. That was a comprehensive talk. If there are any questions, we'll take that. So we have one question from audience. In high-risk cytogenetics, should the treatment approach in translocations like 14, 16, deletion 17, P1 or 1Q gain be different? I think that was the topic of your talk, but you could answer if you want.
So if you look at this, answer the same what we've been discussing in last 15 minutes, that yes, it has to be different, but we can't differentiate between 14, 16, 17p and 1q for the simpler reason that the numbers which are there in each of these studies are very small if you go on to dissect each of these translocation. Having said that, there is a data that 414 and 1q may not benefit with bortezomib maintenance alone. And these are the subsets where you may have to think in terms of combining two agents, and especially thinking in terms of continuous therapy like VRD, if the feasibility is there and if the patient is tolerating.
Dr. Manju, one question is that in terms of this, the high-risk myeloma, in terms of this, the quadruple regimen, there's a DARA VRD is there and the DARA VTD is there. So which regime you choose in the Indian perspective?
Sure.
DARA VTD vis-a-vis DARA VRD.
So if you look at, so we have to talk about the evidence, what is available. So evidence for a phase 3 trial is only available for DARA VTD in the transplant eligible multiple myeloma. The DARA VRD is as of now limited to a phase 2 data. So it's very difficult to comment, that whether DARA VRD based on that phase 2 data should be used. If we have to use, and that's a big if, because if you're talking of high-risk myeloma, the benefit there is not very remarkable, then DARA VTD is something what we should consider based on the available evidence.
Right. Dr. Manju, in your practice, how many percentage of the multiple myeloma you get the high-risk features in your practice in Indian setting?
So we looked, so the data which I talked about from Dr. Amre is from Tata Memorial Hospital. So we had roughly around, 9% who had 17p deletion, roughly around 3% who had, translocation 414, and 5% who were 414. So overall, if you look at, it's, under 20% is what we are talking if you're looking at only high-risk cytogenetics.
Right. Sonia ma'am, any question or comment?
No, I think that was a very nice talk, Manju, and very, very relevant also, because we do face this in our clinical situation, the high-risk patients, and therefore it is a very, very relevant talk also. Thank you very much.
Thank you, ma'am. Thank you.
Ma'am, you spoke briefly about the VRD being used continuously in non-transplant eligible patient, the leukemia paper from US. So do you think that is something doable in our practice? And many of our patients would not be a candidate for tandem transplant for that matter. So, and this has shown some consolidation benefit post-transplant as well. So this is something which can be done in our patient. So what's your thought on that?
Yeah, so continuous VRD definitely is a doable thing in somebody who's fit. But again, I want to mention that continuing the same dose, that is 25 milligram of lenalidomide, 1.3 milligram per meter square weekly of bortezomib and Dexa 40 becomes tough after some period of time. So after a year or so, we invariably, we need to, end up reducing the dose. So it's usually len which, gets low. Many times the Dexa goes off after some time, and bortezomib at the end of it becomes something like a maintenance, which is once in 2 weeks. But yes, those who are tolerating with close watch, one can consider continuing VRD, because we know that once these patients relapse, there are not many options available for them. So we want to maintain that PFS for as long as possible.
Yeah, but surprisingly, that approach is not very popular. No studies are coming on that. All right. So I think that was a nice talk, and we move on to next talk, and I hand it over to Dr. Tufan for the.
Yes, yes. Thank you, Dr. Manju, and thank you, Dr. Hausab. Next, we move into the next topic in this session. The world is now in the COVID-19 pandemic situation. So, try to cover this topic, the managing the multiple myeloma during the COVID-19 pandemic in India, the lesson learned. So, the speaker is Dr. Hari Menon, and Dr. Hari is the well-known face in the community of oncology and the hematology. So, he's the senior consultant and the director hematology and the director of the bone marrow transplant program, the Saitya Hospital, Bangalore. So, over to Dr. Hari, please.
Thank you, Chairperson. Thank you, Dr. Tufan. I'll just share my screen. Yeah. Is it visible? Yeah.
Sir, we can't see your slides.
Okay. Okay. Oops. I'm just trying to. Can you see it now?
No, it is still not visible.
No, sir. You have to share it on the Zoom firstly.
Yeah, I'm doing that. I've done this before.
Yeah.
Just a minute. Sorry. Can I? Oh, it's not coming.
So, Mr. Binod, you have a slide with Hari Menon slide?
No, sir.
1 minute. I'll just try once more. I'm sorry. Or can we go to the next and I will share my, can we go to the next talk and then can I share the slides to the people?
I think there is a conjugate to topic on the debate. The Ashish is there and Dr. Rahul is there. I think we need the two speakers together.
Okay. Okay. I'm just trying to.
Please try.
Yeah. Sorry.
We know is Dr. Ashish Dikshit and Dr. Rahul Bhargav on board.
Dr. Rahul is not on board. Dr. Ashish is there.
Okay. Can you talk to Dr. Rahul?
Sure, ma'am.
Hari, if you can email your slides.
Yeah. I'm just making one more attempt. I've just gone.
Yeah.
I just don't know why this is not happening this time.
Hari, close all the windows on your desktop and then open only the presentation on the desktop and then share.
Okay. Okay. I don't know. I think the problem is that this is my new laptop. So that's a problem.
Okay, so Dr. Hore, you please email your presentation.
Yeah.
Do you have the email address of Kalpesh?
Yeah. I will just email it, ma'am. I'll just email it. Yeah.
Yeah.
I'll just do that. God, I'm so sorry about this.
No problem. Don't do. It's okay. This happens.
This is the failure of technology. Don't worry.
Yeah. I'm just trying once more to share the screen. Yeah, I'm sending it. That's also. This. So I have shared it with Kalpesh.
Vinod, please communicate with Kalpesh and try to share.
Yeah, Kalpesh is next to me only. Just a moment.
Okay.
It has gone. It has gone through. Has it come now?
Yes, sir.
Yes, sir.
Yes.
Okay, thank you. I don't know what I did, but it came. Yeah. So thank you, and
please continue.
I'm sorry about that. So I was given this topic, and I was just wondering how I can give this talk, because we have very little data, and I have to rely upon what is being said. And remarkably, when I was scanning through all the publications and recommendations, I could just find only a common point. And we are so the talk is a bit more philosophical over here. So I'm unable to move the.
Sir,
I'm unable to
Hari
move
sir.
the slide. Yeah.
No, you have like used the slides as your virtual background. So just give me a minute. I'm sharing your slides. You just do the presentation.
Okay,
Just a moment.
Okay, will do.
Hari, this is a tough topic.
Yeah.
That's why we chose you. It's not an easy topic.
No, even as the slides are coming on, I will just try to. So when I was just reviewing the literature and what we have in our Indian data, and of course, Image as with the efforts of Dr. Uday, we did have a small collection of data on what is happening to our COVID patients. But uniformly, when going through the data, most of the recommendations in societies have come up with a common recommendation for treating myeloma patients. And I felt that over a period of time, we started using the same kind of recommendations by default at treating our myeloma patients because we didn't have any time to think when the pandemic affected us, and we just went along with the flow because myeloma patients cannot be without a treatment. Can I have the next slide, please? Can I move the slides from here? No. So we know that the world.
Yes, sir, you can.
I can.
Sir,
okay.
Yeah, so you just have to ask for the remote control.
Okay. 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 Yeah. So the world is facing the COVID pandemic, and there were special concerns that surfaced when dealing with cancer patients, especially related to the immunosuppressed status. And there was a wide perception that more aggressive COVID-19 affection would be there in patients with hematological malignancies. And the access and the quality of care in cancer therapy has also been severely compromised because of the non-availability of services and the inability of many patients and the fear among patients to come to cancer hospitals for their treatment. So multiple myeloma patients were a specific and a particular group with several important aspects. Mainly, they were immunosuppressed in different intensities during their treatment. Most of them are elderly, as we know, and all of them require long-term therapy with prolonged contact with the healthcare system, requiring repeated follow-ups. And this may possibly, and there may be a good section of patients who may require stem cell transplant, which is probably an integral part of their treatment for best outcomes. So it's not okay. It's gone. I'm unable to. Can I have my slides back, please? Can I have my slides? I think my slides have gone. Yeah. You could move the slides because I'm unable to do so. So when you talk about special consideration of a myeloma patient, there is a close association with immune system disorders as far as myeloma is concerned. We know that it's a disease of the immune system. And there is definitely a dysfunction in the humoral responses, as is evidenced by the increased affection of these patients by viruses and bacterial agents. We also know that there is a delayed response to any sort of vaccination. We know from the story from the pneumococcal vaccine and the influenza vaccine, as far as myeloma patients, in which they do have a little bit of a delayed response in terms of generating an immunity to these infections. There is also something called the immune senescence in newly diagnosed myeloma, and which tends to progress down the line, especially if the patient is not responding adequately to treatment. And there are different classes of agent which independently contribute to the intensification of the immune damage, which includes even the T cell responses in these patients. So though we do not encounter too much of myelotoxicity, we do understand that some of the medications that we use induce myelotoxicity and bone marrow suppression, which becomes an added dimension in terms of being susceptible to an infection in myeloma. And we know that most patients are elderly, having comorbidities, especially hypertension and diabetes in these patients. And these negatively impact infection events, as we would call it, which increases the risk of infection and acquisition while worsening outcomes in these patients. And this is the perception that we have. So when we look at the data, which is not part of the COVID times, but the Swedish data, as far as the susceptibility to infection in myeloma patients are concerned, can we just progress? Yeah. So we know that as compared to the controls, there is almost 10 to 12 times increased risk for infection in myeloma patients. Next. And this kind of cumulative probability of infection-related deaths are also significantly increased as against the control population in myeloma, as compared to the control in myeloma patients. And next, we do also understand that patients above the age of 65 had a worse outcome as compared to those below the age of 65. So age becomes the big criteria over here. So this is, I just put up the slide just to understand, to just demonstrate the susceptibility of infection, irrespective of whatever it might be in a myeloma patient. Next. So there's a 10-fold increased risk of viral infections. Mortality-related infection increases from 2 to 12% in these patients. Next. So we also looked at the data thanks to Uday's effort and the image body, which looked at the outcomes of COVID-19 patients in plasma cell. And there were about 27 institutions which participated in the study, which looked at about 94 patients with a median age of 57 years who developed COVID infection while they were on treatment for myeloma. So the median time was about 13.5 months from the diagnosis of multiple myeloma. So most patients, I would gather, were on some sort of a maintenance therapy, and most patients were on proteasome inhibitors. There was severe COVID infection was encountered in about 19% of the patients, and there was a very high mortality rate, at least in this cohort of patients, to the tune of about 18%. So there was no significant impact of age, duration, or myeloma disease status on the severity of outcomes in this myeloma. So this was a short study which has been collated in the Indian context and which is being under review for publication. Next. Can I have the next slide, please? Yeah. So what are the considerations for treating myeloma during pandemic? How do we approach a newly diagnosed myeloma? So the question is, should we modify therapies in these patients? The next question that comes is, are we changing therapy to minimize visits? And what is appropriate and what is optimum over here? And the third question is, should there be a change or a need to revisit maintenance therapy? So therefore, the question that comes is it that immunosuppressive for us to make that change? And so managing transplant eligible patients, so should they be deferred? And who are the people whom we would consider for transplant is a question that needs to be answered. And are we withholding enrollment into clinical trials? We know that there were certain trials which were on the cusp of being activated when the pandemic started in India. And by default, many of them were held up because of the inability to initiate the sites and also the logistics that were involved in taking care of the patient. So at least at least I know from my two of my studies never took off until about a few months ago when we restarted enrollment into clinical trials. So the last and the most important question that everybody is asking, just not only for myeloma, but most malignancies, particularly hematological malignancies, is do we vaccinate our myeloma patients routinely? And therefore, the question that comes up is, will myeloma patients generate adequate antibody response? So next. So how do we approach a newly diagnosed myeloma? Should we modify therapy is a question. So we do understand that as such, myeloma is an immunocompromised state, and as such, that is not going to improve on its own unless the patient is going to be treated for the disease. So therefore, there is really no doubt that we need to go ahead and treat this patient, and we should not be withholding any treatment for such patients, especially when they have symptomatic and active myeloma. There is also the addition of definitive therapy would the feeling that there would be hardly worsening of the immunosuppressed state by the addition of the drugs that we currently use for multiple myeloma, perhaps except for the steroids, which of course can be reduced in its dosing schedule. And we also know that consideration for continuing on a standard treatment should always be opted for. And we know that that it has not contributed to worsening of the outcomes in patients should the patient develop a COVID infection. However, again, the outcomes of these purely depends not on the disease itself, that is myeloma, but more so on the comorbidities and the immunosuppressed state, of course, for which the patient is prone to infection and the degree to which he has an inflammatory response. So the dose-reduced steroids and weekly bortezomib with home administration subcutaneously is something that may be considered, thereby reducing the hospital visits in these patients.
Dr. Hori, you have 2 minutes left.
Okay,
Please
and oral bisphosphonates, yes. Can I go to the next slide, please? And what about immunosuppressives? So most patients who have come to the point of maintenance have at least achieved a VGPR, and their and we would assume that their immune status is better than what they were at the time of diagnosis. So there is no real need for a change in the maintenance therapy. And this is what we have understood. And this is what there has been a recommendation for most societies also. Steroids, if they are in the maintenance therapy, needs to be omitted, and because it doesn't really contribute too much to the maintenance phase in these patients. Similarly, maintenance, it is felt that maintenance does not worsen the chances of contracting an infection in these patients. Next. What about transplant? The initial recommendation is, of course, to shy away from transplant. And currently, too, if the patient has achieved a good response, we may still want to avoid a transplant, though we may not defer the collection of stem cells in this patient with the option of trying to do a transplant at a later date. And also patients who are already in the process of stem cell collection could proceed with the stem cell collection, and we could delay the transplant in these patients. And of course, there needs to be a screening for SARS-CoV-2 before doing a transplant in these patients. Next. So, and what about enrollment in clinical trials? I think I will skip through this because I have already mentioned that this has been taken forward, and enrollment into clinical trials have been started in these patients without any added problems, so except for the logistics that may be associated for the patients to come to the health care facility. And about vaccination, patient with myeloma has a 7 to 10-fold increased risk of bacterial infections anyways, and they do not generate a good antibody response. But whatever, we know that today, that whatever antibodies can be generated, there may be a protective role. And under the circumstances, there needs to be a recommendation for vaccinating all the patients who are on treatment, whether they are on treatment or on maintenance therapy, as far as myeloma is concerned. Next. So I think it's all gone haywire, I think. So I had this ESMO recommendation, which I thought was relevant and which we all follow. Next, can we have the next? So for high transplant eligible patients, treatment should not be postponed, and therapeutic decisions should be made on a case-by-case basis, considering disease stage, risk, and cytogenetics. And there should be the use of GCSF over here to minimize neutropenia. Next. I have just another 3 or 4 slides. So, and when you look at the intermediate priority over here, you may consider delaying transplants, as I had mentioned. We may want to, patients scheduled for undergo should be tested for COVID, of course, and of course, they should be, as much as possible, these patients should be monitored by teleconsult as much as possible. And the patients may be taught also to use subcutaneous bortezomib, which can be monitored over a teleconsult of these patients so that they can avoid a visit to the hospital. Next. And the low priority is, of course, delay the follow-up visits when possible and delay anti-resorptive therapy in these patients. Next. For transplant, Can I have the next slide? So, so for the elderly patients, treatment should not again be postponed. Therapeutic decisions should be made on a case-by-case basis, as is true for the young patient with myeloma. Next, and the lower priority is for patients again who are on continuous therapy should be continued with lenalidomide and dexamethasone. You may reduce the doses of dexamethasone over here to the lower dose schedule, and also consider again GCSF support more liberally, which we do not in clinical practice. But if there is neutropenia, we may want to consider GCSF support over here. Next. So this is my last slide. And patients in stable remissions, especially, delay follow-up visits and perform telemedicines if possible in these patients, and delay anti-resorptive therapy in these patients, and consider for the time being even oral, though they may not be as good, to consider oral bisphosphonates in these patients so that they can reduce the visits to the healthcare facility. And with that, I will conclude. Thank you.
Thank you, Dr. Hori, for the wonderful lecture. So we can, for the couple of questions. My question to Dr. Hori, if the patient develops the COVID positivity, there is no symptom is there, like the mild symptom related to the COVID. So did you start the chemotherapy with the myeloma?
So generally, again, as per the recommendation that is there, we generally stop any anti-myeloma therapy during that phase until such time that the patient will recover and resume the treatment once it is completed. So just one specific thing for those patients on thalidomide treatment, one should be a little careful because we know that thrombosis is a problem with COVID and we don't want to add to that. So most certainly, we should be careful over there, and certainly thalidomide, etc., should be stopped in those situations.
Thank you, Dr. Bhavsar.
For that matter, yeah.
Thank you, sir. That was wonderful. So now we have this pandemic going on, and we postpone the certain phases of treatment, etc. Now vaccine is available. So what's your approach? What are you advising your patients who are on active treatment, or for that matter, on maintenance?
So there was a lot of discussion and among my colleagues, and in fact, I did interact with a few of our international relations, Shaji and everything. So I asked about their opinion as to what we need to do. And when we looked at it, as I said, myeloma is again an immunosuppressed state. We know that the problems that we think about is that whether they're going to generate the antibodies, but we also know that whatever antibodies are generated may be useful, at least we think that it is useful in these patients. So under the circumstances, it doesn't make any sense for us to wait. And so we may just go ahead with the vaccination for whatever benefit that it may produce, because it would appear that even though there are reports of some problems with vaccination, etc., in the larger interest of benefits that we give, I think we should vaccinate all patients irrespective of the timing of their therapy. So I was talking to because we have some patients on daratumumab on a phase 3 study, and there was this thing about wanting to vaccinate, and I was asking, the CRO did not have anything to say opinion on that. So when we asked, I discussed with Dr. Shaji, and he said that they are vaccinating their patients, even on patients on daratumumab. So I think there's really, it's variable, but at least we are going ahead with vaccination for all patients. Yes.
I think, Dr. Bhavsar, we need to close. So thank you, Dr. Hori, for this wonderful lecture and the discussion. Now we move to the next topic. For this, I hand over to Dr. Bhavsar, please.
Thank you, sir, for a wonderful talk. Now we have a debate scheduled for next. The debate topic is bortezomib, lenalidomide, dexamethasone versus carfilzomib, lenalidomide, dexamethasone in the frontline induction therapy for multiple myeloma. The debate was to be between Dr. Ashish Dixit, who was supposed to speak for it, and Dr. Rahul, who was going to speak against. But is Rahul there? I think I see a message where he, because of some COVID-related emergencies, he could not join us.
Yes, sir. He will not be able to join.
All right. So I think we will have ample of time to listen to Dr. Ashish. So Ashish will give you some extra time, and maybe after discussion, after your talk, we could discuss some opposing points as well. So over to you, Dr. Ashish. So just to introduce formally, Dr. Ashish Dixit is a senior consultant in hematology and bone marrow transplant physician in Bangalore, and Ashish is well known to the physician community in India.
Thank you, Mausab and Tufan. Thanks for the committee members also. I mean, it takes away the fun of the debate. It's unfortunate that Rahul cannot join today because knowing him, he is such a passionate debater. I think it would have been more fun. But I mean, it gives me extra time. So maybe I can go through the slides a bit slower and then make sure that it is interesting for everybody. I'll just share the screen here. Sorry, I'll need to.
I'm sure Ashish will carry it forward equally well, as passionately.
We were able to see your slide for a second, then it's vanished.
Yes, but it is showing a. Right, let me just try again. I think I'm facing the same issue that Hari was facing that time. Let me try it again and check.
I must say that I didn't do anything different, but it was just not going in.
Ashish,
short of time, so it doesn't matter.
Ashish, sir, we have your slides, so
you can share. I've sent again. Can you see these slides or no?
Yeah.
Yes, now it's visible.
Perfectly, sir.
So all right. So I just shared the Zoom screen only. So I just put it on the screen share. Fine. So thank you. So the debate topic was VRD versus KRD, newly diagnosed multiple myeloma. Manju made my job very easy, so I can announce that VRD wins hands down. So we'll then go ahead and then see how exactly it does the job. So this was the first trial, the SWOG, that actually started the VRD as a standard of regime compared to RD, where bortezomib, lenalidomide, dexamethasone was compared with lenalidomide and dexamethasone, followed by RD maintenance. Here was the difference, RD was used. And when we see the results, there was significant improvement in progression-free survival as well as overall survival. So VRD became a standard here from here on. And for the elderly, frail population who cannot tolerate a full dose, RVD light became the standard of choice in transplant ineligible. If we see in this trial, the median age was around 73 years, including up to 91 years of age, and progression-free survival was indeed impressive. Now we're coming to the main topic that we are discussing. Let's start from newly diagnosed multiple myeloma who are transplant ineligible. This was the trial that actually from where the debate has begun, and this was a trial to actually answer that debate that KRD may be superior. So KRD was compared with VRD in the newly diagnosed multiple myeloma. This was an endurance trial, phase 3 results, more than 1,000 patients. Now what we see here, it was a surprise. There was no difference in progression-free survival at all. Overall survival was similar. That is expected because it is newly diagnosed case and most of them are salvageable by other regimens. But there was no significant difference. And the primary reason for that not being a different regimen compared to VRD was because of higher rate of cardiopulmonary toxicity. Now, these are elderly people who are not eligible for transplant. Even amongst them, some of them actually proceeded for the transplant. Now, that actually surprised, and the out of proportion toxicity was something that was coming out of blue. That was not earlier seen as much frequency, but overall the progression-free survival was same. KRD did lead to a deeper response, particularly in the high-risk population. So that was the difference. So there was some data that it works well, but there are only 14% of the patient with the high-risk cytogenetics where it is going to benefit more compared to the large population where it will not benefit, may do more harm. So if we look at the variables across different markers that we can look at, whether it is stage or other parameters, there's no difference in the VRD or the KRD arm across the groups. By default, this trial did not include a high-risk population, high-risk cytogenetics cases. It it did include 414, but it did not include any other high-risk cytogenetics model. So there can be a criticism. It did not include one of the vulnerable population that it was supposed to work better. That we agree, it may not reflect. But to answer that, there is another study called Clarion. It is not on the lenalidomide-based data, but this is carfilzomib with melphalan and prednisolone comparing with VMP as a standard line, 9 cycles each, and it was continued followed by a maintenance. And this included all the stages, around 1,000 cases, 955 approximately, with different stages. And when we see the results here, there is actually no difference in progression-free survival. If you see across, it is coming similar. In addition, there is no difference in the outcome in terms of what we see in the variables across the group. There were quite high number of stage 3 cases, stage 3 ISS cases in that. So that answers the query whether stage 3 cases are going to do as well or not compared to KRD. So yes, VRD still works as well. It is not offering a better benefit amongst these cases. Now, to actually make it more sensible, we can include something which actually is not cross-reactive. And that's where the MAIA trial tried to identify whether we can add monoclonal antibody daratumumab to RD and then make it better. So this was a trial comparing DRD versus RD. Quite an expensive protocol if we are discussing in the forum where lower socioeconomic status is being discussed, particularly as a heading of this session. So it is very difficult, but what we know is the results are significant and the DRD median progression-free survival is not reached, including a higher rate of MRD negativity, which is a target goal in most of the trial and current generation. So what we can see over a period of time is, if we compare the results across, the best results are with RBD, and DRD actually makes it even better. So that's the only difference that it has created. So maybe DRD is going to become a routine as the financial cost of it becomes more and more affordable to our population, maybe with the generics at some point of time. Now, when we look at the transplant eligible, we don't have the head-to-head data for carfilzomib with bortezomib with lenalidomide dexamethasone. Any of these are available as a head-to-head trial. What we can gather some information is from the Forte trial that Manju has already discussed. This was carfilzomib with cyclophosphamide dexamethasone versus len-dexa without transplant. Interesting design because it had 2 randomization. One was just comparing if after KRD, do we really need a transplant? So KRD followed by KRD consolidation, followed by a randomization to see the maintenance type, or KRD compared with the KCD, randomize, do a transplant and go for the consolidation KRD or KCD respectively, and then second randomization again to KR versus R. Now, when we look at the result, whether it is the transplant group or non-transplant group, even in the high-risk cytogenetics arm, the results are quite impressive. They are actually coming similar, whether you do transplant or not. So they are looking almost same. Makes everybody wonder, is transplant really worth? But what is important here is not achieving MRD positivity again. It's the sustainability of the MRD that we are looking at. And that's what was the assessment later that came, that if we look at 1 year persistent MRD negativity, if we don't do a transplant, almost 40% of these cases actually started losing the MRD negativity compared with the one who has undergone transplant. So transplant, KRD is not removing the need for transplant in these cases at all. So this is the response pattern. Again, progression-free survival was much better for the one who has undergone a transplant. But yes, KRD definitely was better across the groups. So to make it easier that what exactly we need to add on, this has already been discussed by Manju earlier. I'll just touch upon that what is the need to bring in this study is mainly daratumumab VTD should be added as an addition to improve the outcome, particularly in the transplant eligible. The main results are coming from the MRD data, which is showing quite significant and deepened response. Even though in the final analysis, the high-risk cytogenetics has not made a difference amongst the 2 groups, but it is still something that these groups, whatever responses come, they are possibly likely to be more sustainable over a period of time. And this is the outcome data. Progression-free survival was definitely better with the Dara VTD compared to VTD arm. And those who have achieved stringent CR did have a flat line there, which is going into a continuous remission, suggesting that they are possibly going to be long-term responders there. Now, this was again, since we are discussing RVD, this is a trial of Griffin study, which compared between DARA RVD versus RVD. And then it actually compared the maintenance differently compared to the last one, where it was criticism that our maintenance DARA versus no maintenance was compared. Here, the R maintenance versus no with the DR maintenance was compared, and transplant was a standard in these platforms. This is a very early data, no difference in survival difference between the two in PFS versus OS, but the curves seem to be starting to separate here. So we still need to see this data. It will be interesting to see 1 or 2 years down the line what exactly it shows, whether it is showing any significance. So what do we do here now? So I prepared the next slide, assuming Dr. Rahul will be there. So I'll just say the topics for him also, what all things will be would have been the point for him to depend on. KRD achieves a better remission. The argument is, yes, it does, but the cost is quite huge. The side effects are more, and it is being given regardless of the status for the type of cytogenetics of the remission, the risk status. DARA addition doesn't have overall survival benefit in these cases. It's an unfair comparison. We can't really compare the overall survival benefit so early in a long-term study, particularly when we are looking at newly diagnosed myeloma. The other is addition of daratumumab may not be effective for high risk. It works the same. It is not showing inferiority. It is working same than VRD, and we need to wait for longer data to say whether it is sustaining it or not. And the usual point, cost factor for other drugs to add. Agreed. That is the main factor that is going to decide us to move away from daratumumab as of now. But we need to keep in mind, even when we are offering KRD, it is requiring IV, requiring frequent visits to hospital, and there are a lot of side effects that we may need to manage, which will add on to the cost effect there. So as of now, when we see KRD, it is as other recommended regimen in NCCN guideline, but DRVD is also sitting there in the same bracket, suggesting that it is something that is likely to be still going to be become a category 1 at some point of time. When we look at those who are non-transplant candidates, in any case, carfilzomib is out. Either we use VRD or we use bortezomib-based other regimens. VCD is something which is out, but we can use daratumumab along with lenalidomide dexamethasone and keep it as a category 1 recommendation in those. I would just highlight this. This is a recent guideline, couple of months back it was published. This is ESMO EHA guideline for diagnosis, treatment, and follow-up. And it doesn't mention anywhere where KRD to fit in. Either it is for transplant eligible cases VRD or DARA VTT. If no option, then only VTT or VCD, followed by transplant. For those not eligible for the transplant, it is DARA RD, DARA VMP, VRD, but it's not going to include any of these cases. So that means it is only going to be a select population of the patient that possibly may benefit from there. So I'll conclude here. VRD has got equal efficacy compared to KRD in myeloma. In limited number of cases with high-risk disease, safety and eligibility for transplant should be considered before offering a more toxic regimen. Carfilzomib always can remain a salvage option, and that will be where its place is going to be more useful. And more is not always the better. This is what the endurance trial has told us. So we'll just conclude that in an asymptomatic patient of COVID, there is no point in offering everything when he is fit for a home isolation and admission. Then we are just going off the target. What we are going to end up with is going to be a set patient who is lying there. What we need is more targeted regimen, better efficacy, and better combination of these regimen. Then only the patient can be happy and satisfied with the care we are providing. I'll stop my discussion here, and I'll be happy to answer questions if any queries are there.
Thank you, Ashish. That was quite a comprehensive review of the induction regimen, RVD, and you spoke about alternative regimens as well. So you started with, we are getting some questions, but before we go on to other questions, you started with the confession that KRD not being superior to RVD was a surprise to you as well. And there were a number of studies, phase 2 studies, they said KRD is better. In fact, Endeavor study in the relapse setting showed overall survival benefit of using carfilzomib. So what could you think? What's your likely reasoning for this? Because Forte trial, it was built on the premise that KRD would do better. In fact, they didn't do transplant, and it seemed a bit working. Not only thing which is lacking is sustained MRD negativity, but it is giving good result. So why it is failing in the Endeavor study?
Yes. So most of these, I think, are, I mean, it's a difficult, as Manju said, cross-trial comparisons will be very difficult for us to justify there. But the main concept for endurance trial was mainly to prove that it is superior. And the surprise was we all were assuming that it will actually, it is supposed to be superior. When we use it in the salvage regimen, it works much better, even in those who are failing the bortezomib in the early phase and patient cannot go for any other therapies. So it came as a surprise that why is it failing in this scenario? So it is not a failure. It's mainly in terms of the toxicity that it is offering is not coming to that level. So the PFS is coming same even after having a better response there, because it is negating whatever advantage we are getting. And most of these cases, we need to remember, are going to be long survival. There, we cannot give them the toxicity where the survival is compromised or the cardiotoxicity becomes significant. So these all things started moving us away from the carfilzomib. So that was a surprise that we didn't expect that much toxicity because it was not described as much in the phase 2 study as with that frequency.
Yeah, thank you. I think you have a point there.
My question is that in terms of the cost issue, right? In terms of the cost issue of the carfilzomib vis-a-vis the bortezomib, and in terms of the result, so how do you consider in Indian context?
So in Indian context, I would still favor using carfilzomib only in the scenario of high-risk cytogenetics. I won't consider using carfilzomib as a first line for simple reason that it is very, it's going to make the person more hospital dependent. It's very uncomfortable to give them every week with the IV infusion, particularly when they have been diagnosed. Even those with the renal failure, some of these, it will be preferable to use other targeted drugs. If they can afford, I will rather prefer to use daratumumab upfront. So the use of that, I think, can be restricted to the patients who are having high-risk cytogenetics. That's the best way to place them.
Okay, I don't see any questions. If anyone has any question, they can unmute themselves and ask Ashish.
Ashish, I had a question. Why did you say that you would prefer to use it in patients with high-risk cytogenetics? I didn't get that. You know, because is there a head-to-head comparison between the proteasome inhibitors in high-risk cytogenetics?
Most of them did not, ma'am, but the one that was done as a part of the Forte trial, high-risk cytogenetics did have a good response. So that was the only trial that actually mentioned that there is a significant response and transplant actually enhances it. So other than that, all others did not show as much of a response, and the degree of MRD negativity that achieved and the stringency that was there was significant. So there is no head-to-head trial that has been done, I agree. But the trial results and the phase 2 results were showing that response are almost coming equivalent in high-risk cytogenetics as well. That's the only reason that the high-risk cytogenetics still is an open field to use it.
Yeah, thank you, Ashish. So Ashish, you said in high-risk you would like to use it, but if you see the current MSMART, they have removed that. It was earlier their KRD for this. Now they recommend DARA RD or DARA VRD for ineligible and eligible patient itself. But I think you have a point in our setup where DARA availability may not be there. To consider it in appropriate high-risk patient will remain an option for us.
Yes.
Yeah. All right, Ashish, one question: where you will not use VRD in upfront setting? You spoke about VRD, so where you will deviate from your practice of using VRD?
Yes, so simple answer. Any patient with the renal failure, usually we don't use. So in those cases, we'll not be using. It will be mainly cyclophosphamide based or thalidomide based, depending on what the patient preference is. Most of the time, we go for cyclophosphamide. So we'll use a VCD regimen, try to bring the disease in control as much as possible. most of these cases, I usually prefer to give the bortezomib bi-weekly rather than giving weekly in the beginning, because I still believe that works better in the induction phase at least.
Yeah, and subcutaneous use. So I think that's one probably a deviation where probably VRD may not be appropriate. Thank you, Ashish. Thank you for covering for Rahul as well. And we hand it over back to ma'am.
Thank you.
Okay.
Yes,
Thank
yes,
you,
yes.
Ashish.
Good lecture.
Of course. Very
Yes,
nice.
about ma'am.
So I think are at the end. I think we also await the marketing of Ixazomib in India. That will actually be very good for these high-risk cytogenetic patients.
Of course. If we get it, yes, the maintenance of that definitely will change the picture.
Okay, because there's very good data on that for high-risk cytogenetics.
Yeah.
So thank you, Ashish. You held the debate very well and presented excellent data. And I would like to thank both the chairpersons, Dr. Bahu Sahib and Dr. Tufan, for chairing the sessions, and Dr. Manju Sengar also, and Dr. Hari Menon, Dr. Pankaj Malhotra for their lovely talks. And so now we will move on to the best paper presentation session, which will start in about 5 minutes from now. And that will be for 1 hour. In fact, it's going to start now. It's from 4:40 p.m. And then after that, we will meet back again for the corporate symposium, which will be held from 6 o'clock onwards. And then the plenary sessions from 8 o'clock onwards. Thank you very much for everyone for participating.
Thank you, ma'am.
Thank you.
next session is Corporate Symposium, that is supported by Jensen Oncology. And we have a video to play.
Darzalex, daratumumab, mechanism of action. Darzalex, daratumumab, as monotherapy, is indicated for the treatment of adult patients with relapsed and refractory multiple myeloma, whose prior therapy included a proteasome inhibitor and an immunomodulatory agent, and who have demonstrated disease progression on the last therapy. CD38 is a cell surface receptor with multiple functions, including roles in signaling, receptor-mediated adhesion, and enzymatic activity, and is overexpressed on myeloma cells. Darzalex is the first and only approved CD38-directed human monoclonal antibody that induces cell death in multiple ways, including direct on-tumor activity as well as immunomodulatory mechanisms. When Darzalex binds to CD38 on the surface of myeloma cells, it can generate on-tumor activity through several immune-mediated mechanisms. These include the initiation of the complement cascade, resulting in complement-dependent cytotoxicity, CDC, by which tumor cells are lysed through recruitment of factors in the serum. The targeting of myeloma cells by effector cells for destruction through antibody-dependent cell-mediated cytotoxicity, ADCC, and the marking of myeloma cells for elimination by macrophages via antibody-dependent cellular phagocytosis, ADCP. Additionally, Darzalex has direct on-tumor activity that occurs upon cross-linking, resulting in apoptosis of myeloma cells. Darzalex also works through immunomodulatory mechanisms, which can adjust the immune response, including modulation of the tumor microenvironment, depletion of immunosuppressive cell populations, and increases in cytotoxic and helper T cells. Because CD38 is present on immune cells that are responsible for immunosuppression, targeting of these cells by Darzalex may contribute to the anti-myeloma response. CD38 is found on a subset of immunosuppressive regulatory T cells, Tregs, regulatory B cells, Bregs, and on myeloid-derived suppressor cells, MDSCs, all three of which are also implicated in cancer cell immune evasion. Depletion of this highly immunosuppressive subset of CD38-positive Tregs, Bregs, and MDSCs was observed in patients treated with Darzalex. Cells that express CD38 may produce extracellular adenosine that can contribute to immune suppression. Darzalex may also modulate the tumor microenvironment by reducing this immunosuppressive CD38 enzymatic activity. Significant increases in CD8-positive cytotoxic T cells and CD4-positive helper T cells have been observed in both the peripheral blood and bone marrow of patients treated with Darzalex. In particular, the ratio of CD8-positive effector cells to Tregs nearly doubled, indicating a specific enhancement of the effector T cell population. This clonal expansion of CD8-positive cytotoxic T cells may be indicative of activation of the immune response. By combining direct on-tumor actions of traditional antibody therapy with systemic modulation of the immune system, Darzalex provides a multifaceted approach to promoting myeloma cell death.
So our first speaker is Dr. Dhara Sanghvi.
So,
Over to you, Dhara.
yeah, thank you, sir. So, good evening, everyone. Yes, we are in the midst of crisis, and every one of us is fighting this pandemic, also the fatigue from the pandemic. Hope you all are keeping safe. I would take this opportunity to thank Image and Dr. Sonia Nityanand ma'am and Dr. Anshul Gupta for inviting me to talk on daratumumab subcutaneous emerging data. So, starting with this, daratumumab subcutaneous was approved last year around this time. It was in the May where US FDA approved the subcutaneous DARA. Though it is not approved yet in India. So DARA, Darzalex Faspro, that subcutaneously takes over 3 to 5 minutes. The duration, traditionally daratumumab is given as IV infusion, and the first infusion takes 7 hours versus subcutaneous takes lesser time and lesser time to give the injection. The subsequent infusion for DARA IV are for 4.3 and 3.5 hours. Though modestly DARA IV infusion-related reactions are quite modest in terms of neutropenia, thrombocytopenia, and chest and URTI, that is upper respiratory tract of dizziness. Though, so there are chances of grade 1 and 2 with 28% to 40% with DARA IV. Now, daratumumab subcutaneous lowers this IRR. We will see in the data further. So it is a flat dose of 1800 milligram and given with hyaluronidase, which is so hyaluronidase, which increases the subcutaneous tissue permeability and facilitates subcutaneous drug dispersion and absorption. That we have already seen, which is hyaluronidase is given subcutaneous with trastuzumab and also the rituximab. So coming to safety and efficacy of DARA subcutaneous administration in clinical studies. So DARA subQ was done in pivotal 3 studies, that is POWER phase 1 studies, then PLADUS and Columba as phase 3 study. So I'll take you in detail of this 3 study. Andromeda for daratumumab subcutaneous, which was covered very well by Dr. Ashutosh Vaslekar this afternoon, where he highlighted this whole trial data. So coming to this POWER phase 1B, where DARA subcutaneous dose escalation was checked, that was in part 1, it was tested 1200 versus 1800. And the results were that all 1800 had good ORR, and also disease progression had been seen with 1200 milligram and not enough concentration. So in part 2, they got the, from the analysis, they got the permission to give only 1800. So in part 2, DARA 1800 was tested, which gave deepened responses. We can see here that in part 2, ORR was 52%. And median PFS was found 12.3 months. Coming to safety results, so no treatment emergent adverse events, and which led to discontinuation of treatment, and this was over the 12 months of follow-up. So, and in incidence, coming to incidence of infusion or injection related reaction in patients treated with IV versus subcutaneous. So if we see all other DARA IV studies, that is GEN 501, GEN Pollux, Kester, Sirius. So POWER had the lowest IRR because it was given subcutaneous. So summary, DARA, we can conclude from this study that DARA enabled dosing over 3 to 5 minutes, and it was well tolerated. 16% IRR rate with DARA subcutaneous, while 45 to 56% IRR rates with DARA IV 16 milligram per kg, which has been traditionally given. And high clinical response rates continue to deepen with longer follow-up, that is 12.3 months PFS in all treated patients. From the findings of POWER phase 1 trial, the PLADUS was planned, and then Columba phase 3 study. Phase 3 trial was done, and the similar results were replicated in the phase 3 also. Where it is a non-inferiority, where 522 patients were divided into 263, 259 randomized group to receive subcutaneous and IV. Subcutaneous had flat 1800 milligram dose, while IV had 16 milligram per kg per dosing. The dosing schedule remains the same, that is once weekly for week 1 to 8. Once in 15 days for week 9 to 24, and after that, once in a month schedule until progression. We see the medial duration of infusion, that is 5 minutes, coming from hours, first infusion 7 hours of IV to 5 minutes as first, second, and third. Similar 5 minutes of infusion compared to hours of DARA IV. Co-primary endpoint was ORR, overall response rate in ITT population. So that we can see that it was comparable in both the groups, and overall response rates and depth of responses improved over the months. This was primary analysis of 7.5 months and updated was 13.7 months. So it was similar in both the groups. Co-primary endpoint. So coming to the pharmacokinetic data, that is concentration, C trough concentration, that is the lowest concentration of drug before the dosing. So C trough level was done on after the 8 doses of DARA, that is the day 1 of cycle 3. So, and that was found similar, that was the ratio of DARA subcutaneous to IV was 110%, which met the non-inferiority criteria. Key secondary efficacy endpoints, that is PFS and OS, can see the purple is IV and the chrome yellow is DARA subcutaneous. It was comparable between the treatment groups. Infusion-related reaction, as suggested in phase 1B, that was replicated, that 34% in IV versus 12% in subcutaneous group, giving odds ratio of 0.28, which was quite statistically significant. IRRs were mild and occurred primarily at first administration in both arms, grade 1, 2 with few grade 3 and no grade 4 and grade 5. So it was almost grade 1 and grade 2, which were manageable. Median time to onset of IRR was 1.5 hours for DARA IV and 3.6 hours for DARA subcutaneous, with majority occurring on day of first dose. So this events also, that is a finding that first dose had events. In coming to injection site reactions, so that was 7%, approximately 7% for subcutaneous patients, and all were grade 1 and 2, which were manageable. So IRR rate was significantly reduced with subcu, and no new IRRs or injection site reaction were reported with longer follow-up. And the same with the treatment emergent adverse events, other anemia, thrombocytopenia, neutropenia, URTI, nausea, dyspnea, they were all similar in both groups. So safety profile was comparable between subcutaneous and IV. Now coming to cancer therapy questionnaire, which gives a patient, which patient forms up. So DARA subcutaneous patients were more satisfied with their cancer therapy. That was chemotherapy, cancer therapy satisfaction questionnaire suggested that subcutaneous patient had a more satisfaction compared to IV group. So the conclusion made that it was well tolerated, shorter duration of action, maximum C trough level. So pharmacokinetics were matched of subcutaneous and IV. IRR were low. So those, and infusion over the minutes. So these were the conclusions from the study, and which was a favorable benefit risk profile of DARA 1800 milligram flat dose. Coming to its subgroup analysis, which was done across the body weight of the patient, a group that 65, less than 65 kg, 65 to 85 kg, and more than 85 kg, the same study, Columba. And ORR, so the response rate wasn't changed in different body groups. They were consistent across all body weight, that is less than 65%, and it was matching the male population also, total population ITT. Coming to concentration trough level, so they were in less than 65, the subcutaneous had little higher levels, and which also otherwise it was uniform across all body weight. So coming to this body weight subgroup safety analysis, so that high concentration led to some higher incidence of neutropenia in less than 65 patient of DARA subcutaneous group, but they were manageable, did not result a higher incidence of, so neutropenia were manageable and did not result in the infection. So that the overall, again, the safety was comparable between IV and subcutaneous. So summary as that the higher concentration of DARA subcutaneous in patients less than 65 kg did not have a clinically relevant effect on safety. suggesting no dose individualization is necessary on the basis of body weight, because it was non-inferior, safety and ORR was comparable. Now coming to this phase 2 Pleiades study, where daratumumab subcutaneous was tried with combinations, and also initial results of Dara subcu with in DKD cohort. So that was updated because Dara subcutaneous was given in place of Dara IV later on, and that was presented at ASH 2020. So I will not go through this detail as we have paucity of time. So Pavo and Columba were the main studies, and this Pleiades is a phase 2 study which compared the various combinations, and it was found that the ORR and response rate was the similar of its IV comparable IV trials. That were Alcyon, Kester, Pollux, Maya. So again, the safety was comparable, and overall this results provide additional support. So this were the phase 1, phase 2 and phase 3 studies of subcutaneous Dara. This is Apollo study, phase 3 randomized study of subcutaneous Dara, where DPD was compared to PD alone in patients with RRMM. So it is an open label randomized multi-center study where DPD versus PD divided, and in progression-free survival, median follow-up 16.9, PFS was found 12.4 months in DPD compared to 6.9 months. So addition of Dara subQ to PD improves PFS with a 37% reduction in the risk of progression or death. Apollo depth of response, if we check that DPD has a deepened responses and also the higher MRD negativity. So ORR more than VGPR rate, more than CR rate, and MRD negativity were significantly higher with DPD group, as we see in this bar, and MRD negativity setup. Apollo safety results. So again, there's not the most common serious events were pneumonia. For DPD, it was 15% versus 8% in PD, and lower respiratory tract infection were matchable 12% and 9%. IRRs were reported in 5% of patients in DPT group only. They were grade 1 and 2, which is matching up to the Dara subcutaneous pivotal trials. But only few patients get IRR. That also manageable. So conclusion from Apollo that it's a first phase 3 study of Dara subcutaneous combination therapy in multiple myeloma, and DPD reduces the risk of progression or death by 37%. We already saw, and achieved significantly deeper responses versus PD alone. So that is 6 times higher complete response rate and 4 times higher MRD negativity. DPD achieved longer PFS among patients who were refractory to LEN and had a manageable safety profile with the known safety profile of Dara FC and PD alone. The IRR were low and administration duration was short, thus increasing convenience for patients and decreasing treatment burden. Now, this Andromeda study, as I mentioned, that Dr. Ashutosh has taken in detail, so I would just skip this as also we are reaching the. So daratumumab subcutaneous was studied for amyloidosis, and because of the study, US FDA received approval of Dara for treatment in live-chain amyloidosis in the starting of this year. So this was a major trial. Coming to this, so these are the studies which we went through. That was phase 1 Pavo, phase 2 Pleiades, and phase 3 Columba for Dara subQ, and Apollo, which was the first combination trial, and Andromeda for light chain amyloidosis, newly diagnosed. So these are the Dara subcutaneous trial. Also, I would like to mention that Alcyon, Maya, all protocol amendment have been done due to COVID situation. All these trials have now recruiting patients with Dara subQ. So the further results will be seen with Dara subcutaneous in the ongoing newly diagnosed multiple myeloma trials with daratumumab, for which Dara IV is approved in India for the treatment of newly diagnosed multiple myeloma. Now, other ongoing phase 3 studies. So I heard a lot during Dr. Manju Sengar's presentation also for high-risk multiple myeloma and other sessions also, that which DARA regimen to use, because we have VMP, DARA VTD and VMP now, and we don't have DARA VRD studies. So that is all ongoing. CPS for transplant ineligible patients, where DARA subcutaneous plus VRD. Perseus is transplant eligible, where it will be given as induction and then consolidation and as maintenance. Auriga, that is for the DARA will be given as maintenance to check that NDMM who are MRD positive after frontline transplant. And Aquila trial, that is all for smoldering multiple myeloma. So all these trials have been so all upcoming trials, basically the summary is that upcoming trials are all done with daratumumab subcutaneous formulation. And these are the overview of those studies: CPS, Perseus, Auriga, and Aquila for smoldering multiple myeloma. So currently in India, daratumumab IV is approved as one prior line in treatment of RRMM and also for the newly diagnosed multiple myeloma. DARA subcutaneous is not approved yet, but there is a lot of upcoming data which is to consider. So thank you all for your patient listening, and any questions from the audience, or we can move ahead to Dr. Sagar Lonia's session.
Thank you very much, Dr. Dara.
Thank you, sir.
So our second speaker is Dr. Sagar Lonia, and his topic is where and how to place daratumumab in frontline myeloma management. Over to Sagar Lonia.
Hello, I'm Dr. Sagar Lonial from the Winship Cancer Institute of Emory University in Atlanta, Georgia, and I'd like to spend the next few moments really talking about the role of induction therapy in the management of patients with myeloma, choosing what is the optimal induction therapy, as well as discussions on potentially the incorporation of anti-CD38 antibodies in the management of patients with newly diagnosed myeloma. So let's start off really focusing a little bit on the new updated IMWG criteria for the diagnosis of multiple myeloma. And this, I think, is really important because unlike other diseases that require pathologic definitions of what it means to be malignant versus benign, in the context of plasma cell disorders, the International Myeloma Working Group together redefined what it meant to be myeloma about 6 years ago. And what we did was take the old definition, including the CRAB criteria, which really is evidence of end organ damage, and add to it 3 biomarker-driven criteria. And the real purpose of those biomarker-driven criteria is to identify patients at very high risk of progression and try and prevent the development of end organ damage. Those 3 criteria include 60% or more plasma cells in the marrow, serum free light chain ratio greater than 100, and more than 1 focal lesion as detected by MRI. And the real goal of that 3rd biomarker-driven criteria was to eliminate the use of skeletal survey as a way to identify patients with symptomatic versus smoldering myeloma. And I think that that's really important because most recently, the International Myeloma Working Group has basically said that skeletal survey is no longer an appropriate imaging test in patients where you're trying to understand the extent of bone involvement. The lowest level of technology that is now acceptable is low-dose whole-body CT scan. Next is whole-body MRI and PET scan. And I think the advantages of the modern imaging, particularly PET scans and MRIs, are that it's really exciting to think about the fact that you can pick up earlier bone disease and prevent the development of significant fractures or weakening of bone using modern imaging therapy. Now, one of the things that just drives me crazy is data from many, many papers that start off saying multiple myeloma is an incurable plasma cell disorder. And the reason that that drives me crazy is I think there are subsets of patients that we are curing with aggressive therapy. They tend to be good risk patients. They tend to be RISS stage 1. They tend to be patients with hyperdiploidy. But as you can see here, old Spanish data with 15-year follow-up suggests that among patients who achieve a complete remission with induction, high-dose therapy, and consolidation, there is a plateau on that curve at about 15 years. And what one would hope is that with longer follow-up and with modern drugs, we may actually be increasing this cure fraction of patients overall. But it is clear that for a majority of patients, they are not cured. And so maximizing the depth of response early and throughout therapy, I think, remains critically important. So what is the current state of the art for patients with newly diagnosed myeloma? Well, induction therapy for younger patients, I believe, is 3 drugs at least, followed by autotransplant in first response. Maximized response post-transplant, and that really is calling into question the role of consolidation. At our center, we actually don't use consolidation because with RVD induction, it's rare that you ever need to consolidate a patient or that there's any benefit for consolidation after transplant. Maintenance therapy after autotransplant, this I think is a must. Intensified maintenance in high risk, this is data that our group has pioneered and I think really has made a difference in outcomes for high risk patients. And then again, goals of treatment now trying to achieve MRD negativity. But I think it's an important subtle distinction to suggest that you want to give patients the treatment with the highest likelihood of inducing MRD negativity. But if you don't get there, it's not clear that changing treatment to try and get there really changes the natural history of that patient's disease. And that's being tested now in randomized trials, and I think will be an important question, but for now, we honestly don't know the answer. Now, one of the tenets that I think is really important in the context of myeloma is that combination therapy really is the answer. And as we look at response rates and complete remission rates early on with doublets, with old-fashioned single-agent dexamethasone, and that's what I would call VAD, it really is no better than single-agent dexamethasone, RVD, VTD, KRD, Carcyclodex, you can see that the response rate does in fact continue to go up. And the real question is, when you're adding a 4th drug, what is the best 4th drug? And I would argue the best 4th drug is not an alkylator. This was done in the Evolution trial a few years ago and demonstrated that the addition of cyclophosphamide did not really improve outcomes over RVD. More importantly, I think the addition of a 4th drug as a monoclonal antibody with non-cross-reactive toxicity probably has a much higher chance of offering benefit to patients in the long term. Now, what established the role of triplets in the context of myeloma? Well, as I told you in our group, we've been using triplet-based therapy for over 15 years with RVD being our standard induction regimen. This actually was the SWOG 777 trial that tested RVD versus lenalidomide and dexamethasone. And I don't really think it's a surprise to see that the progression-free survival was greater with a triplet than with a doublet. What I think was a surprise was the improvement in overall survival. And I'll tell you that I think a lot of this difference in overall survival is probably due to the triplet versus the doublet, but also maybe due to the fact that these patients did not get high-dose therapy consolidation. And if you look at the median progression-free survival, it's pretty short here compared to what we would expect with modern therapy, what we would anticipate with modern therapy. And I'm going to show you median progression-free survivals for our RVD 1000 series at the end of this talk, and you can look at that to make a decision on whether or not you think transplant continues to have a role in the management of patients with newly diagnosed myeloma. Now, there was a push a few years ago to look at KRD replacing VRD. Carfilzomib is a proteasome inhibitor that at higher doses is likely more potent, has less peripheral neuropathy, but does have a different adverse event profile, does have a little bit more cardiopulmonary toxicity, hypertension, renal insufficiency. Those tend to be transient and can be managed, but certainly is something to be considered. And what I think you'll notice here is that in small phase 2 studies, both from the NCI and from the University of Chicago, there was a suggestion that the VGPR or better rate, the CR or better rate was higher. And this to me spoke to the concept that small phase 2 trials are good hypothesis generating trials, but whether or not they pan out in terms of long-term outcomes really needs to be tested in randomized phase 3 trials. I will point out, because I don't have time to really mention the Forte trial in this talk, that there was a push to say that KRD was so good that you didn't even need a transplant. And this was a 3-arm randomized trial comparing KRD transplant versus KRD versus KCD. And what I think is really important about this trial, what we learned was that while the response rates may be similar between KRD with and without transplants, the MRD negative rates are actually higher with transplant. And more importantly, the sustained MRD negative rates are higher with KRD and transplant. So you can give KRD, just know that even though you may achieve a higher response rate, it's slightly higher. It's not significantly higher. The durability of that response rate is not the same. And I think that that continues to demonstrate the benefit of transplant even with modern drugs. Now, the Endurance trial tested that hypothesis that KRD may be better than BRD. And it's important to recognize 2 specific caveats of the Endurance trial. The first is these were only standard risk patients. And so that was what the ECOG trial really enrolled only. So the conclusions of the Endurance trial can really only be generalized to patients who had standard risk myeloma. The second is that these patients also were not offered transplant, which again, I think is a major weakness, but is a limitation of many trials that we do in the cooperative groups in the United States. And so again, there were 2 weaknesses in this trial: no transplant and only standard risk. What you see from the Endurance trial, however, is that there was absolutely no difference in progression-free survival. And if you look at patients who were censored for going on to transplant, again, no difference in progression-free survival. If you look at patients who were censored because they had to come off from adverse events, no difference in progression-free survival. No matter how you look at this data, there is absolutely no difference between BRD and KRD. And I think, again, the conclusion is that while KRD may look better in small phase 2 studies at single institutions, in a randomized phase 3 trial, it did not result in significantly better outcomes than what we see with VRD. And the main reason is you had offsetting adverse events. So if you look at the Endurance trial for KRD, again, cardiac, pulmonary, and renal did happen more frequently, was more grade 3, grade 4 cardiac, pulmonary, and renal toxicity. If you looked at VRD, you saw more peripheral neuropathy. Neither of these are really surprises, but they accounted for why you might potentially lose potential benefit in PFS by some of these adverse events. And there are many of my colleagues who say, I'd rather have cardiopulmonary toxicity than neuropathy. I think those are debatable. Patients that develop significant cardiopulmonary toxicity may not be able to go on and get consolidation with transplant. They may not be able to go on and continue therapy with KRD, ultimately limiting the efficacy and utility of that KRD induction. And the same can be said for VRD and peripheral neuropathy. Now, in order to try and move forward from a triplet-based regimen, there certainly is excitement about including daratumumab into the mix. And this was the Cassiopeia trial, which I think was one of the first trials to really evaluate the role of DARA plus a standard regimen in induction, consolidation, and in maintenance. And so what this trial really did was randomize patients to VTD, DARA, VTD, DARA consolidation, and DARA monotherapy in the maintenance, versus VTD, transplant, and VTD, and no maintenance therapy. And I will tell you, this to me is the major weakness of the Cassiopeia trial. No matter how you look at it, when the curves begin to separate, they separate at the time of this second randomization of DARA versus observation. And this to me is a little troubling because I think it's harder to really isolate the effect of DARA early on when you have this confounding second randomization so early in the process. And again, if you look at it, this is the progression-free survival difference favoring the DARA VTD arm. The curves again begin to separate right at 9 months when patients were randomized to DARA versus observation. So I really have trouble drawing conclusions about PFS from this trial. However, I do think it's clear that the depth of response, overall response, and MRD negativity is higher with DARA VTD than it is with VTD. And that to me is the main take-home message, that by adding in DARA early on, you're able to deepen responses, and we hope that that will translate into better progression-free survival. It's just going to take a different trial to really answer that question. I don't think this trial can really answer that question. Now, the trial that may be able to answer that question is the Griffin study. And the Griffin study is a randomized phase 2 study of DARA VRD, VRD consolidation with DARA, and DARA-R in maintenance versus VRD, transplant, VRD, and R in maintenance. So this to me is a more balanced trial. It's a fairer trial to really ask the question about the impact of DARA all throughout the treatment, as opposed to standard treatment with induction and consolidation. And what you'll see here again is what I showed you with DARA BTD. Depth of response clearly better. MRD, CR, all the right endpoints are clearly higher with the use of DARA compared to the groups that did not receive DARA. And while it looks like the curves are beginning to separate at 2 years, again, it's relatively early, small data set, but this fits more with a modern induction progression-free survival than what I showed you in the Cassiopeia trial. And for that reason, I think this is more likely to give us data that will answer the question. And in fact, the randomized phase 3 Perseus trial that did basically the same thing, but in a larger number of patients, will hopefully ultimately answer the question as well. My suspicion is you're not going to see big differences in PFS until you're 3 or 4 years out. That's my suspicion. Let's see what happens with longer follow-up here and with data from the Perseus study. Now, what about looking again at the SWOG study to look specifically at patients not intended for transplant? Again, these are the 2 PFS curves that I showed you before. These are the patients not intending to proceed to transplant. And in fact, I think that that is a very important regimen. But one of the challenges of giving RVD in a truly frail patient population is the toxicity. And so RVD Light was created to really look at weekly dosing of bortezomib, lower dose of len, lower dose of dexamethasone. And this is data from a small phase 2 study from Elizabeth O'Donnell and her colleagues at MGH, where they really demonstrated that RVD Light was an effective regimen. Median progression-free survival is somewhere around 30 months. Again, it's a small study. And for me, the challenge with this dose and schedule is that it's a 5-week schedule. I have trouble using a 5-week schedule. So our version of modified RVD is weekly bortezomib, day 1, 8, and 15. We use lenalidomide 15, days 1 through 21. We use dexamethasone weekly, and we change it to a 28-day cycle instead of a 25-day cycle, or instead of a 35-day cycle. And that makes it a lot easier for us to track. It makes it a lot easier for the patients to track. And I think the responses are likely somewhat similar. Now, what about incorporating DARA into newly diagnosed transplant-ineligible patients? This is data from the Alcyone trial looking at DARA plus VMP. And what they demonstrated, again, was a significant improvement in progression-free survival. In the US, this does not have a lot of traction because VMP is not a regimen that most people use. I don't know if in your centers you use a lot of VMP. If you do, this clearly supports the addition of daratumumab to VMP in that context. And more importantly, if you begin to look at longer follow-up with overall survival as an endpoint, what you'll see here is that the addition of DARA to VMP has an improvement in overall survival. So I think to me, this really is a matter of whether or not this is a regimen that gets significant use in your center. And if the answer is yes, then this is certainly a potential option to consider. But at our center, this does not really get a lot of use, so we don't use this DARA VMP-based regimen for newly diagnosed myeloma. We do, however, use DARA RD. And this to me really is an important regimen. And this is based on the phase 3 MAIA study. And what you see in the MAIA study, again, is DARA Lendex versus Lendex, 737 randomized patients, simple therapy. We know Lendex is a good treatment for patients who are frail and transplant ineligible. And what you see with 48-month follow-up now is 60% are still in remission compared to only 38% with Lendex. And the Lendex arm performed similar to what we saw in the first trial or other clinical trials looking at lenalidomide and dexamethasone in this context. And this, to me, I think is really important. If you look at adverse events, again, you'll see slightly higher in the areas where one might expect it in terms of neutropenia having a slightly higher incidence, anemia, slightly higher incidence of infectious complications, not really a big surprise across the board, and responses and depth of responses clearly higher with the addition of DARA in this context. So for us, DARA Lendex has become a standard go-to for the management of patients with newly diagnosed myeloma. And I think if you really go back to what I said in the beginning, looking at early responses and looking at durability based on depth of response is really important. If you look at patients with MAIA who were MRD negative for greater than 12 months, their progression-free survival is really quite striking. If you look at patients who were not MRD negative for greater than 12 months, it's pretty good too. If you look at DARA, Lendex, or Lendex for patients who are MRD positive, it's still pretty good. It's not as good as these two curves up here, but it still is a pretty good curve overall, suggesting MRD negativity can offer prognostically significantly better outcomes for patients across the board. So again, I think in conclusion, myeloma is rapidly changing with new drugs and targets approved all the time. The treatment paradigm may evolve to more personalized care. We're working on that. The role of cell therapy, particularly CAR T cells, is unknown. Given the short PFS in the refractory setting, we need to understand how much antigen you need for CARs to have an activity later on. And then again, there is room for more than one agent targeting a target. And what I mean by that is, you may be able to use CD38 and BCMA early on. That will certainly be interesting. And combinations of these in the long term and the short term, I think will be really important as we consider how to move forward to ultimately cure patients with myeloma. I don't want to leave you with what I think is the current benchmark for outcomes in patients with newly diagnosed myeloma. This is our RVD 1000 series, published last year in JCO. And what you'll see here is median progression-free survival for standard risk myeloma is around 76 months. That's one of the longest PFSs ever reported for newly diagnosed myeloma. This is 1,000 newly diagnosed patients followed over time. They all received RVD induction, single transplant, and risk-adapted maintenance. And more importantly, if you look at median overall survival, with a follow-up of 8 to 10 years, the median overall survival has not been reached for that group in aggregate. And this, to me, is the goal of effective induction, consolidation, and risk-adapted maintenance to really try and improve outcomes for patients across the board. And if you look at what our current algorithm is at Emory for treating these patients, you can see here eligible versus ineligible. Standard risk, we are incorporating DARA with RVD as our standard. For high risk, we are still using KRD. We're trying to evaluate whether we want to continue that. And for standard risk and the ineligible, you'll see RD DARA has become our standard. For the high risk, RVD Light has become our standard, and then risk adapted maintenance across the board. So what I think you'll see here overall, again, is really exciting data incorporating CD38 antibodies. I think it probably is ready for prime time. And the question is, how do we maximize benefit of that first remission to ultimately increase the fraction of patients that we're curing over time? And that's something I think we need to continue to study and evaluate as we go forward. So thank you again for your attention. I'm sorry I can't be with you at this important meeting, but hope you have a great meeting and look forward to seeing you hopefully in the next year.
So thank you, Dr. Sagar. Next, we have a panel discussion. Next, we have a panel discussion, and the moderator for the panel is Professor Pankaj Malhotra. Dr. Pankaj, Professor Pankaj?
Yes, good evening, I'm there.
Yes. Sir, we have Bahu Sahib Bagal with us and Professor Lalit with us.
Okay, so Dr. Sagar is not joining, and Dr. Anupam is not joined yet. So can we find out whether he's joining?
Yeah, we are contacting him. You can start with the discussion.
Okay. So good evening, everybody. Good evening, sir, Dr. Lalit Kumar, and good evening, Dr. Bausa.
Hi, Pankaj. Good evening.
Good evening, sir.
So, can you see the slides? Can you see the slides, please?
Yes.
Okay.
Yes, sir.
Yeah.
So, so the panel discussion actually is redefining myeloma management in newly diagnosed multiple myeloma and transplant eligible patients. So, although Dr. Sagar has discussed the management of newly diagnosed patients very well, and he has discussed the role of antibody when you add to the triple regimen, but some of those questions which we generally we face challenges or we face problems in our setup, I think that's what we are going to discuss. And actually, I'm very happy that Professor Lalit Kumar is there, who has the largest experience of treating multiple myeloma in India and the maximum publications on myeloma in India. So I think he's the one of the most experienced and best person to answer most questions, and the kind of a practice actually which from his experience we can learn the kind of a practice which we can do in India. And Dr. Bhau Saab in Tata Memorial is looking after a lot of myeloma patients. So again, a view from the largest cancer center in India, we can have the views from there. And I will also take my chairperson and other people who are there to chip in between. I can see Dr. Subhash Verma and Dr. Tapan Sekia. So maybe Dr. Tapan and Dr. Verma, sir.
I am backbencher today.
So I will not ask you. So what I will do is I will not ask the question. I will ask Dr. Lalit to ask the question to you, which I know you will not refuse.
Okay.
So we can say, I don't know. Lalit will answer.
Sir.
All right. So
we have a lot of bright people like Bhausa is there, so don't worry, sir.
So, okay. So we will discuss about a case history of a 60-year-old gentleman who is newly diagnosed multiple myeloma, and he has 414 translocation and RISS3, and in the CRAB features he has anemia and bone lesion, PSS1. So this is kind of a typical patient which we see in the outpatient. So what are the choice of regimens which you use? So first I will ask Dr. Bhau Saab, DRVD, RVD, VCD, or any other regimen. So what is your practice? So first we will discuss that if the patient has the affordability and he's transplant eligible. So what do you do for this patient?
Yes, sir. So I'll start with our current practice. Our current practice is to do induction with RVD and collect the stem cells after 4 to 6 cycle when we have at least CR or VGPR in these patients. And after that, we generally tend to consider for a transplant in the first remission itself, given the logistic issues with storing of stem cells, etc. And that is our practice. So there are different options as you are listed, sir. And definitely VCD was our previous standard. We used it for quite some time. But as all of us know that VCD has been shown to be inferior to RVD in randomized studies, and we have moved on. And that's why our choice is currently RVD. We are aware of the data with DARA RVD, sir, and DARA RVD routinely for all our patients for this thing, for the simple reason that with this treatment schema of RVD followed by transplant and followed by a maintenance schema, we are yet to see a good evidence of benefit in terms of PFS or for that, and forget about overall survival. So that has not been really our regimen of choice. And VTD, we don't use it, and we have issues with neuropathy in our patients, so that's not our induction regimen of choice.
Right. So in majority of these patients, you will follow the RVD regimen, and you don't follow addition of DARA to the induction regimen, which is fair enough. So right now it is not the routine policy of adding DARA. That's what I can gather from you.
Yes,
right?
sir. Yes.
Okay. And okay, we go to Dr. Lalit, sir.
I think I agree. Bhausa is very nicely summarized. So BRD probably still the standard for us also, and we have the maximum experience with this only. And daratumumab, unfortunately, because of the cost, we are not able to use it as a first line. We have very limited experience of maybe less than 15 patients, that too mainly for the recurrent or as a salvage. So I really cannot say that we bind therapy so far, honestly. So that is one. So after the same, as he said, we 4 to 6 cycles, and then we'll follow with the maintenance, transplant, and then maintenance.
Okay, so this is both Tata and AIIMS are kind of a government or a semi-government setup. So what happens in the private sector? I think Dr. Tapan Sekia can put a great light. Dr. Tapan Sekia as well as Dr. Verma.
I think almost exclusively we use IVD.
Right. So no DARA into the regimen.
Extremely difficult
Extremely
in our situation. Yes.
Pankaj,
Only
actually,
relapse or refractory situations we have used few patients, like Dr. Lalit said, maybe we have 8-10 patients. That's all.
So one of the problems are is this, that daratumumab, I mean, the regime itself, like every week for first 8 weeks, then 2 weekly. I mean, this is like this is still not very convenient and especially
comfortable for the patient as well as for the yes.
So, I mean, apart
right,
from
and right. So yes, I think you are right, sir. In most of the centers, I would say almost 90-95% of the centers, is the RVD, which is kind of a standard treatment. Even I know from in the Max, Rahul Rathani actually used a lot of VCD as the first line regimen because they are more comfortable, and VCD is more gentle regimen on patients. So their first line treatment is VCD rather than RVD or VRD kind of a regimen, right?
We will use only with the renal impairment, not otherwise.
Right, sir. Sir, Dr. Verma, sir, any inputs or anything?
So my first choice is RVD, and if it's a renal failure, then VCD.
Right. Okay, so this we have discussed DARA for all. So in our Indian setup, one obviously is the cost of therapy. The second is as Dr. Lalit sir mentioned, that weekly regimen and for 8 weeks and then once in 2 weeks. This kind of many patients they do not they are not comfortable with this kind of a regimen. So
I would say this is not
addition
still
of DARA
user-friendly.
in yes. So maybe when subcutaneous DARA is available, that may be more user friendly.
Right.
Right, sir. So okay, so this patient received DARA RVD regimen because he was kind of considered as a high risk. 414 is kind of a thing which some people consider as high risk, some consider as intermediate risk, and some consider as standard risk. So so one of the question I think which is commonly asked is why we always say 4 cycles, 4 to 6 cycles. Why not only 1 cycle or 2 cycles? So that is sometimes the question is asked by the residents. Why is there any kind of a randomized trial which has shown that 4 cycles are better than 2 cycles or 6 cycles are better than 4 cycles? So what is the theory behind this? Dr. Bhausab, if I can ask you first.
Yeah, I think, sir, the general philosophy is to get the maximum cytoreduction before you collect the stem cell. In my opinion, it has nothing to do with the contamination of the stem cell product with the malignant plasma cell, but it is just that you have cytoreduced the patient. You have initial issues because of the disease which are controlled, and you are better able to do that. And as I said earlier, sir, our policy is not to stick to the strict number, but get a patient into CR or VGPR, so whether it is 4 cycles or 6 cycles. And as you rightly pointed out, there is hardly any data to guide us on the number of cycles before transplant. I think 2 studies which did that was Myeloma 11, where they changed the treatment of the patient if the patient had less than VGPR after 3 cycles. But I think this is the thought process behind our policy of giving 4 to 6 cycles, sir.
Right. Lalit sir?
Yeah, actually, Pankaj, this depends on the from country to country. For example, the US, where the insurance-based system is there, they generally will take the people for transplant after the 4 cycles. Or maybe the insurance company will not probably reimburse the extra money. In Europe, generally they give up to 6 cycles. That is the generally principle. For example, in our country, for example, even if you have the best center, any center you can get, which is suppose you have all the facilities, this patients, because there is no insurance system and patients have to really make so much of arrangements, logistic issues. Even if I have achieved the CR at the end of 4 or 6 cycles, for example, and if I start counseling from the 4th cycle onwards that we will need a transplant, he had to make or arrange or for his children, for his family, that somebody had to come with him to stay with him. So many times, like it takes like a couple of months actually before they can go for transplant. So therefore, like generally 4 to 6 cycles. And secondly, how it came probably from the hematologic means like Hodgkin's lymphoma, where people felt that like after 3 or 4 cycles, you achieve a good PR, then you give 2 more additional, and then you finally that become like 6 plus minus 2 cycles. Something similar to that. So generally, most people nowadays prefer giving 6 cycles of whether you use any of these regimes. So that is the generally, and plus about response, what we have seen like at the end of 4 cycles, and then if you continue, there is a further increment in at least 10 to 15% of patients who can progress, who can improve from PR to BGPR or from BGPR to CR, at least 10 to 15% patients.
Right.
So the response continues to happen.
Yeah. No, I think, sir, you have made a very, very important point that even though theoretically we discuss a transplant after 4 cycles or 6 cycles, but I think 90% of our patients actually get transplant after 8 cycles or 10 cycles, kind of a thing. We start counseling from 2nd cycle onwards. But as you said, they have to make a lot of logistic arrangements, supportive therapy and other things. And then, many times even we have all the transplant centers have a waiting list. So it is, very rare that, you see that patient is undergoing transplant after 4 cycles of RVD or DARA RVD or 6 cycles. The same is experienced at PGI also, that, the median time when these patients undergo transplant is something like 7 to varies from 7-8 months to 10 months or so. Dr. Tapan Sekia, any experience, anything you want to add here?
No, it's similar because of the situations. Most of the time, people do go beyond 4 cycles. We all do realize this 4 cycles are optimum from viewpoints of response as well as toxicity management. So I think it's similar everywhere in the country.
Right. Okay. So,
in fact, Pankaj, I would like to just add one point here.
Yes, sir.
Earlier, like when there was some publication that prolonging lenalidomide beyond 6 cycles can jeopardize your stem cell quality. But then now after the Plerixafor has come, I think that issue is really not a major issue, at least I would say that.
Yes, sir. I think very, very important point, sir. Again, this is again the same experience that, many people say that you stop lenalidomide after 4 cycles or 6 cycles and change that. We have not changed that. And we have kind of never faced a problem in mobilization. Recently, because of the COVID, we did one transplant where the patient actually received 11 cycles of DARA RVD, and she was still able to mobilize. So Dr. Lalit sir has made a very important point that even if you are continuing with lenalidomide, and previously we were thinking that this will probably compromise the stem cell collection. In our experience, we have not seen that, and same experience as Dr. Lalit said. Dr. Tapan sir, you have any experience if the lenalidomide is continued?
Exactly same. But a question might come up that what dose of lenalidomide you have been using. That's the thing, some people dose you have 25 right from the beginning. They might raise the questions that for, but I completely agree with plerixafor. People those who have at 25 milligram from cycle 1 onwards, or starting with 15, slowly increasing up to 25. So far, we haven't had that problem with any of the myeloma cases.
That's a very important point. And Dr. Bhausab, you have faced any kind of a problem or continuing
No,
with
sir.
the RVD?
So as you said, sir, the collection often get delayed even in our center, and usually it happens after 7 or 8 cycles only. And our experience with this collection has been good. Means we don't have any problem. But as Lalit sir said, maybe it's because of the ease or whatever. Our ease of plerixafor has gone up, and probably the chemomobilization has come down, and probably this has nothing to do with the RVD, but it is probably ease of collection.
Right. So it is kind of a very reassuring to me also, because after 4 cycles it is always a guilt kind of a feeling which starts coming in you that you are continuing lenalidomide after 4 cycles. So listening to Dr. Lalit sir, Dr. Tapan Sekia sir, and Dr. Bhausab, it is reassuring that we both in most of the centers people are continuing lenalidomide. So Dr. Lalit sir, as Dr. Tapan said that sometimes you do reduce the dose of lenalidomide. So what is your view on that?
Yeah, initially actually we did the studies on the induction therapy, because as per the protocol, so that time we had kept like we will assess the response at the end of 4 cycles. So that time we were using like 25 milligram daily for 21 days. But then in some studies, some patients we have used the 15 milligram also, that like RD light, what you call it, 15 milligram for. But now as a standard practice, like we use 25 milligram daily for 21 days, or except the people who are like little performance status wise look like that they are little 2 or 2+ kind of thing. So there, in the first cycle, we'll start with the 15, and if they are okay after the end of the 4 weeks, then we'll probably make it back to the 25 mg. So that is the only thing. So of course the other things like kidney function, everything else is okay. So that is practice. And after 4 to 6 cycles, then sometime like we may probably reduce the dose to the 15 milligram or 10 milligram also. So
right. Yes, I think the same practice, we also do the same practice that after 4 to 6 cycles, if there is a CR kind of a thing, so many times we reduce both DEXA from 40 to 20, as well as lenalidomide from 25 to 15 or 10 milligram sometimes. So,
right. Pankaj?
Yes, sir.
I love Vincent Rajkumar. I'm almost a blind follower of him.
We all love, sir. We all love Dr. Vincent Rajkumar.
The reason I bring him up here, he has been saying in meetings time and again that he said, I treat a huge number of Indian patients. He said, I've never used more than 15 milligram in any Indian patients. He said, for you, 15 is good enough. So we as a whole in the department stick to 15 as much as possible. Sometimes people come with a second opinion with 25. I said, let's try and see if they tolerate fine. But seems to be 15 for us most of the time. Right or wrong?
Right.
It's Vincent
I think
who has convinced.
No, I think, sir, you have made an important point. I think if I look at, 100 patients who are on RVD, and I would feel that almost 60 to 70% patient would be on 15 milligram only, because very few patients tolerate 25 milligram, in our setting. One of the problem which we face is, many patients develop skin rash or some toxicity, and we actually have to reduce the dose of lenalidomide in majority of them. So you are right, sir. You are right. Anybody else wants to make any comment on the dose of lenalidomide or toxicity of lenalidomide?
I think lenalidomide sensitivity to the skin, the dermatological complications can happen with 10, 15 or 25. So I'm not sure whether the dose is important from that point of view. And most patients generally, like if you stop and then restart alternative, generally they are able to develop the adaptation and they are able to tolerate. Rarely some patient really will have difficulty, there you have to stop and change the drug. So that is the kind of
yeah. So in some patients, we have seen that if they develop toxicity, we stop. Yeah. Sir, please go on.
Actually, one of the reasons are in our country, patients come from very far off, from peripheral center to coming to major centers. By the time they come, there is a long interval. If you ask the duration of symptoms, the median duration of symptoms is generally 6 months plus. So the performance results, even they were in good shape when somebody could have diagnosed that time, say 3 months, because I have seen in AIMS itself, they come to orthopedics because it considers backache. So it takes like from appointment to getting investigation, and they will ask for PET scan, and PET scan usually will take 1 to 2 months time, and they will keep on going and going. Finally, somebody, right resident will think this, let us do serum electrophoresis. And fortunately, if it comes positive, then it will refer to us. So it takes roughly about even AIMS, I would say 6 to 8 weeks to reach to the medical oncology. So that is the probably reason that performance does dip down. And if you could have really got the people in the, especially Manjuba is making a point today, like the 58 years for us is like equal to 65 years for the US people. And that she's showing that one of the graph slide, which I really like that. So it looks like that one of the reasons that why we have the people with the not so physically in a shape like what people in the US, is probably maybe our health system is still not, I mean, still have to develop it.
Sir, again, your point is reassuring, sir, that, same thing, patients come here and it takes, they keep on, going into the OPDs and, on OPD follow-up, and sometimes the diagnosis is delayed. Okay, so there are some audience question also. One question is pyrexia due to lenalidomide. Anybody has seen that?
I think it's very rare. I have seen one patient is actually father of one of the resident actually. So we stopped everything, and then finally the fever responded after we stopped the lenalidomide. But that is, and then we saw the literature. There have been few cases have been reported, but this is not the routine. I mean, usual. It's not a major cause. But yes, it is described. Actually.
Rarely it can happen.
Yeah,
yes.
And it's more commonly described with pomalidomide, sir. And we recently had a case also. So
okay,
that's one thing.
Okay. Thanks for that information. So the other audience question is, sir, in our center, it is very difficult to go up to 25 because of cytopenia. What is the minimum dose we can give? So that has been said, 10 milligram. Our patient tolerate thalidomide better. Any comments on that is using VTD? Dr. Lalit, sir,
actually we
use
have,
of VTD.
We have used actually, especially the patient who come with the renal failure. So like in the BTD, I start with the 50 milligram if they have the renal insufficiency in those cases. And then, I mean, the VCD, of course, is one of the better choice. And then other choice is the BTD. So start with the 50 mg and then go maximum 100 mg. Initially we did the like almost 10 years back, one study, thalidomide, Theldexa versus Lendexa. And we started with the protocol like from the US data, 200 mg. After 10 or 15 patients, they really had terrible time, totally drowsy, like they will not wake up and all that. So finally we reduced it to 100 mg, and which we continued. And in fact, and after 4 to 6 cycles, if you give, generally neuropathy is not the major issue, except few patients who are diabetic and the diabetes is under control, then the neuropathy is manageable. And then obviously you have to, after the beyond 6 cycle, you have to proactively ask for the neuropathy, and then you have to reduce the dose or stop sort of thing before it becomes difficult. So thalidomide, I would say 50 to 100 mg, and if it normal renal function, good general condition, start with 100 mg, and that is probably the optimum for us.
Right. Thank you. Yeah. So I think the use of BTD is only because of the fear of neuropathy. Both bortezomib and thalidomide can cause neuropathy. But as Dr. Lalit sir rightly said, that if you use a lower dose and if you are proactive in asking questions about neuropathy, BTD again is a good regimen, and you can use that. There are
also
a few
compared to lenalidomide. It's a cheap because thalidomide, 50 mg about 30 rupees and 100 mg is about nearly 55 or something. So compared to like lenalidomide, cost will be like almost I would say probably 10 times roughly compared to 1 month of thalidomide.
Yes. Yeah, lenalidomide 25 milligram would be something like 25,000 or so, and whereas 100 milligram of this would be 3,000 or so. So this is okay. There are some other audience question. I think they have been answered. This is actually on DARA from Dr. Neha Ganju about where do you prefer DARA combination in newly diagnosed multiple myeloma. That has been said that in India, even if it is high risk, most centers are not using that. And what are the indications for DARA as monotherapy? I don't think so. Upfront, DARA as monotherapy is used. And in what subset of patients do you give consolidation therapy? That we will come after, we discuss about the management of this patient. Okay, so we go further in this response before auto transplant. So this is another question which is asked, that do you want a PR, VGPR, CR, stringent CR, or MRD negative status? Where are you comfortable, or it doesn't matter any response before auto transplant? Dr. Bhausa?
Yes, sir. As we discussed earlier, sir, we try and get a good depth of response CR or VGPR, and that is with the thought process that our patient would be stabilized, the collection would be adequate, and the pre-transplant response correlate with the long-term outcome. But whether trying and changing the management so as to get the CR, VGPR, whether it leads to better outcome, which we don't know. As I alluded to the myeloma 11 study, where they tried improving the response by addition of bortezomib in patient with PR or less, and they could get on to the improvement of response. So that is one study I can remember where they tried to get a better response before transplant, and that's the practice in our center, sir.
Okay. Dr. Lalit sir, any
I think I agree what Bhausa had said, that like you just check the serum electrophoresis M protein report, and gradually it has been coming down. Like suppose at the end of 6 cycles, then you probably make give another 1 or 2 more cycles. Or if the patient, I mean, normally like everybody will get the bortezomib, so as a part of ERD or BTD or VCD. So only thing like in patient who is getting BCD, in those cases you may like to give probably change to the lenalidomide in place of cyclophosphamide. So if everything else is okay, so like suppose somebody has got a only PR at the end of 4 cycles, then you really want to would have been gone into the VGPR or CR, would have been more comfortable. So that is a little sort of sometime we have done that. So I think so I would say in the summary, like CR is always the best which you want, or VGPR probably. So CR or VGPR probably the best before you take for transplant, but up to PR is fine. So below that, even stable disease, people have been doing transplant. We have done progressive disease. Certainly, we should avoid doing transplant because the results are really not satisfactory, and most people relapse within a year or so.
Right. There is an audience question here. Is there any way to differentiate BOTI-induced neuropathy versus thalidomide-induced neuropathy? This is for Dr. Lalit sir.
Yeah, symptom-wise, like for example, bortezomib neuropathy typically like so burning sensation in the soles generally, the feet, and so like if you are asking why thalidomide, generally patients will have more of numbness and paresthesia. But if you do the otherwise like nerve conduction velocity or something people have been getting for 4 or 6 months, and sometimes they could be a little mixed up, then you may have little difficulty. But typically the bortezomib neuropathy patient, they will cry of the pain that is so burning, like they just have kept their foot on the hot sand. or something like that. So that means this is like I mean, there are some objective ways also, but that's what symptom-wise people will generally come. So you just stop the bortezomib or take the guidelines. There are guidelines, like reduce the dose or make it or stop depending on the severity of neuropathy. And then generally 70–80% is generally significant improvement in 2 months or 2.5 months time, at least perceptible.
Right. Thank you, sir. I just got the message that Dr. Vincent Rajkumar has joined. So welcome, Dr. Vincent, to the Myeloma Congress. We were just discussing about the dose of lenalidomide just before you joined, and about 25 milligram, 20 milligram, 15 milligram upfront in newly diagnosed patients of multiple myeloma when we are using RVD as the regimen. So the general consensus was that most patients do not tolerate 25 milligram, and in majority of these patients we used 15 milligram or 20 milligram. So any opinion, any feedback on that?
Well, thanks for having me, and it's really great to be on this panel. I do agree with you that from what I've heard, mainly from folks like you, that in India, 25 milligrams does not seem to be the right dose. Whether it's due to the exact population genetics, or whether it's due to the body mass index, I'm not sure, but certainly 25 seems to be too high. So the doses that you're currently using, I would completely support.
Right. Thank you so much. Thank you so much. So coming from you is reassuring for all the audience, the students who are listening to this panel discussion. And so we were just discussing about
neuropathy.
The neuropathy, whether anything which can differentiate whether it is thalidomide induced neuropathy or bortezomib induced neuropathy, patients who are on VTD therapy. And Dr. Lalit was just discussing about how to differentiate and how do we practically manage these patients. So anything to add there?
No. I think Dr. Lalit just summarized it nicely. It is very difficult to differentiate the two. The best treatment for these neuropathies is to try and prevent this in the first place. And generally by using the lower dose of thalidomide, like you already suggested, and by using bortezomib once weekly subcutaneously, we find that the risk can be reduced quite nicely. So it's keeping an eye out for this, and then dose modification, even from the outset with the once weekly sub-Q is what we are using for Velcade. And then for thalidomide, like you said, please don't go beyond like 200 milligrams is enough.
Right. Thank you for this input. We are actually getting a lot of audience questions here. So I think which are important to address. So somebody has the question, will substitution with pomalidomide help in case of phlegm-induced rash? So we were discussing that some patients do develop skin rash because of lenalidomide. And even if you dose reduce, so they still have that rash. So what do you do? So one is choice is to replace lenalidomide with either thalidomide or pomalidomide. So any experience in that, Dr. Lalit, would you like to comment on that?
We have not really done that, but we have used the pomalidomide as one of the study which we are doing right now. So some patients can develop the skin rash with the pomalidomide also. And since they are from the same class of drugs, so I would expect that that should be possible. I mean, whether percentage wise, I don't know whether it's like what is the frequency wise, but we have seen at least 2-3 patients with the pomalidomide grade 1 or grade 2 skin toxicity.
Right, sir. Thank you. Lot of audience questions again are coming back to the same point which we have.
Any suggestions about this? Whether can you replace pomalidomide with lenalidomide? Vincent?
Yeah, the rash with these drugs, I remember going back with thalidomide, we were among the first to report this problem, and it can be quite severe. But except for these very severe Stevens-Johnson's TEN type of rashes, the other ones, we do try to see if we can switch the IMID, because the IMIDs are such an important component of therapy. You don't want to just not use them. So if you have significant grade 1, 2 rash problems with one IMID, then trying another one with a modified dose may be reasonable. Sometimes we do find that pomalidomide works better, but from what I heard from people in India, doctors in India, is that in your experience, pomalidomide seems to have more complications, and I'm not sure whether they're, side effects, and I'm not sure if that's just because of the time stage in which you're using or it's real.
Right. Yeah, thank you. So, so there are a lot of audience questions, although we have discussed this question, but at least there are 5 audience questions on the use of daratumumab upfront. So Dr. Vincent, before you joined, we were just discussing the regimen for newly diagnosed patients. So, and in India, it's 99% is RVD kind of a regimen, and DARA is rarely used. One is obviously the cost issue. And second, as Dr. Lalit said, that it is the regimen is kind of uncomfortable for the patients, but most important is the cost issue. But again, there are 5 audience question on the same, that if cost is not a factor, would you add DARA upfront in these patients? So maybe you have joined now, so if you can give little bit suggestion on use of DARA upfront along with RVD.
Right, this is a great question, and I'll give you my unbiased answer. We, even at the Mayo Clinic, we have in our algorithm, you can use either VRD or DARA-RD. But personally, when I am giving talks and in my own practice, and after looking at all the data, I still prefer VRD for all my patients. It's very difficult to compare the VRD randomized trial with the Maya trial, because when you use VRD, what you're doing is you're using a triplet for 6 months or so, 6 to 7 months, and then you are giving just lenalidomide. Whereas with DARA-RD, the type of results you saw with the Maya trial is possible only if you're going to give DARA-RD for several years. And that we don't know, we know the cost is going to be very, very high, but we also don't know what the long-term consequences of like 4 or 5 years of DARA-based immunotherapy would be. So I feel like you cannot compare the 2 phase 3 trials, and based on what we know, VRD is my default, and so I'm glad that 99% are doing VRD. So continue to do that as your default. Now there are some patients. Yeah, there are some patients in whom, in our group, we are considering adding DARA, not replacing it, just adding DARA to the VRD. And that I would say is reasonable if you have a young patient, probably less than 60 or so, who has very high risk myeloma, preferably double hit or something like that. And they're able to afford the treatment. And you're only talking about 4 cycles of DARA VRD, and then you're going to go to transplant. Then I think it makes sense based on the Cassiopeia data and which was DARA VTD, and also the Griffin study, that you can justify the use of the 4th drug in that select group of patients. And that too for a limited time when you're taking them to transplant.
Right. Thank you. I think this is a very, very important information for the residents, as well as reassuring for all of us that that if we are not adding DARA upfront, we are reasonably okay doing this therapy for our patients.
Okay, sir,
right.
If you allow, can I ask Dr. Vincent a question? So we heard his opinion on Maya under the lens, very nice piece to read. I want his comment on Cassiopeia. So the study is DARA VTD then transplant, and after that there is a DARA maintenance in one arm, and other arm doesn't receive maintenance. So basically, the his comments on the design of this study and generalization of this in our practice, where RVD is the induction.
Yeah, thanks so much for asking that question. See, and one thing for the residents and fellows to understand is you have randomized trials and then you have randomized trials. It's all in the design. If you design the trial slightly biased manner, you can get whatever result you want. And the Cassiopeia trial, the Alcyone trial, they're all designed to make sure that the DARA arm wins, because you have only DARA maintenance that's going on indefinitely. And so you have no idea whether the benefit you're seeing is due to the induction or the maintenance. You also have no idea whether the same result could be obtained by just using the DARA at the time of progression. So what the residents and students here listening should take away is, don't just look at the fact that it's a randomized trial or that it was published in the Lancet or the New England Journal. Look at the design and say, does this make sense for the question we are trying to answer? We're trying to answer, like, if the standard maintenance is lenalidomide and the control arm is not getting lenalidomide and it's a DARA versus observation, how does that help answer that question? So the design is very important. You're very correct that just because a trial is published in a top journal, just because it's randomized, doesn't mean it actually helps you answer the question. So we wrote another article in the Lancet. If people are interested, they should read, which is called Interpretation of Clinical Trials from Results to Reality in the Lancet, myself and Philippe Moreau, in which we make the point that many times when you read these trials, the audience or the reader does not know why the trial was done. And why the trial was done is not in the primary aim or the secondary aims either. These trials are done to get daratumumab approved frontline. It's a regulatory design just to make the approval, but it doesn't inform how best to use DARA, which is the type of trials we should be running to try and ask, is it better to do DARA now with 4 drugs, or should we just do VRD and then do DARA at the first relapse and get the same outcome? So just try to remember that sometimes the trials are done just so that we can get the drug approved quickly, and then we have the choice so we can use it if we want, but it doesn't really mean that that answered the question that we want to ask.
Yes, thank you. Thank you so much for those words of wisdom, or I would say choosing wisely, protocol for myeloma patients. So this is very important for the residents and fellows who are listening to this panel discussion. Okay, to the organizer, how much time do we have for this panel discussion? I can go on. Do we have another 5 minutes?
2 minutes, sir.
Only 2 minutes. Okay. So, so this patient received 6 cycles of RVD, and pre-transplant. This was the picture. That M band was a very small 0.3 IgG lambda. So it was not IgG kappa. Serum free light chain ratio normal, bone marrow MRD negative, PET CT few FTG-8 lesions. So how do you interpret this response? Because this is another thing which we get in many patients, that the serum free light chain ratio is normal, but there is a small M band kind of which is present, and immunofixation positivity. Dr. Bhau Saab, if can start from you. Do you see this kind of a response? Dr. Bhau Saab? Okay, Dr. Lalit sir?
Yeah, actually this is something probably seen in about 10% or 12% of cases. And I think Dr. Nupur Raje has published a paper in Blood few years back. This kind of discrepancy between the serum electrophoresis versus serum free light chain. So I mean, there have been various explanations regarding like the long half-life of IgG molecule versus oligoclonal bands and so on and so forth. So, but the fact is this, that if serum free light chain is normal, then I assume like I forgot the like baseline serum electrophoresis, how much it was.
It was something like 3.5 grams or so.
So he will probably qualify as BGPR, I think, right?
Yes.
Right.
So, so this, as you said rightly, that 10 to 15% of patients, the bone marrow MRD is negative, light chains are normal, but a small M band or immunofixation still remains positive, and this constitute a separate group of patients who probably, as compared to who are immunofixation negative, they overall their response progression-free survival is little lower than patients who are immunofixation negative. So quickly again, this patient underwent a transplant, hematopoietic cell transplant with melphalan, and again day 100 assessment. Again, the M band was same. IFE was showing IgG lambda, light chain normal, and bone marrow MRD again negative, and PET CT again shows few FDG-avid lesions. Same findings as before transplant. So something similar picture. So sometimes it is very difficult to counsel the patients. When you are telling them that you are undergoing transplant, so we are achieving a better response, and it is kind of a consolidation. But the same response is there post transplant, so sometimes it is difficult to counsel the patient. So how you do that? Dr. Lalit sir first, and then maybe Dr. Tapan, and then maybe Dr. Vincent, and then we can wind up the panel discussion.
Yeah, I mean, this is an unusual situation, but probably can happen, I suppose. So I'll just reassure him that we'll just monitor it over the next couple of weeks. And probably I will put him on the lenalidomide maintenance and just watch it like every 4 to 8 weeks time, what happens to this MBAN. That's what will.
Right, sir.
Right, so I hope someone quietly did not give daratumumab to this patient. Jokes apart, I suppose I agree with that. I think by definition, you might call it near complete remission by so people use it, especially for clinical trials. But I completely agree with Dr. Lalit that by doing transplant with high-risk melphalan, I think benefit is for about 70% of the people. That's what I tell everyone, that you don't expect that everyone will get it. 70% gets perhaps a practical benefit. And often it's difficult to document when you get a very good response upfront. I think if you spend a lot of time with the patients, they are comfortable.
Yes. Yeah. So spending time always, but sometimes, the convincing them, we build up so much of aura of transplant, to them, they undergo transplant, and then they expect kind of a miracle, which obviously we all know it is a consolidation, but it is not a kind of a miracle. So Dr. Vincent, how do you counsel these patients there in US?
Yeah, I think what you just said is the most important thing. You want to do that ahead of time, just so they understand that. And I usually tell them, listen, in acute leukemia and diffuse large B-cell lymphoma, when we do transplant, we are hoping for a cure. Whereas in myeloma, the transplant, the reason we do the transplant is to prolong life and not raise their expectations that after the transplant, it's going to be like, MRD negative and flat and everything, because that may not happen. Number two, even if it doesn't happen, the patients can do quite well. We did a study that we reported on extraordinary response to transplant. People who just got induction and transplant without maintenance, there's like 15% of patients who can go 7-8 years without any progression. But if you look at those patients, not everyone got a CR. I think about a third of them were not even they were in partial response, and they still did well. So you want to reassure the patients that, yeah, if you get MRD negative, fine, but if you don't get it, you still could be fine. And we'll just watch you closely. We'll give you the appropriate maintenance. and just like what you all were discussing.
Right. Yes, thank you so much. So I think we are running now short of time. So maybe I can end the panel discussion here, and I thanks the organizers again for giving us the opportunity on behalf of Dr. Lalit Kumar, Dr. Tapan Sekia, Dr. Subhash Verma, Dr. Bhau Saab, and Dr. Vincent Rajkumar, who joined in this panel discussion. So I thank you all, as well as to the fellows and residents who are listening to this panel discussion. Thank you very much.
Thank you, sir.
Thanks, Pankaj.
Thank you, sir.
Thank you, Dr. Pankaj, Dr. Vincent Rajkumar, Dr. Lalit, Dr. Saikia, and Dr. Bhau Sahib for this wonderful panel discussion. So we will now move on to our plenary session. Are we live now?
Yes, ma'am. Yes, ma'am.
Vinod, are we live?
Yes, ma'am.
Okay. So we will now move on to the plenary session for today. And good evening to everyone, and a very warm welcome to all the esteemed faculty for this 4th annual conference of the Image Group. On behalf of the Image Group and the organizing committee of this program, the Indian Myeloma Congress 2021, I would like to extend a warm welcome to all the faculty members and the participants. We were compelled into having it through video conferencing, obviously because of the COVID pandemic, but it seems to be going well with a lot of dissemination of knowledge and information on multiple myeloma. And I want to thank all the esteemed faculty members for participating in it. So the plenary session will be chaired by Dr. Subhash Verma, who is the Director of Medicine and Hematology at the Fortis Healthcare, Mohali. And of course, we all know him very well. He's a very eminent hematologist who's played a pivotal role in setting up hematology as a subject in India. And General Velu Nair, who's now a consultant in hemato-oncology and bone marrow transplant at the Apollo Hospital, Ahmedabad. So over to the chairpersons for this plenary session. Dr. Nair and Dr. Verma.
Are we live and are we audible?
Yes, you are.
Thank you very much. Thank you, Dr. Sonia. And I must, my co-chair, Dr. Subhash, I'm sure he's on already the virtual platform. And nice to see my good friend Vincent after a long time in COVID times. Hi, and a very good evening from my side and a good morning for you. Actually, when we started this image in 17, 18, we never knew it'll snowball into such a good event. We started the first meeting, you all were there in Delhi. And when we put this together, we never really imagined that it will come to this stage. Despite this rascal virus called COVID doing what it has done to us, we are still here on the platform and still discussing academics. That just shows the spirit behind this whole venture. And I must congratulate the organizers and all the participants for still being with us and being here. I know everybody's stressed, but I think the tough gets going in tough times. And so you're all tough people. So today's plenary session is a very well thought out session. And myeloma has been revolutionized. And if you see what's happened in the last a decade and a half, it's amazing what's happened. And, we have so many molecules which have come out. It's like the T20 in India, the cricket that we talk of. The bench strength is increasing every day. One molecule goes, there's another molecule. So we always tell people, buy time, there may be something coming tomorrow. So, and the first talk is none other than Dr. Vincent Rajkumar, whom we have got to see so many times in the last many years, who's going to talk on the changing treatment paradigms in multiple myeloma. As you know, he has been in the forefront and has focused on so many clinical trials and landmark trials that we practice today. He's been a member in those pivotal trials. So I can keep on talking about him for a long time, but he's already participated in the panel discussion, as I see, and he needs no introduction in India in any corner, whether it's hematology or non-hematology. Vincent, you're well known. So take off, the platform is yours. Let's hear from you on the changing treatment paradigms in multiple myeloma. Dr. Vincent.
So thank you,
Hi,
Dr. Vincent.
I'm Vincent Rajkumar, Professor of Medicine at the Mayo Clinic in Rochester, Minnesota. Today we will be discussing changing treatment paradigms in multiple myeloma. I have no conflicts to disclose. There are many changes happening in the treatment of myeloma, and what I thought I will do is to highlight 6 of the major paradigm shifts that are occurring. Some have already happened, and some I think will happen in the next year or two. The first major paradigm shift is the treatment of smoldering multiple myeloma. Now, for many, many years, since the first description of the term in 1980, observation has been the standard of care for treatment of smoldering myeloma. And there's a good reason. There were no good treatments, there was no good risk stratification, and there was no evidence of benefit with early therapy. But none of these are true anymore. As you know that in 2014, the International Myeloma Working Group updated the diagnostic criteria for multiple myeloma and essentially made small subset of smoldering myeloma patients upstage them as myeloma. These are patients with more than 60% plasma cells, more than 100 free light chain ratio, or more than 1 focal lesion on MRI. However, the vast majority of smoldering myeloma patients are remaining as smoldering myeloma. And the question is, should we treat these patients? If so, who should we treat and who should we watch? We have now very good risk stratification tools to separate smoldering myeloma patients into a low-risk group who have only a 5% risk of progression and high-risk group, which has a 25% per year risk of progression. The Mayo 2018 risk stratification makes this very easy. In this risk stratification model, there are 3 risk factors: bone marrow plasma cells more than 20%, M-spike more than 2, and free light chain ratio more than 20. For patients who have 2 or 3 abnormal, the risk of progression is 2 years median, is 50% at 2 years median, or in other words, 25% per year in the first 2 years. This risk stratification model has now been confirmed by the International Myeloma Working Group, and this paper was published recently in the Blood Cancer Journal. Again, the same thing. For patients who have 2 of the, what we call the 2-20-20 or the 20-20 system, if you have 2 of the 3 risk factors abnormal, you get to be in the high risk group. And in the high risk group, the risk of progression is 50% at 2 years. We now have data that high-risk smoldering myeloma, whichever way you define it, and I think the Mayo 2018 is an easy way of defining this high-risk group. Early therapy does benefit. The Spanish trial found that early therapy in high-risk smoldering myeloma is associated with a significant difference in risk of progression. That is also associated with an overall survival improvement. More recently, the ECOG trial found that patients with high-risk smoldering myeloma derive benefit with just lenalidomide therapy. In this trial, as you can see here, progression to end organ damage was significantly different in patients who received lenalidomide versus observation. And when you look at the high-risk group, the group that we said Mayo 20-20 system, you can see that there is a marked difference in risk of progression, almost a 90% reduction in the risk of end organ damage with early therapy with lenalidomide. So the three reasons why we observed smoldering myeloma, no good treatments, no good risk stratification, and no evidence of benefit with early therapy are all no longer true, because we do have good treatments, we do have good risk stratification, and we do have now evidence from the Spanish and ECOG trial that early therapy does indeed reduce dramatically the risk of progression to end organ damage. Therefore, the paradigm has changed for management of smoldering myeloma. In a new patient, if the patient has myeloma defining events, we know we will treat the patient as myeloma. But if the patient has smoldering myeloma with no myeloma defining events, you can classify them into high risk or standard risk or low risk based on the Mayo 2018 system. Clearly, low-risk patients can continue to be watched, whereas for high-risk patients, we are now ready to recommend therapy with lenalidomide alone or lenalidomide plus dexamethasone, usually for 2 years, or enroll such patients in clinical trials. The question still remains whether patients with high-risk smoldering myeloma are best treated with len or lendex, or should we treat them more like myeloma? And a number of clinical trials are ongoing. For example, the daratumumab lendex versus lendex trial in the US is asking the question whether patients with high-risk smoldering myeloma are better treated with a myeloma-like therapy like daratumumab lendex or just a preventive therapy with lendex alone. There are also more aggressive trials going on, like the ASCENT and the CAESAR trials, which are asking whether if we apply therapy early, we can cure smoldering myeloma. And more to come on this. But at this point, the paradigm has changed in that for high-risk smoldering myeloma patients, we have good risk stratification, and we do recommend therapy with len or lendex or on a clinical trial. The second big paradigm that we need that is changing is how to treat newly diagnosed myeloma in a risk-adapted, cost-effective manner. One of the main things we know now is that myeloma is not one disease, but many different subtypes. Not only that, there are some high-risk patients, those who have 414, 1416, 1420, del17 or 1q gain, where if you have 2 high-risk abnormalities, your risk increases. And if you have 3 high-risk abnormalities, your risk increases further. So as we learn more about risk stratification, we are now contemplating how to manage myeloma in a risk-adapted manner so that we can best deliver the care for our patients. For newly diagnosed myeloma, the standard of care has been VRD. And that's based on the SWOG trial, which showed that VRD improves overall survival compared to RD. But can we improve on VRD? Can we improve on VRD by changing the triplet, by using carfilzomib instead of bortezomib, or by using a monoclonal antibody instead of a proteasome inhibitor? Or can we add a new drug to the triplet and make it a quadruplet? We have some data now. The MAIA trial shows that daratumumab lendex is an alternative to bortezomib lendex. But the main thing to keep in mind is that with daratumumab lendex, you have to give the triplet until progression, which is 4 to 5 years of daratumumab-based therapy, which means high cost. On the other hand, bortezomib lendex means that you're going to give the triplet only for 6 months, and then you're going to give lenalidomide alone. So it is much less toxic, much less expensive. Unfortunately, there are no head-to-head trials comparing VRD to DARA-RD to decide what is the best treatment. And so we have to decide based on our own circumstances, depending on the costs, what patients can afford, depending on the duration of therapy, which is the best option for your patient. As far as changing the proteasome inhibitor, we now have data from the endurance trial that carfilzomib lendex has no advantage to bortezomib lendex. So VRD still remains the standard of care and the standard proteasome inhibitor. What about adding a drug, making it a quadruplet? Here we have data from the Cassiopeia trial that adding daratumumab to a triplet can improve both progression-free and perhaps even overall survival. But we need more confirmation whether this VTD data apply to VRD. We're beginning to get such data with the Griffin trial, where you can see that DARA plus VRD gives you higher MRD negative rates. But at this point, it's not clear whether that strategy is necessary for all patients and whether that strategy will improve overall survival. And this is a paradigm that we have to test in the next few years. So as of right now, for transplant ineligible patients for standard risk, we could either do VRD or DRD, but my preference is for VRD based on the fact that it is only 6 months of a triplet and it's much more convenient for the patients and less expensive. For high-risk patients, VRD still remains the main standard. DRD is an alternative for standard risk patients, in particularly patients who have neuropathy or problems tolerating VRD. In transplant-eligible patients, it's the same scenario. VRD is still the default. However, in high-risk patients, particularly those with double hit or triple hit myeloma, you may want to consider DARA plus VRD. And once we get more data on the quadruplet, these paradigms might change for the standard risk as well. Now, the EQUATE trial just opened in the United States. This is led by Dr. Shaji Kumar. And this is asking the question whether everyone needs quadruplet, or we can adjust the quadruplet based on MRD status. So in this trial, all patients will get DARA-RD and then will be randomized after 9 cycles to addition of bortezomib or continuing on DARA-RD alone. And we'll analyze the results based on MRD status. And our hypothesis is that MRD negative patients may be okay with DARA-RD alone, whereas MRD positive patients may benefit from the addition of the fourth drug. The next paradigm to consider is the role of early transplant, and this is also changing. At the ASH meeting, there was updated results of the early versus delayed transplant trial conducted by the IFM. Here, patients received in Arm A 8 cycles of RVD alone, versus in Arm B, patients received RVD followed by transplant. All patients received maintenance therapy. Interestingly, at 8 years of follow-up, progression-free survival was longer with transplantation. However, even at 8 years of follow-up, there is really no difference in overall survival, which means that if your patient is interested in delaying transplant on an intent to treat basis, as long as you have stem cells collected and stored and the ability to transplant late, overall survival seems to be identical, whether you do an early transplant or a delayed transplant. And this is true even though patients in the delayed transplant arm are not always getting the delayed transplant. So it almost looks like the initial risk stratification or the initial randomization still holds. So essentially, this is why my algorithm here for standard risk offers the choice between early transplant or delayed transplant based on patient wishes and also based on circumstances. If your patient is younger and is very insistent on delayed transplant, overall survival at this point seems to be similar whether you choose an early or a delayed transplant approach. The next question to ask is role of consolidation therapy. And here we have data now from some important trials. The STAMINA trial looked at patients with newly diagnosed myeloma who are treated with double transplant, single transplant followed by consolidation, or single transplant followed by maintenance alone. As of right now, you can see that there is no benefit with either a double transplant or with consolidation therapy compared to just one transplant followed by maintenance, either with progression-free survival or with overall survival. And even in the high-risk patients, there is no difference whether you do a double transplant or whether you add consolidation. The EMN trial found that overall progression-free survival may be improved by consolidation. However, at this point, there's still no benefit in overall survival. A meta-analysis of post-transplant consolidation has been published, and this finds that there is really no benefit in CR rate, progression-free survival, or overall survival with routine consolidation following a transplant. So basically, induction, transplant, and then you move straight away to maintenance with either lenalidomide for standard risk patients or len plus bortezomib for high-risk patients. And I think there's limited, if any, role for consolidation therapy. What about duration of maintenance therapy? So far, we are giving maintenance with lenalidomide indefinitely. But the question is, do we need to? And this is being challenged in the E1A11 endurance trial, which is still ongoing, and which has a component of randomization of lenalidomide for 2 years versus lenalidomide until progression. And this trial is going to be very important because if we find that 2 years is sufficient, we can spare patients a lot of cost, toxicity, as well as risk of second primary malignancies. The default still remains maintenance until progression, but I'm anxiously awaiting the results of this trial. There's also another trial that is set to open in the US called the Optimum trial. And in this trial, patients who are MRD positive, patients who are MRD positive are randomized to len plus ixazomib versus len plus placebo. And here we are asking the question, if you've been on len maintenance for 1 year already, then does it benefit MRD positive patients to add another drug? So this is MRD directed therapy for MRD positive patients. Similarly, SWOG is doing a trial where all patients are randomized to len versus len plus dara. But if patients are MRD negative after 2 years, the question is, can we stop therapy safely? Again, MRD directed therapy. So the paradigm for maintenance is changing with these trials where we are asking the question whether limited duration is sufficient or whether we can adjust the maintenance duration based on MRD. Finally, what about relapse myeloma? We have many new BCMA-directed strategies. Clearly, in the multiply relapsed population, so far, all we have, patients who have failed IMiDs, PI, and anti-CD38, all we have are combinations with cyclophosphamide or multi-drug combinations. But BCMA-directed strategies are coming up. There are many BCMA-directed strategies, one of which is BCMA antibody drug conjugates, such as belantamab, which is already approved in the US, BCMA-directed bispecific antibodies, and BCMA-directed CAR T-cell therapy. All of them are focused on a BCMA-directed strategies. They're promising. Belantamab is already approved. There are probably CAR Ts that are going to be approved this year in the US. But I think sooner or later, the paradigm is going to be, what do you do when patients fail anti-BCMA therapy as well? What strategies do we have for such patients? And here there is some hope. We are having new bispecifics that are coming up, which are not directed against BCMA, as well as many new drugs. The two novel bispecifics that I'm most interested about are cevostamab, which is a bispecific that doesn't target BCMA, but rather it targets FcRH5, and talquetamab, which is a bispecific targeting GPRC5D. Results were presented at ASH last year, and they're very promising. So we do have immunotherapy that is not directed against BCMA that is coming up. And finally, we have many other new drugs, iberdomide, venetoclax for 11-14 myeloma, and then also the recent approval of selinexor. So we will see how we find a place for these other drugs in patients. But I think the role of these other options may be more in patients who have failed BCMA-directed strategies. So I hope to answer questions in the live session. Thank you very much for your attention.
Thank you, Dr. Vincent, for that lovely talk. You are on board?
Yes, I am.
Yeah, great. Well, I will start with the question box. And the first question is from Dr. Deb, Utya Deb. who asks, in kappa light chain multiple myeloma, which is found in 20% multiple myeloma patients, how would you plan the induction therapy?
I'm not sure I get the question. I think as long as the patient has myeloma, the treatment is the same, whether it's kappa or not.
I agree with you. This is the question in the chat box, so I'm just relaying it, but I fully agree with you, and I'm sure that's answered the question. The next one is from Professor Pranab Bhattacharya, who asks, early transplant will result in CR always when you do a single transplant only. That means he's saying single versus tandem transplant is the question.
So again, as I mentioned in the talk, the two points are that one has to look at the IFM trial that was just reported at ASH 8 years later, whether the early transplant gave you better MRD rate, or whether it gave you better CR rate, or whether the delayed transplant people got the delayed transplant or not. It really didn't matter. As long as your intent was to transplant the patient early or late, they had the exact same overall survival at 8 years. So it really boils down to resources for transplant, ability to store stem cells, what is the patient's preference, what is their risk status, because we usually like to do the early transplant for high-risk patients, age, such and such. For double transplant, the data I didn't get into, but there are two trials which are contradictory in modern times. In the old times, there were many trials which looked at single versus double. In the modern times, the US trial did not find any extra benefit to the second transplant, either in the standard risk group or in the high risk group. In the European trial, there was a benefit seen with the second transplant. So the question is, how do you reconcile these two obviously contradictory results? And I think, to me, the availability of treatment options at relapse is very critical. In Europe, because of their regulatory policies and their pricing policies, many treatments that are available at relapse in the US are still not available. So when your relapse options are limited, then it looks like the second transplant adds something. But if you have adequate options for relapse, it seems like it doesn't. So we are not routinely doing second transplants. And the only group we are considering it are people who are high risk, young people who are not in CR after the first transplant.
Thank you. I have a question, Dr. Vincent. How do you use MRD in your practice to actually interrupt a continuous versus a finite maintenance therapy?
Yeah, excellent question. And again, just for the audience, I look at MRD as a very important tool that we have for myeloma, but how you interpret it depends on what you're using it for. So one way of using MRD is simply to give prognostic information to the patient, which is a proven role for MRD. The second thing is to use MRD instead of overall survival as a surrogate endpoint for regulatory approval. And the I-SQUARE team is trying to do the surrogacy analysis, which are more complicated, and we don't have the results yet. The third role is what you mentioned, which is, can you use the MRD result to decide, in an MRD positive patient, should we add something, or an MRD negative patient, can we stop something? I think those really require randomized controlled trials, and that's what we are doing right now. The SWOG trial is going to randomize patients to stop versus continue. The Europeans are doing the same thing. Shaji's got a trial. If you have MRD positive, should you add a drug or keep the same lenalidomide? So if you want to use MRD to make treatment decisions, right now you'll be doing it basically on hope and biology, but not on data. And that data has to come from randomized trials. And of course, the fourth role of MRD, which only time will tell, is, are there a small group of patients who are sustained MRD negative, say for 3 years, who potentially are cured? But cure is a word we can use only after time goes by and we find that that actually plays out. So far, the MRD negative group is still having a slow risk of progression that's continuing.
The last question, Dr. Vincent, is, there is always a gap between trial data and real world practice, which you'll agree with me.
Yes.
And what really concerns us is the real world practice.
Yes.
So what are the triggers that you use for changing your protocol, which you're implementing in newly diagnosed multiple myelomas? How much would you actually investigate before changing a protocol? Let's say VRD. And what tools would you use to change this protocol, and how early would you change it? In terms of non-response, in terms of resistance?
Sure. Again, great question. I think the general message is, the only question the trial answers is, if you had the same trial population in front of you, what the answer might be. But it doesn't answer that question once you go outside that setting for generalizability. So that's why you have to remember the patients who are not included in trials for a reason, and we are extrapolating it in general practice. To me, I think I keep coming back to all of the transplant randomized trials generally did not look at the level of response when deciding, what to do for transplant versus no transplant. All the early versus delay, the transplant versus no transplant, they all gave 3-4 cycles of induction, and no matter what the result was, they randomized patients. So that's the best we have, and so that's the default route we choose. Having said that, if somebody you've started on VRD is not getting a response or is progressing, and they still have adequate disease left, I think today I would probably try to add treatments, either add daratumumab or substitute daratumumab, or switch to VCD if dara is a cost concern, trying to get them. On the other hand, if a patient's responding but has only achieved a PR or VGPR, that doesn't bother me. I would proceed with treatment as long as they are responding. It's only the non-response or a actual progression while on VRD. Those two are quite uncommon, but when they do occur, I feel like the trials haven't answered that population clearly. So we need to, use our judgment depending on the patient in front of us.
Thank you so much, Dr. Vincent. In the interest of time,
Dr. Nair, we have 5 minutes more, so we can
great.
So we can take up a couple of more questions.
Fantastic! Thank you so much. With Dr. Vincent, you could go on the whole evening.
I know.
So obviously, but that's a very great input. So if you have a question, or my co-chair, Dr. Subhash, has a question, otherwise I will shoot the next question also. So if you both have any question, please go ahead.
I just will ask a very short question, and I would like you to take up the questions in the question and answer box. But Dr. Vincent, I would like to ask you that what do you look at the place of immunotherapy in the treatment of myeloma only for relapsed refractory patients, or do you let's look at it 5 years down the line or beyond, or because it's still an incurable disease, or do you think of it as a consolidation after the induction chemotherapy?
Oh, great question. And I think we have to do what you're saying. We have to look at immunotherapy. By immunotherapy, I mean bispecifics or CAR-T, like right after transplant or even right after induction. And the whole idea would be twofold. One is, like you said, can you cure patients if you give immunotherapy early on when the immune system is relatively preserved? Or secondly, if you give immunotherapy, can you give the patient a long duration of time where they don't need to take maintenance or anything else? It becomes cost effective if you can get rid of the maintenance. At least in the US. Now, because the US, the maintenance with lenalidomide is $17,000, $15,000 or so a month. So for 3-4 years, you add it up, it comes to the CAR-T cost. But eventually, I think CAR-T itself does not have to be that expensive. And in countries like India, once you have the technology set up, I'm sure you'll be able to do it at a fraction of the price. And also, if you can get the regulatory framework correct, we argued that CAR-T should be done, the FDA should regulate CAR-T like stem cells, not like a drug. Yeah. So that if you have like top centers in India who can do CAR-T and the government says, yeah, you are allowed to process the cells the same way we process platelets or red cells, engineer them. Hopefully in the next year or two, you'll have machines that can do all of this within a few hours and return the T cells back to the patient. When you look at it as a drug sold by BMS, it's $450,000. When you can do it yourself in a center, then it becomes more feasible. And I think India would be a great place to start asking the questions, can CAR-T be used instead of transplant or instead of maintenance?
You'll be happy to know, Dr. Vincent, we have 12 centers doing basic, bench to bedside on CAR-T cells. A few quick questions, yes or no's from the question chat box. One is, what is your maintenance strategy in patients with established CKD? Chronic kidney disease.
Yes, you can use lenalidomide. I think all you have to do is to reduce the dose appropriately. And we have done the phase 1, phase 2s that show that. So just use the paper that Dr. Mikhail published. And that has the dosing, but just use that.
Okay. And the other one is on Len. There's a lot of talk on the Len dose and maintenance, 10, 15, 25.
10 milligrams, 3 weeks on, 1 week off for India.
Then there is a question which actually talks about, this is Dr. Hari Menon, who says DARA has been an excellent addition to the armamentarium, but not impressive enough for high-risk myeloma. Is it worth preserving with the same when ASCT tandem may do just as well following standard therapy?
I'm not sure I caught that question quite correct, because they're two different settings in which we consider them. So, DARA, just like any other drug, has better effect in standard risk than high risk. It doesn't mean it doesn't work in high risk. It just works to a lesser extent. But that's true of lenalidomide, that's true of bortezomib, that's true of all of the myeloma treatments.
Thank you. So, but one last one is belantamab-induced keratopathy. Your comments?
It is a serious problem in about, 30% to 40% of people have this keratopathy that's severe grade 3-4. Most others are grade 1-2. It is a problem. I think that can be resolved with eye drops and by lengthening the interval between the treatments. So time will tell how it fares against the bispecifics which are coming out. Before I leave, I just want everyone to be aware that there is a whole group of physicians and concerned people in the US who are very, very worried about India. And we are trying to do all we can to help, whether it be putting pressure on the US government or trying to raise resources or provide direct feedback for the COVID situation. So please reach out if you have requests or if you think that there are things that we can do to help, because we feel kind of helpless here. But we really feel for you, and we just pray that everyone is safe. And please mask, social distance, get your vaccines. Thank you so much.
Thank you so much, Dr. Vincent, for that wonderful talk and the question answer session and your concluding remarks, because that is what matters. We are there for each other. Thank you so much. I hand over to Dr. Subhash, my co-chair.
Thank you, Dr. Rajkumar, for being there with us.
Thank you, Dr. Sonia, for that comment. And Dr. Subhash, if you could introduce the next speaker, please. Not audible. I can't hear you.
Can you hear me?
No, there's been a change, Dr. Sonia, in the talk.
Yeah, so the second talk is multiple myeloma genomics.
Yeah, you're giving the talk because we didn't know that.
Yeah. It must be there in the program.
I don't know whether Dr. Subhash knew it. Dr. Subhash, you're not audible. You're not audible. We can't hear you, Dr. Subhash. Unmuted. Dr. Sonia, can you hear Dr. Subhash? I can't hear him.
No, I can't hear him.
Yeah, even I can't hear you, Dr. Subhash. Can you hear us? Raise your hand. Can you hear us? Yeah, but we can't hear you, unfortunately. Your lovely voice is not audible. So Dr. Sonia, without wasting time, why don't we start the talk?
So can you see my screen?
Yes.
Okay. So I'll go on with the talk. It's on multiple myeloma genomics. What do we understand today? So after the lovely talk by Dr. Vincent Rajkumar, a slightly basic talk on the genomics of multiple myeloma. So as we, even though, the median survival and the 5-year overall survival has increased, the median survival has increased from 39 months to 60 months, and the 5-year overall survival from 31.2% to 50.3%. This is some data from the Japanese Society of Myeloma. Yet, myeloma continues to be an incurable disease with a poor prognosis. And what is interesting is that though there are comparable median number of non-synonymous recurrent mutations, that is 35 per genome in multiple myeloma, 30 per genome in B-cell lymphomas, and 12 to 13 per genome in acute leukemias, yet the prognosis is poor. And I think the refractoriness is due to the complex genomic architecture of multiple myeloma with this unique biology of clonal evolution. A lot of insight has been gained on the biology of multiple myeloma, on the genomic biology, because of refined technology, such as the high-density array-based gene profiling, the comparative genomic hybridization, and the next generation sequencing. So I will begin by this cartoon, which shows that multiple myeloma actually provides a unique framework to study the sequential genomic evolution which occurs from MGUS to smoldering multiple myeloma to full-blown multiple myeloma to the high-risk states like extramedullary disease and plasma cell leukemia. So with this, there is a flow of the genomic evolution also. Myeloma is initiated by primary events leading to a clonal population, but then it's the driver events, the secondary genetic events, which are acquired in subsequent clones, with selection of the clones according to the Darwinian selection, which leads to a disease progression through the various stages of myeloma. So what are the primary drivers, the primary genetic abnormalities? There are basically two. One is the chromosomal translocations, which affect the immunoglobulin heavy chain locus, which is, as we all know, on chromosome 14. And it is one of the most heavily transcribed genes in plasma cells. So you have translocation 414, 614, 1114, 1416, 1420 with an adverse prognosis with 414, 1416, and 1420. This is one of the most important primary event. And these translocations, I'll be touching on later, they lead to a deregulation of the cyclin D pathway, that is an overexpression, with a loss of the checkpoint from G1 to S phase of the cell cycle. The second most important primary genetic event in multiple myeloma is the hyperdiploidy. And you find trisomies of the odd chromosomes, 3, 5, 7, 9, 11, 15, 19, and 21. And they normally have a more favorable outcome unless there is, over a period of time, acquisition of adverse cytogenetic lesions like deletion 17p. etc. So these primary events, whether it's 11-14, 6-14, 4-14, 14-16, 14-20, or hyperdiploidy, they all lead to an deregulation of the G1S phase checkpoint through the cyclin D1, D2, or D3 upregulation. And even some of the secondary events, which I'll be touching upon later, they also operate through the upregulation of the cyclin D pathway. So, as I said, this is a normal plasma cell, goes on to MGES. You have the immunoglobulin heavy chain translocations seen in 50%, hyperdiploidy in 40%. These are the primary events with an overlap in 10%. For a further evolution from MGES to smoldering to myeloma, you have secondary events. And the most important are the RAS mutations, and there are activation of two major oncogenes, RAS and MYC. If you see the KRAS and the NRAS mutations are normally seen in 0 to 7% of patients of MGES, but each one of them is seen in 20 to 30% in multiple myeloma patients. So these are acquired drivers which push the disease further on. And RAS is actually the most frequently mutated gene in newly diagnosed multiple myeloma. And there are multiple mechanisms why it leads to an uncontrolled proliferation. The second most, apart from the RAS mutations, the second most common translocation, which is a secondary event, is the MYC, or translocations to the MYC locus. Again, you find them only in 3 to 4% of the patients with MGES or smoldering multiple myeloma, but in full 15 to 20% of the patients with newly diagnosed multiple myeloma. And the most common partner loci are the immunoglobulin encoding genes, IgH, IgL, IgKappa. And these MYC translocations to the MYC locus are very frequently observed in the hyperdiploid myeloma cases. And they're usually again associated with the poor outcomes, especially when they involve an immunoglobulin partner. Along with that, you may have deletion of chromosome 13. And why does that lead to tumor progression? Because it leads to the haploinsufficiency of a tumor suppressor gene, which is at 13q14. So chromosome 13 deletion is also an important secondary event, apart from the RAS and the MYC translocations. So this is where I said the RAS and the MYC RAS mutations, MYC overexpression, deletion 13. The interesting thing is, from myeloma to extramedullary disease to more advanced forms of the disease and plasma cell leukemia, the whole transition now becomes bone marrow stroma independent. And usually one finds NF-kappa B mutations, MYC translocations, 1p loss, 1q gain, deletion 17p, and p53 deletions. So this is a stroma-independent growth leads to extramedullary lesions and leukemic conversion. So there is a constitutive, as I said, activation of NF-kappa B, massive structural abnormalities of the chromosomes involving the 8q24 locus in which the c-MYC gene is located. As I said, 1q gain, deletion of 1p, 17p, and TP53 mutations, which are seen only in 5 to 10%, 5 to 8% in newly diagnosed myeloma, and up to 25% in plasma cell leukemias, showing that this is a driver or acquired genetic abnormality. So this is just a cartoon showing a normal 17p with a wild type of p53, where drugs lead to apoptosis of cancer cells and DNA repair occurs normally. If there is a 17p depletion, one chromosome, monoallelic depletion, and a wild type of p53, you will have a reduced apoptosis and a reduced DNA repair. But if 17p deletion is coupled with a p53 mutation, there is a huge oncogenic potential, drug resistance, and impaired DNA damage, repair with genomic instability. So this is just an overview of the different genetic pathways in cell cycle regulation, which are involved in multiple myeloma, which are the MAP kinase pathway, the MYC activation, the NF-kappa B pathway, the cyclin D pathway, as well as the TP53. And I like this picture very much because it shows a branching pattern of the evolution in multiple myeloma through the various stages. This is a myeloma initiating cell, which is dominant in MGS, but it starts branching into clones which acquire different genetic abnormalities, and it goes forward. This is smoldering, this is multiple myeloma, all the colored circles are the different clones. And finally, there is a Darwinian selection of clones which are drug resistant, and they bring back the relapse, as well as they lead to what is known as a resistant myeloma in the end stage. This is just showing that there is an ancestral clone to begin with a mutation A only. Then there is a clone 1.1 which has mutation A and B. Then another clone with A, B, and C, another clone with A and D mutation, and another clone with A, D, and E. So as the clones go on further, they may retain the original mutation, which is mutation A, but they acquire more and more genetic abnormalities, and some of them help in the selection of these clones. So how does this translate into clinical medicine? We all know that translocation 414 has an intermediate risk myeloma with a median overall survival of 5 years. 1416 and 1420 are high-risk myelomas with median survival of 3 years. Similarly, a 1q gain is an intermediate risk myeloma with a median overall survival of 5 years. A deletion 17p is a high-risk myeloma, and so would be an isolated monosomy 13 or isolated monosomy 14. Further, the clinical implications. We all know this is a data which was published way back, that if you have a translocation 414, the overall survival will improve with the use of the proteasome inhibitor bortezomib. This is very well documented. So this is kind of a translation of understanding the genetics to clinical management. Similarly, this is a very nice paper which was presented in ASH 2015, where again a proteasome inhibitor, which is IRD. If you see in the high-risk myeloma patients, including patients with 17p deletions and with translocation 414, if you use IRD, at least the outcome is similar to the standard risk patients. That is an ixazomib-based regimen. So this is some data on translocation 414 and a 17p deletion. deletion 17p along with or without translocation 414, where this is a data which has shown that a tandem transplant will have a better outcome, a better survival outcome. I'm sorry, I'm unable to move to the next slide. Okay. So this is some data on venetoclax. We all know venetoclax binds in the groove of BCL2, where the pro-apoptotic protein is normally bound, displaces it, and that leads to an apoptosis of cancer cells. And there is data to show that venetoclax has a beneficial effect in patients with the translocation 1114. This is some data from Dr. Shaji's group. That the response rates were better in patients who were given venetoclax with translocation 1114, whereas it had no effect if this translocation was absent. Now this is again, these are all, mind you, patients who are relapsed refractory. In BRAF 600E mutation, this is a patient who had failed multiple lines of therapy and there was really nothing to offer. And then a whole genome sequencing was done and it was found that this patient has a BRAF 600E mutation and the patient was given Varmurafenib. And you can see that there was a decrease in the size of the tumor, as well as a decrease in the M spike and a biochemical response in the patient. So the genetic characterization did lead to a benefit in the patient by using a targeted therapy. So this is another paper where the RAS MAP kinase pathway mutations have been targeted by trametinib, published in Leukemia in 2016. And this is the response in terms of the free light chains, the urinary M proteins, and the serum M proteins, KRAS and the MRAS mutations. And similarly, the PET-CT data also showed a good response by targeting the RAS MAP kinase pathway. So finally, this is some of the actionable mutations in myeloma which are also evolving are, these are the targeted drugs which are being tried for mutations in KRAS, for mutations in NRAS, for translocations involving MYC, for mutations in the FGFR3, and mutations in BRAF. I showed one example of it. And similarly, for 1p deletion, 1114, 614, these are some of the targeted therapies which are in phase 2 trials. And this is something which I picked up from Dr. Shaji's talk yesterday, that he presented it as a beautiful slide, that this is an ongoing NIH drug trial, which is called my drug design, targeting the high-risk, functional high-risk patients. For example, if you have, this is a trial which is on the RAS mutations with cobimetinib plus dexamethasone, the IDH activating mutations with anasidinib, the CDK pathway activating alterations with abemaciclib, the FGFR3 activating mutations with ardafitinib. And if there are no detectable actionable mutations, then daratumumab And for 11-14, venetoclax. And then the addition of chemotherapy with each of these targeted molecules, which is isaxazolid, pomalidomide, and dexamethasone. So there is a basis for understanding the genetics of myeloma. It forms a very, very interesting platform for, I don't know, the slides are, okay. So concluding, it's a genetically complex and heterogeneous disease in which there are primary events, secondary events, clonal heterogeneity, which leads to the tumor progression through the various stages. And we got a lot of insight through the whole genome sequencing. And further studies on the sequential samples taken before and after treatment will help us to understand about resistant clones. And as already moving in that direction, as Dr. Vincent Rajkumar presented, high-risk smoldering myeloma, identifying patients with a high risk of disease progression and developing early interventions using precision medicine, it may move towards a more curable or preventable disease. We can probably stop at the level of MGIS or smoldering multiple myeloma. So thank you. This is our group from the Department of Hematology, and we express our deep gratitude to all people who have participated in this image symposium in spite of these horrific times in India, you know. And this is our Center for Hematology, Bone Marrow Transplant and Stem Cell Research at SGPGI. Again, we thank you all for participating. Thank you.
Thank you, Dr. Sonia. Am I audible now?
Yes, sir.
Okay.
Very well audible now.
Okay. So
what magic have you done?
So I had to log out and then log in again. That's what I did. Usual thing with computers, you know, put them off and then put them on again. Okay. So thank you very much for a very excellent and crisp presentation on genomic landscape. I really don't see any questions here, but you've really touched upon the importance of understanding the genomic changes, not only in pathogenesis, but also in progression of the disease, and maybe then identifying the targets for an individual patient, which might be different from the other patients. My question to you would be, at what stage would you like to actually do genomic studies? Because as you say, it's actually acquired over a period of time. So how many times would you actually look at these parameters? At each relapse, at the time of diagnosis, what would be the strategy once we start using these strategies?
So the standard practice is to do, is to do karyotyping, and more important, to do FISH at baseline. And that, will give you a fair idea of the high-risk groups. A lot of this is to understand a lot of this genomic analysis that I have highlighted, and the NGS is to understand the genomic architecture of myeloma. But in the clinical practice, one would still do a FISH and a conventional karyotyping at diagnosis. But what if one has the facility and you have a patient who is a relapsed refractory patient who has failed multiple lines of therapy? It may be worthwhile to do an NGS to pick up some of these acquired genetic abnormalities to target them. This is what would be at this point of time, because these are not routine tests. They're expensive. They're not readily available, even though, NGS is now being widely marketed by MedGenome. But probably in patients who are relapsed, especially multiple lines of therapy, and who are refractory, it would be worthwhile if one can afford to do an NGS to identify lesions which are targetable as of today.
Dr. Subhash, can I ask a question?
Yes, sir.
Thank you. Dr. Sonia, thank you for that great talk on the genomic landscape in multiple myeloma. My question is, since this is more of an academic platform right now in terms of genomic landscape, but if we are in a research center, if funds are not an issue, would you do this upfront in high-risk patients? And especially after Dr. Shaji Kumar's talk yesterday, that you can actually, when we are thinking of intervening, and we know that early interventions have an advantage, especially in the high-risk group. So hit hard, hit early, rather than wait for relapse. So in those sort of settings, do you envisage that we will do upfront, the timeline to do the landscape and in a high-risk patient? And if we have a target, to try and either include it in a clinical trial or to obviously intervene?
It's a nice question and a very thought-provoking question. My take would be that at the, even if you have the facility of genome expression profiling, or even of NGS, if I would say, it would be, in the beginning, you have already identified high-risk patients through the chromosomal translocations of the immunoglobulin gene heavy chain. So you already have that group. But if it's a young patient and you want to identify more mutations or more genetic abnormalities, since you are, hitting for a probable cure in that patient, and in addition to the chemotherapy that he has highlighted, in that last talk where I've taken the slide from him, you want to target those genetic abnormalities. That would be a place to invest and do an NGS, where you feel the patient is young and you're hitting for a cure in that patient, rather than to just wait for a relapse refractory state, maybe upfront. That's why that trial is being carried out, where they're doing NGS upfront and trying to identify the targetable lesions and combining them with the combination chemotherapy. So I would go more for a patient where I would be hitting for a cure, the younger myeloma patients.
Yeah, thank you very much. The only other issue basically is that we go by data that is coming from the West, and we really do not know what is our own genomic landscape. So do we behave similarly or differently, predominantly because we are different otherwise? Yeah. And therefore, unless we have our own data, just relying on data which is coming from elsewhere may not always be the thing to do. So maybe some institutions, some places will have to start looking at this and say, are we same? That's one question that we need to ask ourselves. Would you like to ask the same question? I'm not really very sure whether we behave similarly.
Yeah.
Right? When we say that,
it's very relevant that we need to genetically characterize our own myeloma patients. And
because when we say, I'll give you a simple this thing. We say we do not tolerate 200 milligrams of thalidomide for the same weight. Yeah. So why is it that we don't? Yeah. I mean, so there are several such questions, and I think if funds are not a major issue, then at least in whole of India, we just need to look at these data also and collate our own data.
Right. Fully agree with that.
Thank you. Dr. Velu Nair, over to you.
Yeah. Thank you very much. Thank you very much, Dr. Sonia. And I think you did a great job to introduce us and sensitize us to a difficult topic. And like Dr. Subhash has said, obviously we should put our own house in order to actually start this front, which we are still very naive. Can we have the slide for the third talk, please? Yeah, I have the pleasure to introduce Dr. Sagar Lonial, the chair and professor of the Department of Hematology and Oncology from the Anne Bernard Gray Family Chair in Cancer, the Winship Cancer Institute. He's going to be talking on the sequencing of novel agents in the treatment of multiple myeloma. I've had the pleasure to meet Dr. Sagar on more than one occasion in India when during his visits in better times, in non-COVID times. He's involved in pivotal clinical trials and has been instrumental in bringing us many of the practice points that we actually presently do. And we look forward to your talk, Dr. Sagar. The platform is all yours. Dr. Sagar, please.
Hello, I'm Dr. Sagar Lonial from the Winship Cancer Institute of Emory University in Atlanta, Georgia, and I'm going to spend the next few moments talking about sequencing novel agents in the context of relapsed multiple myeloma. It sounds like from the agenda, this is really an amazing meeting, and I continue to congratulate the organizers for bringing such an august group of people together to share experiences. I'm sorry I can't be there with you in India this year, and hope that you and your families are safe. But look forward to joining you hopefully next year when the pandemic is in a better situation. So I wanted to start off really talking about the modern goals of therapy in the context of newly diagnosed myeloma. And I'm going to do that because much of what I'm going to touch on is relating to patients with relapsed myeloma. But this is actually a data set from our RVD 1000 group of patients, which were basically a group of about 1,000 newly diagnosed myeloma patients treated over about an 8 to 10 year period of time at our center. All of them received RVD induction. Most of them received single transplant followed by risk-adapted maintenance. And risk-adapted maintenance, as you know from our program's history, uses single-agent lenalidomide maintenance till progression for standard risk and RVD consolidation for high risk. And what I think you'll see here are the new benchmarks in terms of what I think progression-free and overall survival look like with treatment in the modern era. And what you'll notice is that the median progression-free survival here is somewhere around 65 months for all patients in aggregate, and the median overall survival is over 126 months, again, for all patients in aggregate. If you break that down into standard risk in red and high risk in blue, what I think you'll see even more excitingly is that the median PFS for standard risk is about 76 months, and for median overall survival has not been reached for that patient cohort overall. And what I think this really speaks to is the context of good induction, good consolidation, and continuous lenalidomide maintenance. And those to me are the three hallmarks for maximizing the duration of the initial response. Now, as we begin to think about this, as you can see, there is no clear plateau on this curve. Patients do continue to relapse. And so what do we do in the context of relapse disease? And so I think there are a number of factors that come into play when managing patients in the relapse disease setting. They include frailty, disease morbidity, risk assessment, treatment history, and lifestyle. And certainly in the US, patient preference plays a strong part. I'm sure that perhaps in your environment, perhaps cost or travel plays a big role in terms of what patients may or may not be able to do. But all of these factors go into weighing what one might do in the context of relapsed multiple myeloma. And again, the most effective regimen is one that is induces a long PFS, is safe, and maintains a good quality of life. Now, when we look at therapy for patients with relapsed myeloma, what you'll see is, again, triplets are the preferred treatment approach, typically with second-generation IMiDs, PIs, or monoclonal antibodies. And so in patients with len and bortezomib refractory patients, again, carfilzomib does become a major drug. The use of DARA, an anti-CD38, ELO, an anti-SLAMF7, or isatuximab, a different anti-CD38, all come into play. And as you can see, when patients become triple-class refractory, the number of potential treatment options become more and more limited. Now, in myeloma, we like to talk predominantly about backbones. This is an IMiD backbone regimen or a PI backbone regimen. And that really started to become less relevant when we put IMiDs and PIs together and came up with regimens like VTD or VRD or KRD. And the reason is that it's both the IMiD and the PI that are the backbone in that context. Now, knowing what we know about myeloma therapy in 2021, when a patient is in relapse disease, it probably becomes almost more important to think about the three backbones. And the three backbones now are CD38, an IMiD, or a proteasome inhibitor. And when I think about what to do in the context of first relapse in a patient progressing on single agent lenalidomide maintenance, my thought is I'm going to take this and I'm going to add this or this to it. And so you can see that demonstrated here, CD38 plus an IMiD or CD38 plus a PI. This becomes the true agent approach that we take in the context of managing early relapse disease. Now, this presumes that a patient is not CD38 resistant. And as we're seeing more and more daratumumab used in initial therapy for newly diagnosed myeloma, this may not always be the go-to scenario, but at least in patients that have been treated in the last decade or so, if they've not seen and if they're not resistant to an anti-CD38 antibody, this partnership or this partnership likely takes the precedent in terms of what we're going to do to manage that relapse disease. Now, there are a number of studies that use lenalidomide and dexamethasone as the control arm. I was IRD, ERD, KRD, or DRD. And the real challenge that I have when looking at each of these four trials, even though this certainly was a trial that I led, is that the real challenge here is that almost all of our patients now are progressing on lenalidomide maintenance. And so these four trials, as good and as important as they are no longer relevant in the era of modern myeloma therapy. And that's a painful thing to say because we have almost 2,500 patients that went into these randomizations. But now with everybody progressing on single agent lenalidomide, I think that their utility is actually quite limited. Now, if we begin to think about other control arms that might be more relevant for our patient population in 2021, these are the trials that begin to come up. So we've got the Optimism trial that was POM, bortezomib dex versus bortezomib dex. We've got the Castor trial that was Dara, bortezomib dex versus bortezomib dex. We've got the Endeavor trial that was KD versus VD. We've got the Boston trial that was selinexor, bortezomib dex versus bortezomib dex. And then we've got the Bellini trial, which was bortezomib vendex versus vendex. And this is a special situation. We're going to talk about that at the end. But in general, again, this is probably far more relevant for a patient population that is lenalidomide resistant than any of the previous trials that I showed you on the previous slide. Now, the third backbone to think about in the context of relapse disease is pomalidomide-based salvage therapy. And again, we know that PomDex has an overall response rate of about 30%, that median PFS is somewhere around 4 to 5 months with a median overall survival of about 12 months. Now, remember that many of these trials using PomDex as a control arm or using PomDex in partnership with something else did so in second relapse or later, because the indication for pomalidomide in Europe is later disease. In the US, we've been using POM earlier in first relapse because patients are progressing on lenalidomide. And so when you look at the PFS, particularly this will come up with PomDara, you have to recognize that it's a later line of therapy population, and that's why the PFS may in fact be ultimately shorter. There are certainly combinations of Dara-PomDex, we'll talk about that, CAR-PomDex, bortezomib-PomDex, Ixa-PomDex, and again, Elo-PomDex. And we'll talk about each of those in the coming moments. Now, this is data from our group, actually published almost 5 years ago now, looking at POM-Dara-Dex in first relapse. And cohort 1 was a group of patients who were POM and Dara naive. And what you'll see here is that median progression-free survival has not been reached yet with a median follow-up of about 41 months. Now, this was a relatively small data set, but certainly suggests that this can be a quite effective regimen, even in the context of lenalidomide resistance, when patients all in this cohort had had a median number of lines of 1. So this, again, was very early relapse disease. Now, the MM014 trial is a data set presented by Dr. Siegel and colleagues that looked at Dara-PomDex, again, in len and bortezomib-resistant patients. These were 1 to 2 prior lines of therapy. So again, earlier lines of therapy. And what you'll see here is that the median PFS is much longer than 1 year. In fact, it's probably closer to 18 to 24 months and did exclude prior treatment with POM or DARA. So again, this to me suggests that this is a very active regimen and can be quite effective in an early relapse patient population. Now, this year at ASH, we saw data from Dr. Dimopoulos in a randomized phase 3 trial of DARA POM-DEX versus POM-DEX. Again, median number of prior lines was 2 to 3, so a much later population of patients than what I just showed you on the previous 2 slides. And yes, the triplet is better than the doublet. Median PFS was about 12 months, which is shorter than what I showed you before, but again, likely relates to the fact that it's a later line patient population. And so even though they are both POM and DARA naive, they're still heavily pretreated, relatively speaking, and have acquired mutations and other genetic abnormalities as a consequence of 1 or 2 prior lines of therapy prior to study entry. Now, what about looking at other agents that combined with daratumumab? This is the CANDOR trial, which led to carfilzomib, DARA-DEX, or KDD versus KD. Remember, this is carfilzomib at 56 milligrams per meter squared, given twice a week. So this is not a once-a-week dosing schedule, and it's a much more it's a higher dose of carfilzomib, which it can be quite effective, more effective than CAR at the lower doses, and more effective than bortezomib at the lower doses as well. Does not have neuropathy, does have a slightly higher incidence of cardiopulmonary toxicity, but can be partnered perhaps with monoclonal antibodies because there isn't overlapping toxicity. And what you'll see here again is a significant improvement in progression-free survival, favoring the triplet of CAR, DARA, DEX over carfilzomib and dexamethasone. Now, if we continue down this road of other POM-based combinations, ESA POM-DEX or IPD becomes another one. This was a randomized phase 3 trial, again, in later lines of therapy. And what you'll see here is that IPD has a median PFS of 11.5 months, basically the same as what I showed you from the Apollo study, but again, later lines of therapy, which I think explains why the PFS is shorter than what we see when we use an IMiD plus an anti-CD38 in the first relapse setting, particularly POM plus an anti-CD38 in first-line therapy, or first relapse therapy. Now, IKEMA is looking at isatuximab plus CAR-DEX. So again, CAR at 56 twice a week with ISA versus CAR-DEX. And again, what you see here, better overall response rate, better MRD negativity rate, better PFS overall. And in fact, the toxicity, again, was similar to what I showed you with CANDOR, in that at the higher dose of carfilzomib, you do get a little bit more of the cardiopulmonary issues with carfilzomib. Infusion reactions are really minimal with ISA and DARA when you use them in the IV with pre-meds. And with DARA now giving sub-Q, this is much less of an issue as well. And again, here is the IKEMA study in terms of progression-free survival, 19.5 months versus not reached, with a median follow-up of about 24 months overall. So again, these suggest to me that the triplets of a CD38 plus either a PI or a CD38 plus an IMiD are incredibly active. And one of the questions that comes up is ISA really different from DARA? And in my mind, they are not. They are basically the same antibody. They may have slightly different binding epitopes, but functionally they're the same. The real advantage for DARA is that it's sub-Q. And so if sub-Q DARA is not accessible for you, then ISA or DARA, I think, are relatively similar in terms of adverse events, in terms of combinability, and in terms of response rates and PFS. What about ELO POM-DEX? This to me is certainly an interesting regimen to consider, particularly in patients who have progressed on DARA-LenDex. ELO POM-DEX certainly is a reasonable thing to consider. And again, in a later relapse therapy, median PFS is 10 months, more than double what you saw with pomalidomide and dexamethasone alone. So again, I find this to be a very effective and important treatment regimen for patients in the context of relapsed and refractory multiple myeloma, and is a nice partner with an IMiD. And as you all know, we certainly have drugs coming down the pike like iberdomide or CC-92480. Those may partner nicely with elotuzumab as well. Those studies are being done at this time, again, to bring back an antibody that we think can have efficacy, just not by itself, likely needs to be partnered with an effective immunomodulatory drug overall. Now, the newest in the phase 3 trials for early relapse is the Boston trial, and this is selinexor bortezomib dex versus bortezomib dex. Again, 1 to 3 prior lines of therapy. What you'll see here, selinexor has a median PFS of about 13 months compared to bortezomib dex, which is about 9.5 months, a hazard ratio of about 0.7. One of the things that is often highlighted here in terms of the whisker plot is the fact that high-risk patients did seem to gain some benefit, relatively small subset of this trial, but certainly is something to think about. And again, if you've not had a PI before, clearly you got benefit from using a PI in the context of 1 to 3 prior lines of therapy. So this certainly is another new approach to use in the context of relapse disease in this situation. Now, I want to switch gears for just a moment to talk a little bit about the new target, which I think is the first evidence of precision medicine in myeloma, and that's targeting BCL2. And I would argue this is really most important in the 11-14 subset of patients overall. And if you look at the 11-14 subset of patients, what you'll see is single agent venetoclax has a response rate of about 40%. When you begin to add dexamethasone to that, the response rate jumps to 60%, somewhere between 50 and 60%, suggesting again that dex plus ven is synergistic, more so perhaps than even the PIs plus venetoclax. And more importantly, that this can be a very effective combination in the 11-14 subset. Now, I will tell you that I think that this phase 3 trial made a mistake. When the Bellini trial was originally designed, it took all patients, 11-14 positive or 11-14 negative, and it randomized them to venetoclax plus bortezomib dex or placebo plus venetoclax dex. And what I want you to see is the bottom line, which is really the top line data that caused the FDA to be concerned. And what it showed was that the PFS clearly better with the addition of venetoclax, but the overall survival was actually worse with the addition of venetoclax. And the reason is the non-11-14 patients, particularly the high-risk cohort of patients, may have gained less benefit from the addition of venetoclax. Now, if you flip it and look at only the 11-14 subsets here, what you'll see is big benefit in PFS and big benefit in overall survival as well. And this to me is really important because what it speaks to, in my mind, is the idea that these are highly effective therapies, specifically in the 11-14 or BCL2 high patient population. BCL2 high is a little complicated. I don't even use that, to be honest with you. I really focus on the 11-14. And more recently, one of my colleagues, Vikas Gupta from Emory, actually just published a paper in Blood using a flow cytometry-based scoring system to identify which patients, irrespective of 11-14, may be sensitive to venetoclax. And he tested things like CD20, CD38, CD56, and he created a scoring system by flow cytometry that you can use to risk assess or to risk stratify the benefit of venetoclax-based therapy. And I would encourage you all to look at this paper. It's really an interesting paper that really talks about biology, but actually came up with a coherent and focused scoring system using flow cytometry, which I think we all do, to predict which patients are going to be most sensitive to venetoclax-based therapy. Now, I'm going to wrap up giving you a key into the future, and I'm sure there are other talks during this session talking about future directions in immunotherapy. BCMA, to me, is the next big frontier, and sequencing BCMA with CD38, SLAMF7, and other targets, I think, is going to be really important. We know there are BCMA-directed CAR T cells. We know there are BCMA-directed antibody-drug conjugates, BiTEs, and bispecific antibodies. And so figuring out how to put these together is, I think, the challenge for us in the next 2 to 3 years. And we know, for instance, that the bispecifics are very active, particularly high overall response rates, lower CRS rates than we see with CAR T cells, but certainly the dosing and the efficacy and the PFS is really going to be the big question. And we don't have enough data and enough follow-up to really understand that. Now, hot on the heels of the bispecifics, or actually earlier than the bispecifics, we now have CAR T cells. And the biggest challenge we struggle with CAR T cells is not the overall response rate, which you can see here is quite high across the board. What we struggle with is not even CRS, which while the numbers here look quite high, in reality, the grade 3, grade 4 numbers are actually quite low. Neurotox also relatively low for grade 3, grade 4. What we struggle with is persistence. that the half-life of the CAR T cells in patients with myeloma is not long enough for us to get long-term cures. And again, you can see here the median PFS is around a year for ide-cel. This is the one that was just approved by the FDA. And this to me really speaks to questions about, is it better earlier in therapy? And we're testing that now. We'll know the answer to that in the next year. And two, are there strategies we can take to improve persistence or build on the benefit with a CAR so that you don't get that quick CR, quick MRD negativity, and then 6 months later they've relapsed? That to me is the real challenge with CAR T cells. And we just need more data, more follow-up, and honestly, more patients enrolled on the trials to really understand how to put all of that together. So when I think about conclusions, the management of relapsed myeloma is both sequential, meaning you have to pick your drugs and your targets, and combinatorial. Combination therapy is what's gotten us where we are in myeloma. And one of my colleagues actually just sent an editorial that we had published about 10 years in JCO called The Era of Combination Therapy in Myeloma. And I'd like to say we were prescient in terms of predicting what was going to happen. I think we were sort of riding the wave of combination therapy, but that editorial really was quite timely back then, and I think predicted much of what we're seeing in our combination approaches now. Optimal approaches include the use of anti-CD38 antibodies early on with another partner. Our center likes to use that with an IMiD because we think the IMiD antibody partnership is synergistic. PIs can be very effective with anti-CD38. I think they're additive, and we don't really have head-to-head data yet, although hopefully soon we'll have a trial of DARA plus POM versus DARA plus CAR in first or second relapse myeloma to understand which of the two partners is really better. And then again, the future will include combinations of BCMA, whether they become quadruplets or quintuplets in treatment, or we use sequential therapy. Those are all questions we're going to have to answer in the future, and we don't know the answer to at this time point. So again, with that, I will thank you for your attention and hope you have a wonderful meeting. And my email is listed here. Please feel free to email if there are additional questions that come up as well. Thank you so much.
Thank you, Dr. Sagar, for that very nice talk and getting us into a contemporary status of sequential therapy and the use of novel agents. And I'm told you're not available for taking questions, but you've been generous enough to give your email for anybody who has questions to directly ask you them. Also, there are no questions on the chat box. I mean, we are on time, so I'll just like to wind up by saying that the selection, sequencing of drugs available and the novel agents is becoming complex with increasing options, and it includes monoclonal antibodies. And the choice of treatment, as has been brought out, depends on patient factors, tumor features, and obviously, you know, the type of therapy, whether it's combinational or sequential, and the toxicities thereof. You have to take all this into consideration. And what's also very important is how studies are designed. He just told us how important the control arm was. You know, Lendex versus a botsum dexamethasone. So really speaking, I think, you know, it's very important when we even interpret certain papers, and some of the old wine in new bottles are equally important, like he said, starting from editorials and predictions. So I think the new kids on the block, which are really interesting, available in our country, is venetoclax and the BCL2 and the translocation 1114, what you talked about, because we obviously have a little catching up on doing what is approved and available in our market, and the cost, and obviously the access and the availability. So with that, I think I will hand over the stage to my co-chair, Dr. Subhash, for the last and final talk of this lovely plenary session. And if Dr. Sonia has any comments to add, Dr. Sonia, please do before we go on to the next talk.
It was a very nice talk, and we are deeply grateful to you for giving this talk. He's not available for the questions, so I think we can move on to the next lecture. which is by Dr. Maury Getz. So Dr. Nair?
The next talk is on, yeah, then, okay. So Dr. Maury
Hello,
Gertz, welcome.
I'm Maury Gertz. I'm professor of hematology at the Mayo Clinic, and I'm honored to address you today on the diagnosis and evaluation of macroglobulinemia of Waldenstrom. These are my conflicts of interest. These are the defining characteristics of macroglobulinemia. In A, you can see a retinal photograph showing hyperviscosity, retinal tortuosity, retinal hemorrhages. In B, you can see a simple serum protein electrophoresis with a very large gamma spike on the right-hand side of the panel, greater than albumin. In C, you can see the immunofixation electrophoresis showing that there is an IgM and kappa dense band that co-migrates with the monoclonal protein on the serum protein electrophoresis. You can see IgG is polyclonal, IgA is reduced. And finally, morphologically in the bone marrow in D, you can see the bone marrow cells, and these are not plasma cells with eccentric cytoplasm and a perinuclear clear zone, but we're actually looking here at lymphoplasmacytic cells, not small lymphocytes, not plasma cells, but morphologically lymphoplasmacytic lymphoma. So Waldenstrom's macroglobulinemia is a rare form of lymphoma. It's only 2% of all non-Hodgkin's lymphoma. It's much more common in men than women. The age-adjusted incidence rates for men is less than 1 per 100,000 person years. For females, 0.3 per 100,000 person years. But keep in mind that the prevalence of an IgM-MGUS at the age of 70 is 0.5%, 1 in 200 adults. And that's based on the fact that 3% of adults have a monoclonal protein. In addition to the monoclonal protein, 1 in 6 will be an IgM protein. Smoldering Waldenstroms represents 28% of patients diagnosed. So it's important when you see a newly diagnosed patient to ask whether they really need therapy, whether they have symptoms to justify therapeutic intervention. And it's a disorder that actually is not of young people. The median age at diagnosis is 71 years. The defining mutation of macroglobulinemia is the MYD88 mutation. This slide demonstrates the rate of progression of smoldering asymptomatic Waldenstroms into active. And you can see that the MYD88 mutation or wild type does not predict progression to symptomatic macroglobulinemia and cannot be used as a determinant as to whether patients are being treated or not. When we see patients with macroglobulinemia, they divide into 4 categories. There are those patients who have an IgM MUGUS, which have a monoclonal protein, but everything else is negative, no symptoms, no marrow infiltration. Smoldering Waldenstroms has an IgM monoclonal protein, 10% lymphoplasmacytic lymphoma in the marrow, but no symptoms. Symptomatic Waldenstroms are patients who have symptoms due to infiltration of liver, spleen, nodes, and marrow. They develop cytopenias, and they can develop bulky lymphadenopathy. The important thing to remember is there are patients who don't fulfill criteria for Waldenstroms, but have disorders related to the IgM monoclonal protein. If the IgM monoclonal protein misfolds, you get amyloidosis. If the IgM monoclonal protein binds to polyclonal IgG, you get a type 2 mixed cryoglobulin. And if the monoclonal protein fixes complement to the red cell surface, you get cold agglutinin disease. And finally, if the IgM binds to peripheral nerve myelin, you get MUGUS with peripheral neuropathy. So there are a number of paraneoplastic manifestations of IgM monoclonal gammopathies, and those paraneoplastic manifestations are not actually Waldenstroms, but are complications due to the IgM monoclonal protein alone. As I mentioned, the MYD88 mutation is the defining mutation of Waldenstrom, but please note that it will not distinguish Waldenstrom from IgM MGUS. So having MYD88 is simply a marker of the lymphoplasmacytic lymphoma, but not a marker of symptomatic activity, and again, does not direct us to whether these patients need treatment. That decision remains based on clinical grounds. How does MYD88 impact outcomes? Well, in a number of ways, it does. When we looked at a large number of patients who were mutated MYD88, there were a group of smoldering patients, a group of wild-type patients. These patients were treated with bendamustine and cyclophosphamide-based therapy. So these impacts do not reflect ibrutinib treatment. But what we found with cyclophosphamide and bendamustine-based therapies is that the mutational status of M88 had no impact on overall survival or time to next therapy, and that really were very few differences in the clinical features. One thing we did notice is that if you have a wild type MYD88, you have a higher risk of transforming to intermediate or high-grade lymphoma, so-called Richter's syndrome. And you also have a higher risk of developing a secondary myeloid neoplasm from therapy, MDS or acute leukemia. We know that MYD88 status is a predictor for response in patients who receive ibrutinib or zanubrutinib or acalabrutinib, but it does not appear to predict outcomes in patients treated with cyclophosphamide or bendamustine. And here are the graphs to support that. You can see that survival status with those therapies are independent of MYD88 status, and it doesn't really matter how you segregate these patients. If you're wild type or mutant cyclophosphamide or bendamustine, no survival difference. But as I had mentioned, the risk of transformation to large cell lymphoma is greater with MYD88 wild type. In fact, if you look at the 5-year transformation rate of Waldenstrom to large cell lymphoma, it was 16% in patients who were MYD88 wild type and just about 3% in those patients who were mutated. So the risk ratio was 9.8. And so one patient that's wild type needs to be monitored more carefully for the possibility of a Richter's transformation, and the median time to transformation is 4.5 years. This is the staging system for Waldenstrom. It's based on 5 factors. Age being the most important, it counts for 2 points in this system. If you're over 65, you cannot be low risk. It also depends on anemia, thrombocytopenia, the beta-2 microglobulin, which is an important measure. Monoclonal IgM does impact prognosis, but only if it's greater than 7 grams. Otherwise, it has no impact on outcome. Please note that this staging system does not include LDH, but it has been demonstrated that in the high-risk category, LDH, normal or abnormal, can distinguish between an ultra-high risk and a standard high-risk patient. But when you see a patient, the important things to know are the hemoglobin, platelet count, beta-2 microglobulin, and IgM level. We do know that the goals of response depth in Waldenstrom's are not like multiple myeloma. In multiple myeloma, it's very clear that MRD negativity, stringent complete responses, and complete responses do better than patients who have very good partial responses or partial responses. But in macroglobulinemia, we can't demonstrate that. We can't unequivocally show that response depth predicts survival. So patients who achieve a PR can do actually quite well and may not need any second-line therapy to deepen their response. When we looked at 119 patients, 72 of whom died, median age 70 and median hemoglobin 9.4, that progression-free survival and time to next treatment did predict overall survival. But although progression-free survival translates to overall survival, response depth, including minor response, did not predict overall survival. So if you have a patient who has an IgM protein of 7,000 and it goes to 4,000, which is less than a PR, but their adenopathy resolved or their hemoglobin rose from 9 to 13 grams, that may be a sufficient response, and no further second-line therapy may be indicated because the response depth, very minor, can still predict very good outcomes in this disease. Viscosity is a unique aspect of macroglobulinemia. Patients can have a measured elevation in viscosity and have no symptoms, in which case therapy isn't required. We've seen many patients with an IgM over 6,000 who are asymptomatic who can continue to be observed if they have no other symptoms demanding therapy. In addition, the level of IgM is a poor predictor of viscosity. We've seen hyperviscosity with levels as low as 3,500, and we've had patients with 8,000 IgMs with no hyperviscosity. The one thing that predicts hyperviscosity symptoms is the viscosity level at diagnosis, not the IgM level. The IgM level cannot be used to gauge whether a patient will require therapeutic intervention. At the time of diagnosis of Waldenstrom's, if there is an elevated viscosity level, it does predict eventual symptomatic hyperviscosity, but it has no impact at all on survival. When we talk about the kidney in Waldenstrom's, that's a unique subset. Kidney involvement is seen in 5% of patients with Waldenstrom's. The most common renal syndromes are amyloidosis, so it's amyloidosis with an IgM monoclonal protein depositing as amyloid, and cryoglobulinemia. Those two entities account for over half of the involvement of the kidney in Waldenstrom's. Direct infiltration of the kidney with lymphoplasmacytic lymphoma is very, very uncommon. The patients who do have Waldenstrom of the kidney present with pretty nonspecific features: proteinuria, hypertension, fluid retention, active urinary sediment. Just a couple of points regarding rituximab. It's important that if rituximab is used as a single agent in a Mogus neuropathy patient or a cold agglutinin patient, there is a risk that the use of rituximab will result in a spike in the IgM level, where you can see here patients whose IgM went from 5,000 to 8,000, 4,000 to 8,000, and the use of rituximab as a single agent can precipitate symptomatic hyperviscosity, and that rise in IgM is not a manifestation of progressive disease. It's simply a flare, and as you can see at time point 2, the viscosity level tends to drop back to baseline. So a viscosity rise after rituximab therapy, be aware, but it doesn't necessarily mean treatment's not working. So now we'll talk the rest of the time about the treatments available for macroglobulinemia. The preferred treatment for macroglobulinemia newly diagnosed at Mayo Clinic is bendamustine, and that's based on this trial. This trial that was published by the East German Lymphoma Study Group had 41 patients with Waldenstrom's, of whom 22 received bendamustine and rituximab, and in this phase 3 trial, 19 received R-CHOP. In both groups, the response rate was 95%. So newly diagnosed Waldenstrom, response rate to bendamustine, 95%. And the median progression-free survival for R-CHOP was 36 months, was far superior with bendamustine. So it's clearly better than R-CHOP or CVP. At the time they reported this trial, there were 4 relapses in the R-CHOP group, 18% in the bendamustine group, and 58% in the R-CHOP group, clearly superior for bendamustine. And when you look at the progression-free and the overall survival between the bendamustine and R-CHOP group, you can see that the hazard function for progression-free survival is 0.33, favoring bendamustine. No obvious survival benefit, but in addition to progression-free survival, the patients in bendamustine had a better quality of life, less alopecia, less nausea, vomiting. This is just a little slide about how long responses last until new therapy is required, comparing bendamustine with cyclophosphamide and rituximab. And you can see in treatment-naive patients, the duration of response is much longer in bendamustine patients. In patients with relapsed disease, bendamustine appeared slightly superior. There was a trend, but it did not reach statistical significance. In terms of time to next treatment, we could not demonstrate any differences between bendamustine and cyclophosphamide. But remember, progression-free survival is longer with bendamustine. A common question that comes up is rituximab maintenance, and the MAINTAIN trial was reported at ASH in 2019. Patients with Waldenstrom who were all treated with rituximab and bendamustine. First, note that the progression-free survival with rituximab and bendamustine was 78 months. 218 patients were randomized to rituximab maintenance for 2 years or no maintenance observation. The 5-year survival in both groups was 78%. Therapy-related myeloid neoplasm was seen in 2 of the 218 patients for 0.7%. Progression-free survival between rituximab maintenance and no rituximab, not statistically significant. And based on this trial, Mayo Clinic does not recommend rituximab maintenance for macroglobulinemia. Proteasome inhibitors are powerful agents in the management of macroglobulinemia. And here's a list of trials that looked at bortezomib-based therapy, starting with bortezomib rituximab, bortezomib dexamethasone rituximab, both by the Clinical Trials Group and the European Myeloma Network, a trial that looked at bortezomib, cyclophosphamide rituximab compared to FCR. As you know, that fludarabine cyclophosphamide was used at one time for CLL. And then there's one on carfilzomib rituximab dex, and then finally ixazomib rituximab dex. And you can see that all proteasome inhibitor-based therapies are highly active, with response rates of 85 to 98%. Remember, bendamustine was 95%. That the PR rate or better ranged from 66% to 91%. That progression-free survival was 43 months in one trial. It was 57% at 5 years. And overall survival at different time points based on the trial, at 1 year, 96%, 7 years, 66%. And so the use of proteasome inhibitors is a very valuable potential therapy for macroglobulinemia. This is the recently reported result on the use of ixazomib orally 4 milligrams weekly with rituximab and dexamethasone. The advantage here is that other than rituximab, you have an all-oral therapy for outpatient treatment of these patients. And you can see the aggregated results over a period of 6 cycles, followed by 6 months of monitoring. The IgM fell from a median of 5,000 to 1,000. Also important to note, and true of virtually all therapies for Waldenstrom's, at the end of treatment, the median IgM level was 2,300, but the IgM continued to fall for a full 6 months after therapy was discontinued, and so that the maximal response is not seen at the completion of therapy, and that when you stop treatment, you continue to observe patients, and for the next 6 to 12 months, they can have further decline. In B, you can see that the median hemoglobin rose. And again, the median hemoglobin at onset of study was 10 grams. And by the end of treatment, it had risen to 12 grams. But notice that in the 6 months after therapy was discontinued, hemoglobin further rose from 12 grams to 13 grams. So ixazomib, no question, has activity. Ofatumumab has been looked at as an alternative therapy to the use of rituximab in these patients. In this trial that was reported in Lancet Hematology, 16 weekly doses were given. The PR rate was 59%. 2 out of 22 had an IgM flare, but it was rather disappointing that the progression-free survival was only 536 days. So ofatumumab really is not a better alternative to rituximab for therapy of macroglobulinemia. And I will tell you that if you are allergic to rituximab, ofatumumab also wasn't a valuable crossover drug because ofatumumab also caused allergic reactions. Let's look at BTK inhibitors. First, ibrutinib for newly diagnosed myeloma. When this was first reported, 30 patients newly diagnosed, the major response rate was 80%. There was no difference between wild type or mutated CXCR4, but patients who had wild type MYD88 had a lower response rate. Notice the response rate of 80% and what we've previously mentioned for bendamustine and bortezomib. In a very important study on treatment-naive Waldenstrom was published in the New England Journal of Medicine. This is a prospective randomized study of ibrutinib, rituximab, and placebo rituximab. And what it demonstrated is that ibrutinib produced much deeper response with a partial response rate or better of 83% compared to placebo rituximab that had a much lower overall response rate as a best response. And notice the IgM depression, the levels in B were much lower. So the median IgM level for both groups was about 3.5 grams at the time of study entry. Patients receiving ibrutinib rituximab fell between 1 and 1.5 grams. Patients in the placebo rituximab fell to about 2 grams. So response is deeper. So this was a very important study establishing the role of rituximab ibrutinib. Unfortunately, there was no arm of ibrutinib alone, so it's difficult to say whether rituximab ibrutinib is superior to single-agent ibrutinib. There is one area where ibrutinib first-line therapy is mandatory, and that's in the Bing-Neal syndrome, so-called central nervous system infiltration with macroglobulinemia. Most of these are case reports and case series, but they definitely show that there is benefit using ibrutinib because it crosses the blood-brain barrier. Cyclophosphamide, bortezomib, bendamustine do not cross. And in this one trial that reported 7 patients, all improved their meningeal enhancement on magnetic resonance imaging, and cerebral spinal fluid protein, glucose, and cell count all improved. So for central nervous system disease, BTK inhibition is required. So just some tips on monitoring patients who are on BTK inhibitors for macroglobulinemia. 1, for the first 2 cycles, you have to watch for flare of the IgM monoclonal protein. With BTK inhibitors, 11% develop atrial fibrillation that needs to be monitored. Patients receiving proteasome inhibitors have a very high incidence of peripheral neuropathy, and monitoring for a proteasome inhibitor-induced painful neuropathy is important. All of these agents are myelosuppressive, and so monitoring the CBC on a regular basis to allow for dosage adjustment. Other issues with BTK inhibitors, they can cause skin rash, lower extremity edema, joint pain, bleeding without coagulation abnormalities, and pneumonitis. And all of these are BTK-associated problems. So if using ibrutinib or second-generation BTK, you need to watch for this. What about second generation? Acalabrutinib, which has been approved for the treatment of mantle cell lymphoma, was given the 14 treatment-naive macro, 22 relapsed macro, and a dose of 100 twice daily. Overall response rate, very impressive, 93%. No difference between the major response rate between treatment naive and relapsed refractory. Very few very good partial responses. Notice 2-year progression-free survival, 90% for treatment naive, 82% for relapse, and the overall survival at 2 years was 92% versus 89%. So not much difference in the endpoints of progression-free and overall survival. However, notice the adverse events: headache, diarrhea, easy bruising, dizziness, fatigue, and nausea were major problems with the use of acalabrutinib. When they finally reported this out in Lancet Hematology, however, the atrial fibrillation rate was only 1%. That compares with 11 or 12% with ibrutinib. And the adverse events leading to discontinuation of therapy was only 7%. So although acalabrutinib was not more efficacious, it was less toxic. Here you can see a comparison here between treatment naive and relapsed refractory, showing very similar outcomes with acalabrutinib therapy. Zanubrutinib has recently been approved by the US FDA for the treatment of macroglobulinemia based on this trial, ASPEN. And this was a head-to-head comparison of ibrutinib and zanubrutinib. The main differences between these two drugs were not efficacy, but actually were toxicity. Please notice that atrial fibrillation was seen in 7% of ibrutinib grade 3 and none with zanubrutinib. And when you looked at all grade atrial fibrillation, it was 18% versus 3%. In addition, diarrhea was much less frequent with zanubrutinib, 22% compared to 32% with ibrutinib. And so because of the lower toxicity profile associated with zanubrutinib, it was approved for use in macroglobulinemia. Here you can see some of the secondary efficacy endpoints. The CR and VGPR rate was slightly better for patients with zanubrutinib, although the major response rate was virtually identical between the two groups. The distinguishing feature was a higher VGPR rate with zanubrutinib, 28 versus 17%. And if you looked at CR plus VGPR, this achieved statistical significance as well, favoring zanubrutinib for very deep responses. Venetoclax is highly active in Waldenstrom macroglobulinemia. The ramp up is pretty typical, 200 to 400 to 800 milligrams, just as you use in leukemia. 30 patients were reported, 15 previously treated with BTK inhibitors. The overall response rate was 87% GPR. It was 7% in patients who had previously been exposed to BTK. It was 27% VGPR in those not exposed. And there was a lower response rate in CXCR mutated patients. Toxicity with venetoclax was pretty typical and minimal. Small numbers of patients with neutropenia, less than a quarter, and then 3% each, back pain, constipation, diarrhea. So venetoclax has high activity in the treatment of macroglobulinemia. With the last slides, I want to summarize Mayo Clinic MSMART recommendations for the treatment of macro. First, for newly diagnosed patients. If you have an IgM MUGUS or you have Waldenstrom's with no symptoms and you're not anemic and you don't have thrombocytopenia, you should be observed without treatment no matter what the IgM level is. Single agent rituximab is inferior for macroglobulinemia, but it can be used for the non-neoplastic, the paraneoplastic complications, including IgM neuropathy, cold agglutinin disease, and cryoglobulinemia. In those settings, a trial of single agent rituximab for those paraneoplastic findings is reasonable. But for patients who have true Waldenstrom's, anemic, thrombocytopenic, B symptoms, hyperviscosity, or bulky disease, the recommendation is bendamustine rituximab. 6 cycles and then observation, no therapy, median time to progression, 78 months. Patients who have symptomatic hyperviscosity, not just a number, but have symptoms, oronasal bleeding and the like, 1 or 2 plasma exchanges will suffice to allow bendamustine to work. If bendamustine is not available to you, rituximab cyclophosphamide dexamethasone can be considered in these patients. Waldenstrom's for salvage therapy, relapsed refractory, you take into consideration what the first therapy was. If a patient was treated and then observed, let's say they got bendamustine, and they relapse 7 years later, I would retreat that patient with the exact same induction if the relapse was greater than 3 years after prior therapy. However, if they relapse within 3 years, that would be a time if I had used bendamustine to use a BTK inhibitor. Zanubrutinib is approved and appears to have lower rates of atrial fibrillation and diarrhea. Ibrutinib is reasonable. Bortezomib can also be used as an alternative, as can cyclophosphamide, rituximab, dexamethasone. And if the patient has relapsed and not seen bendamustine, bendamustine can be used. I do want to point out that for patients with multi-line refractory, older agents such as fludarabine and cladribine can also be used in the management of macroglobulinemia. I want to thank you very much for your attention during this talk, and have a wonderful conference.
Thank you, Professor Maury Gertz, for an excellent and very clear, concise presentation on Waldenstrom's. I don't see many questions here. There is only one question, and that I think you. So, role of rituximab maintenance, that you actually told us in passing that there was no difference in people who were given rituximab maintenance versus those who were not. Would you like to take it up now?
So that's absolutely correct, Dr. Verma. Patients who received in the only randomized trial of maintenance therapy for this specific lymphoma did not demonstrate, and it was a very large, over 200 patients with macroglobulinemia and long follow-up and no benefit. So when we complete therapy, let's say 4 to 6 cycles of our bendamustine, we would not give rituximab maintenance. And there was one question about bortezomib versus bendamustine. And of course, they haven't been directly compared, but what I would say is that the incidence of neurotoxicity with bortezomib in patients with macroglobulinemia is quite a bit higher than it is in multiple myeloma. I think these Waldenstrom's patients who have a circulating IgM and are older tend to exhibit a greater prevalence of neurotoxicity. And because the neurotoxicity from bortezomib can be really quite profound, and these patients live a very, very long time, 10 and 15-year survivorship is increasingly common. I try to avoid upfront use of bortezomib because of my concern that they'll have long-term painful peripheral neuropathy. And bendamustine, other than the myelosuppression, is really a pretty easy agent to use.
Yeah. Dr. Subhash, can I ask questions whenever you
Sure.
allow? Can I ask?
Sure, please go ahead.
Yeah.
Sure.
Dr. Gertz, this is Jalal Nair. Thank you for a wonderful talk. I have a few questions and 1 or 2 comments. The question is, as you correctly said, that once we give the treatment, then we observe for a recurrence or a relapse before we again intervene with the treatment, either before 3 years or after 3 years. My question is, what do you monitor in an asymptomatic patient, and what timelines do you follow for monitoring this clinically and laboratorily?
That's a wonderful and a very important question. The reason it's important is that relapses in macroglobulinemia tend to be very slow and very indolent. So a simple rise in the IgM is insufficient to reinstitute therapy. We really need to see recurrent symptoms. So typically, if a patient was treated because of progressive anemia and their IgM fell a certain amount, and they begin then 3 years, 4 years, 5 years later, the IgM is rising, but the hemoglobin is stable, I'm not retreating them. It's only when I see the original symptom, whether that was hyperviscosity or anemia, begin to recur, that I will really begin to intervene, because the velocity of relapse in most patients is very slow and very linear. And so if they're not anemic and their hemoglobin's 13 grams or 12 grams, I'll let them develop a little more anemia before I will reinstitute therapy. I don't think it's justified in such an indolent disorder to reinstitute therapy on biochemical relapse alone, which is commonly done for multiple myeloma. But the tempo of disease and the adverse genetics of myeloma are very different. So the same principles do not apply. My patients need symptoms to warrant reinduction therapy.
Thank you. The next quick question is, when you use a single agent rituximab in paraneoplastics, syndromes like peripheral neuropathy, what is the frequency of an IgM flare?
So the IgM flares occur about 20%, but the reality is patients with IgM and peripheral neuropathy have very low IgMs to begin with. You don't get Muggis neuropathy dads or with IgM with levels of 4,000 or 5,000. These patients have levels of IgM of 600, 800, 1,500. So even if they flare and the IgM doubles to 1,500 or 2,500, it's clinically unimportant, and it would be really, really rare to require plasma exchange for a flare in these paraneoplastic, because their IgMs in the amyloids, in the cold agglutinin, in the cryo, they're very low IgM levels. So a rise is not causing a change in the viscosity of the serum.
Thank you. And the next question is on the study published in NEJM on ibrutinib rituximab versus placebo rituximab. I thought that was a very poor comparison. You said, okay, you could add a single agent ibrutinib as a third arm, but the standard that we've been doing is, for example, at least a bendamustine rituximab comparison. So to have a placebo ritux versus a ibrutinib rituximab, I don't know how robust that is as a control arm.
So that's quite insightful. And of course, the real issue is who initiated the trial. And this, of course, is a trial initiated by the pharmaceutical company whose primary goal is drug approval.
Yes.
And
yes.
So what you do is you compare it to a very weak comparator, which is single agent rituximab, which is virtually inferior in everything. In the CLL trials, there were trials, what did they compare to? Chlorambucil. Well, yeah. If you want to get a drug approved, find a very, very weak but legitimate control arm. So you're quite correct. It was a very poor choice.
Yeah. My last question is, the overall survival, in one of your slides, you showed 66% at 5 years. Now we know that the median age of these patients is very high, 7 decades and plus. How many of these were due to comorbidities and how many of them were purely due to WM?
So this has certainly been looked at, and believe it or not, 50% of the mortality in macroglobulinemia is unrelated to the underlying macroglobulinemia. These patients die of second primary malignancies, stroke, myocardial disorders, and heart failure. And so only half of the patients diagnosed with macroglobulinemia succumb to macroglobulinemia. And that's why the choices of therapy become so important, because toxicity of therapy becomes a big deal since half the patients aren't going to die of the disease. So disorders that result in peripheral neuropathy would not be my preference. Agents that require continuous indefinite administration where you can never stop the drug also would not be my choice. It's another reason why I like drugs like bendamustine or cyclophosphamide, because the therapy is finite, you can stop it, you get 5-6 years, you can reuse it.
Dr. Subhash, I think we are okay for time. If I can just squeeze in one last quick question. Dr. George, since you are an authority in this field, I have a lady who's 70 years old, who's actually, was diagnosed in Boston in the US, but she was asymptomatic, she was not treated. She came to us and she became symptomatic with anemia and other symptoms. And we ultimately treated her with a BR regimen and gave her the complete, course of cycles. She remitted and was very comfortable for nearly a year. After a year, she started having diarrhea, profuse diarrhea, 15 to 20 times. So we obviously thought about, amyloid or any, autonomic neuropathy and infective causes. We looked at everything, we found nothing. We biopsied her both upper and lower, and we actually found an eosinophilic infiltration right through her gut. And we gave her, budesonide orally and systemic steroids, to which she has responded. But whenever we try to taper off the steroids, she goes back into a relapse of the GI symptoms. her Waldenstrom's is very much under control even now. I don't know if you have ever seen such a case, because I haven't come across many such reports.
So the eosinophilic material you saw, was that collagenous colitis or was that Congo red positive?
Congo red negative.
Okay. Well, you know, in these types of patients with no defined cause of the diarrhea, if the patient doesn't have gluten enteropathy, I do tend to focus on symptomatic therapy. And for patients with this severe diarrhea, in my practice, I use a fair amount of tincture of opium to try and really slow down the bowel, and try to use things like budesonide, because obviously you can't keep people on systemic corticosteroids indefinitely related to the morbidity.
True. Thank you so much. Thank you so much for your patience and answering all my questions.
Well,
Thank you.
it's been a delight. I was very honored to be invited to speak at the conference. Hopefully I can do it another time in person.
Thank you, Professor Gertz. It was really a pleasure listening to you. And we hope that we'll meet some other time, maybe face to face. Bye.
Thank you so much. I will be signing off then.
Okay. Bye-bye.
Have a wonderful conference.
Okay. Good night.
Bye-bye now.
Yeah. Do we have the organizers, or can we stop now?
Yeah. Good evening, sir. Sorry. Yes, sir. So we come to an end to this day 2 of our conference. And now we'll tomorrow meet at 11 a.m. in the morning for the final day of the Indian Myeloma Congress. And we have some exciting talks by our speakers. And we hope all the delegates as well as the faculty to join tomorrow. We understand that you are all busy during this COVID pandemic, but hope for meeting tomorrow. Good night.
Good night.
Thank you, Anshul. Thank you, Dr. Subhash.
Okay. Thank you, Dr. Velu. Bye-bye.
Thank you. Thank you very much. Thank you, Dr. Sonia.
Thank you.
Good night.